Morning, friends, and I'd like to extend a warm welcome to all of you seated here and those online to the Pediatric Symposium 4.0. Okay, I'll just take a step back prior to the start of Pediatric Symposiums here. In September last year, we had our first Pediatric Symposium, and that was primarily a follow-up from our interactions with Mayo Clinic. So we've had 3 such faculty come to us. The first one being a pediatric endocrinologist, then we had a pediatric cardiologist, and then we finally had a pediatric adolescent medicine specialist who came from Mayo. And we had sort of come to a point where we said, okay, this is enough for the year for pediatrics. But the Department of Pediatrics, with their showing their enterprise, partnered with Indian Association of Pediatrics, which is a fairly robust association in India, and have been partnering primarily through Vanita here to run this a series of online meetings. This is a one-off in person, but I guess the ongoing education will take place on the online platform. And having said that, I'd like to welcome each of you, especially our guests who are here, Dr. Baswaraj, Dr. Yogesh, and also I think the first person who we met online was actually him, Dr. Ranjan Kumar Pejawar, when we discussed the options of a partnership between between AMH and IAP, which is what the fruit of that is what you're seeing today. And without much ado, I'd like to wish you all a blessed day, a day where learning takes place. And I'll just leave with a thought and a word, which is always something which is close to my heart, and that is ongoing learning, right? And ongoing learning is something which will always help us stand in good stead. And the ongoing learning can happen in any form. It can happen from any person. It can happen from your children, from your family, or a more formal learning process. And I'll share with my own experience with learning, which I am going through right now in this doing a Harvard course, and it's not easy. But you know what? You need to stretch yourself. It's only in stretching yourself and pushing boundaries would you be able to scale new heights. And with that, I wish this pediatric symposium the very best. And my only prayer for you is that learning happens, learning is beneficial, it's applicable in the workspace, and you will utilize this to become a better physician. And the ultimate beneficiary of all of learning is that the patient has a better deal. Thank you and have a good day. Yeah.
Thank you, Dr. Deepak, for those encouraging words. Now we will get started with the activities of today. I invite Dr. Basaraj to give some opening comments before we get started with the CME. Dr. Basaraj is the IAP president. He was part of championing the cause of this IAP-AMH collaboration. We would like to hear from you before we get started. Dr. Basaraj, can you please come over to the stage?
Good morning. At the outset, let me congratulate AMH, especially Dr. Judge, Cherian, Deepak,
and Dr. Vanita for making a collaborative effort to have this pediatric CME. We had a one in the month of October. This is the inaugural CME which has been occurred. So I bring in a greetings from 48,000 pediatricians of India. This is Indian Academy of Pediatrics is one of the second largest professional pediatric organization in the world, next to the American Academy of Pediatrics, with 374 city branches, with 31 district branches, with the super specialties of pediatrics is in an almost, we are in a transition stage where a lot of super specialties has come up in India. This is we had a MOU with the great effort of our International Licensing Committee convener, Professor Ranjan Pejawar, who has been very instrumental with coordinating with that, well supported by Professor Yogesh Parikh, our Honorary Secretary General. So good to see the lot of academic things started, not only in Bahrain and other parts of the world where the Indian Academy of Pediatrics is actively spreading the academic activities to make the whole world as in a quality care of in children, where the learning, what Dr. Deepak said is absolutely, we need to learn from each other some of the things we can and some of the things you can. So it is a mutually learning and taking the academics to the greater heights. In that, and AMH, which has a long history, which has been in within a forefront in academic activities. I'm sure this is in the CME, physical CME, and much more things is going to come in the near future. With this favor, the best wishes for the today's program. So where the lot of other things can be planned depending upon the need of what really the Indian context which is required, what is required in the Bahrain, so that at the end of the day, the quality of a child care is the need of the hour. With these few words, best wishes for the today's program. Thank you very much, Dr. Vanita, once again for this wonderful one.
That was Dr. Basaraj, IAP president. Now we embark on the exciting journey of CME activities. I'll hand over the mic to Dr. Sana, who will be your MC today. And the first activity would be sessions covering neonatology. And Dr. Athar and Dr. Jamila would be the moderators of the session. I invite Dr. Sana to officially start the CME activities, and a warm welcome again to one and all. Let's get started with the activities. Thank you.
Thank you and good morning, everyone. Welcome to the Pediatric Symposium 4.0. I think we're going to get fuller. I know there's been a lot of traffic on the roads today, so thank you for all of you who've joined us today. Our opening lecture will be by Dr. Ranjan Pejawar. Dr. Ranjan is professor of neonatology, and he's a chief neonatologist in Meenakshi Hospital in Bangalore, India, with over 40 years of teaching experience for everyone. So undergraduates, postgraduates, nursing graduates, and fellows in both India, England, and the Middle East. He's participated in 34 major research projects with 172 scientific papers published in various national and international journals, with numerous presentations in national and international scientific meetings as well. He's also the author of 22 books on neonatology and pediatrics, with several contributions to other textbooks as well. He is the editor-in-chief of the Indexed International Journal for Neonatology and editor-in-chief of the Nursing Digest, the quarterly journal, and member of editorial boards of the Journal of Perinatal Medicine from 2012 onwards, and the Journal of Maternal, Fetal, and Neonatal Medicine. He has also won the prestigious award of the Networked India CNN IBN National Award for the Best Innovation in 2015. Dr. Ranjan will be speaking on two topics today, the first of which will be antenatal antibiotics, the good, the bad, and the ugly. So we can invite Dr. Ranjan on stage, please.
Sabah al-Khair. Good morning. Salam alaikum. Now, please call me Ranjan. I am the a neonatologist in Bangalore, which is called the Silicon Valley of India. Thank you for inviting us and giving us an opportunity to be here and share some of our views about some of the aspects of the vast specialty of pediatrics and neonatology. I fully agree with Dr. Deepak when he said that our education continues. I always tell my students, the day you feel that you know everything or you have learned everything is the day you start decaying. So continued medical education should continue, and I'm glad American Mission Hospital has embarked on this noble task of continuing the education in pediatrics in the Kingdom of Bahrain and neighboring countries. I'm glad you are liaising with Harvard, which is one side of the West, and India, which is in the East, and making it a balanced collaboration. Thank you very much. Now, I am going to speak on the antenatal antibiotic usage, a topic which is seldom discussed. How many of you have seen the movie? How many of you have seen the movie, The Good, the Bad, and the Ugly? Yeah, I can actually roughly work out the age of the people who have raised their hands. It is an iconic movie of the Western category of movies. That is when the cowboys were ruling the Western part of USA. Where do we? I'll operate that. I know that. Yeah, yeah. This one, yeah. So no, I want the previous one video to work. Enter. This is one of the all-time hits. As the ugly here. This was how US was in the late 19th century and early 20th. And they were actually looking for gold in that area. So with the thanks to Indian Academy of Pediatrics, who have allowed me to coordinate the international activities and come here and talk to you all. As it is written here, Indian Academy of Pediatrics, The Good, the Bad, and the Ugly, directed by Dr. Ranjan Kumar Pejawar. The movie starts here. Antibiotics are one of the most important medical innovations. Saves lives when used appropriately, but inappropriate use leads to potentially untreatable resistant infections and long-term health problems in children and adults. So it's a double-edged sword. A recent assessment predicted that without restrictions, if you go on using antibiotics, the global antibiotic use will increase threefold by 2030, which is not very far away. So we have to be cautious. Unless we all work together to reduce antibiotic overuse, we could be assigning our children to a future of chronic illness. Current estimates suggest that more than 60% of the pregnant women at some stage of their pregnancy receive antibiotics. Intrapartum or early use of antibiotics in the antenatal period, too much use of antibiotics, and too early. Too early means too early in their disease process, whatever we perceive it to be, without sending cultures, without waiting to see whether antibiotics are needed or not. Knee-jerk reaction and starting antibiotics are the hazards. Underappreciated long-term adverse effects of early antibiotic exposure, because we underestimate it. We have to stand back and think about it before starting any antibiotic in the antenatal period. That is what I mean by that statement. Now, chorioamnionitis, as we know, is not uncommon. Both clinical and subclinical chorioamnionitis are much more common in preterm than term deliveries. May account for 50% or more of the preterm births before 30 weeks of gestation, chorioamnionitis. There are two types. With ruptured membranes, you have early labor pains, or without rupture of membranes. Now let's go. Laboratory and clinical data have shown a link between spontaneous preterm labor and delivery with ruptured membranes. So this is quite common. And also, they will be associated with both systemic and ascending genital tract infections, including urinary tract infection. So it seems logical that antibiotics may have a positive role in such cases in the treatment of preterm labor, thereby avoiding or postponing the preterm labor and resulting in a more mature infant, making the lives of the neonatologists a bit better and the growth of gray hair a little bit slower in these neonatologists. So that is the whole idea. However, this does not apply to preterm labor with intact membranes. There, the situation is completely different. Recent Cochrane review, including 14 studies randomizing about nearly 8,000 pregnant women with preterm labor and intact membranes, showed that no significant difference with or without antenatal antibiotics in the perinatal or infant mortality, in preterm birth, or in any other clinically important short outcomes for the infant in case of preterm labor with intact membranes. Number needed to treat is 34 for the use of it with the infection in mind, and the number needed to treat for the maternal adverse effects of these antibiotics is 17. So 2 times the risk we are taking by giving antibiotics in labor with intact membranes. So we should really refrain and think about deeply whether it is needed or not. Then we come to the other important part of obstetrics, cesarean section. The rates of cesarean section is going up globally. In India, overall in the country, it's about 30 to 35%. Reading the literature, I also realize it's the same in the Kingdom of Bahrain, more than 30%. But if you go to urban centers and especially corporate sector, and hospitals where high risk deliveries are tackled, the cesarean section rates can go up as high as 70 to 80%. Very alarming and very noteworthy. And the second problem is cesarean section is a surgery. Just in case, let me start antibiotics. That is the other mentality lot of us have. So these are the two aspects we have to bear in mind. Low risk women, where elective cesarean section is with intact membrane, approximately 1,000 women should receive antibiotics in order to prevent 6 cases of endometritis and 4.4 cases abdominal wound infections. For all the rest, we are giving antibiotics unnecessarily and without any use and without any need. Please remember this. Whereas in women at higher risk, emergency cesarean section, ruptured membranes, obesity, etc., the numbers needed to benefit much lower, between 5 to 25, to avoid 1 case of maternal postmortem morbidity. So this may be rationalistic. Further research on long-term infant outcomes, the safest strategy is still to administer antibiotics prophylactically after the cord is clamped. Please remember, it's only few minutes, maximum maybe few hours before you can give the antibiotic to satisfy your thinking process. But at the same time, it is after the cord is clamped and the fetus inside or the little baby inside will not get that antibiotic. We'll come to that later. Group B streptococcus is very rampant in the West. I don't know how is it in Bahrain. In India, it's a bit low in incidence. Maybe we are not looking for it enough. Time will tell, but there is, not that it is not there. In such cases, we screen them, even in the West, and some of them, depending on the conditions they fulfill, we start prophylactic antibiotics. Actually, the golden standard would be to do a rapid PCR. Nowadays, you can do it in few minutes. Rapid PCR is the gold standard to decide whether we should give GBS or not to pregnant women. We do this just before, you can call it peripartum period. As I said, when we screen, sometimes we are forced to give. So about 20 to 30% of the fetuses of women having suspected or proved GBS will already be on antibiotics. We can't avoid that, but others we can prevent. If our objectives is to prevent GBS and early neonatal sepsis, as well as reduce antibiotic administrations in utero, then the solution would be to give vaccine to prevent GBS infection. This is almost ready. I don't know whether it's already available in the West, but very soon we are going to get this vaccine for usage. Coamoxiclav is the commonly used antibiotic to prevent GBS. But what does coamoxiclav do? It increases the risk of NEC, necrotizing enterocolitis, in preterm babies. This was one of the findings of the Oracle trial. And necrotizing enterocolitis is a nightmare for any neonatologist to treat and to overcome. It's a very, very difficult neonatal morbidity. Fourfold increase of proven or suspected NEC comparable to a placebo in a trial, I think, which looked at some between 1,000 and 2,000 cases. Fourfold increase of proven or suspected NEC comparable to placebo was observed. Now, one of the important things we should bear in mind is when we give perinatal antibiotic exposure, it affects the transition between maternal and neonatal microbiota. Microbiota is the population of commensals It may be bacteria, spores, fungal, the commensals which are there, which are supposed to be there, and which are found to be useful. So they also get affected when you give antibiotics to the mother. And they result in early onset sepsis in the neonate. A large study by Zhu et al. From China have shown that. The other important problem is the overuse of antibiotics to treat infections like respiratory and genitourinary or genital infections, which are not uncommon, which may or may not need antibiotics. We have to wait and see, we have to perform the appropriate investigations before taking a decision to start antibiotics, which many of us don't do it because these are the days we use what you call as defensive medicine, defensive medical practice. So that comes in the way. Some may need if it is severe infections, but in this world of pollution and various climate changes, some respiratory infections and genital infections, like anybody else, pregnant women will also have. We should keep that in mind. Antenatal antibiotics have long-term effects. Bahrain et al. Have observed that vast number of bacteria in our gut, as well as viruses, fungi, and other organisms are there, as I said earlier. Our microbiome essential for normal health and development. These disturbances, when we give antibiotics, has been linked to ever-growing list of health outcomes, such as mental health, immunity, obesity, heart disease, and cancer. See, this requires long-term vertical follow-up, which is not easy to perform. I'm sure in a place like Bahrain, it can be done because you have a captive audience, people who are stable in their follow-up, but not in India. It's very difficult. You have to follow up for 30, 40 years. But studies have shown these NCDs, non-communicable disorders, are on the rise. And one of the reasons is fetus and newborn in a very early stage have received antibiotics. We tend to stop thinking decades away. We look at the immediate effect, but we have to follow them up. And who follows them up? The neonatologist hands over to the pediatrician from the NICU, and the pediatrician hands over to the physician. So this is the handover and takeover, which has to happen very cautiously and in a very systematic manner. An infant's major contact with bacteria and other microbes occurs at birth. Babies should have the natural and the logical privilege to be born by vaginal delivery. When they are born by cesarean section, they lack this opportunity of going through the normal commensals in the mother's vaginal tract, in their lower reproductive tract. Those delivered by cesarean section are more likely to acquire bugs from their mother's skin or from the hospital equipments and hospital environment. That is the problem. Perinatal antibiotic exposure may be associated with the disturbance of the vaginal microbiota dysbiosis, and it is highlighted by many disorders which may affect the neonate. So the microbiota of the mother has to go to the baby. If you go antenatal antibiotics, whether cesarean or normal delivery, it can affect. But cesarean section has the additional problem of the baby not passing through the environment which it is supposed to pass through. So it has more problems. So that is what I want to emphasize on. So they have done studies. Babies born through cesarean section has a very low levels of lactobacillus species in the newborn and lactobacillus species in the mother's genital tract if you have given antibiotics, and especially in preterm delivery. In addition, it has been found that full-term gestational age and absence of perinatal antibiotic exposure seems to be protective factors in the transmission of dysbiotic gut microbiota and early onset sepsis. They have also found that wheezing is a big problem in mothers who have been given antibiotics and babies who have received antibiotics. I might slightly trespass into the outside the neonatal period in this topic, but I'm doing it with intention. Prenatal exposure to antibiotics and wheezing in infancy. Maya Popovich has done a lot of work, and a birth cohort study has shown that antibiotic use in the first and the third trimester of pregnancy, the wheezing in children aged less than 18 months has been very high. But there were a lot of confounding factors. They continued their work, they refined their research, and they said no association if the exposure happened during first trimester, but the exposure, if it happens in the third trimester, there is a definite association between development of wheezing in early infancy. Then the risks of wheezing after genitourinary infections during pregnancy were increased independently of antibiotic treatment. This is one of the confounding factors. Even if there is genitourinary infection and you have not treated with antibiotics, there was no Ronin culture, even then the risk of wheezing was there. So that was one of the confounding factors which made them make the statement that if it is in the third trimester, it is more dangerous than giving antibiotics in the first trimester. The association between prenatal antibiotic exposure and infant wheezing could be largely explained by many confounding factors. Antenatal antibiotic, capital A, small a and B, resistant infections in neonate. Regarding early onset sepsis, ampicillin resistance was more common with intrapartum antibiotics. Maybe it was used for GBS, and it was 50% versus 16% with a p-value of 0.01, less than 0.01. Resistant to at least one maternally administered antibiotic was more frequent with intrapartum exposure. Very clear. Again, the p-value is less than 0.01. So at least one antibiotic out of the many which you may have given to mothers, the baby will be resistant. Other observations are antenatal antibiotics exposure affects enteral feeding, affects body growth, and neonatal infections. The effects on body growth vary by the exposure level and the age of gestation. If the baby was delivered less than 34 weeks of gestation, the chances are higher. I will go further and state that the baby's early microbiome acquired from the mother at delivery educates the infant's developing immune system in the first weeks and months of life. So if you use antibiotics during antenatal period and early in the neonatal period rampantly, the newborn and fetus may be illiterate. That means the education of the body for developing normal immune system may be affected. That is what I mean by illiterate. Antibiotics in pregnancy can alter mothers and therefore baby's microbiome, affecting early immune responses. And this may increase the risk of infection in childhood. A recent Danish study has said antibiotics in pregnancy was associated with increased risk that her child would develop a severe infection in the first 6 years of life. Again, a good, proper vertical follow-up. The increase in risk was greatest among children whose mothers were prescribed more antibiotics and who received antibiotics closer to the delivery. The association between antibiotics in early childhood and obesity, very clear, very clear. This has been well established. So that's why I said I'm trespassing a little bit beyond the neonatal period. So early exposure to antibiotics and later obesity is very clearly demonstrated. Antibiotics exposure within the first year of life is associated with a 10 to 15% increase in the risk of obesity. Again, Crohn's and celiac disease, gastrointestinal disorders, particularly antibiotic usage in the first 12 months of life is linked to these major disorders. The exact risk is difficult to quantify, but children receiving over 7 courses of antibiotics in the first 12 months, which is not uncommon with recurrent respiratory tract infection, are at a 7-fold risk of Crohn's disease. Other childhood inflammatory diseases like juvenile idiopathic arthritis have also shown similar association. So we come back to what we, I put this thing earlier. So what it says, okay, it's not playing now. Doesn't matter, you have already listened to it. So what it says is there is a good with antibiotics in pregnancy, as indicated by severe respiratory and GU infections. As far as possible, minimize the antibiotic exposure of the fetus in the late third trimester. Practice antibiotic stewardship, not broad spectrum antibiotics, narrow spectrum antibiotics after looking at the culture, the right dose, the right duration, and stopping it if you feel that it is not required after the results come back. One thing which we should remember, if you give antibiotics just after the cord is clamped, the problems are much, much, much lower. The bad part is rampant use of antibiotics, cesarean sections without definite indications, routine use of antibiotics for that, and the disturbance of the maternal-fetal and neonatal microbiota leading to dysbiosis. These are the bad effects. And not giving probiotics to the newborns. Now they even promote giving probiotics to the pregnant ladies. And they have found that not just probiotics mixed with oligosaccharides, which are the prebiotics mixed with oligosaccharides, which are called symbiotics, are very, very useful. And specific symbiotics are now available in the market to be given during pregnancy and also to the newborns. But all the same, always practice antibiotic stewardship. So what is ugly about antenatal antibiotics? The ugly one is the antibiotics usage resulting in early onset sepsis, necrotizing enterocolitis, leading to resistance to antibiotics, so that the baby, if has any severe problems, goes to PICU, the baby or infant is already resistant to some of the antibiotics. That is the ugliness of antenatal antibiotics. Antenatal antibiotic exposure affecting enteral feeding, the growth and the increase in neonatal infection in the preterm infants during their early infancy is the ugly scene of usage of antenatal antibiotics in pregnant women. Obesity, GI disease, juvenile arthritis obviously are. A small mistake which you have done are leading to major problems. So that is the ugly part. So I end with the slide. I am a firm believer of perinatal medicine. Perinatal medicine is the joint management of pregnancy and the delivery by the neonatologists or pediatricians and the obstetricians, because newborn is a continuum of the fetus. It's just the same individual, but more mature. So the pediatricians and the obstetricians need to liaise well early in the antenatal period, sometimes even in the preconceptional period also, depending on the inherited disorders which the risk might be there. So please be in good touch with your obstetric. Do not follow the old dictum, I'm in charge till the cord is cut, you take over later. Please talk to each other, liaise, and prevent a lot of possible complications. Even in the curriculum, they should be taught the liaison of the obstetrics and the pediatric people. Regionalized care is superior, and we have to develop more perinatal centers under one roof. The obstetricians and pediatric subspecialties should be present. Just as a signal, when I was the president of the National Neonatology Forum of India, I published this clinical protocols in perinatology, which covers all these things, and the perinatal in utero infections, everything is there in this book. And I'm very happy that it was well received. Once again, I thank the team from American Mission Hospital for giving us an opportunity and for me to be here and speak a few aspects of antenatal antibiotics. You may ask, why did I choose this topic? A, as I said, the liaison between pediatricians, obstetricians should be stronger. And B, this is a seldom discussed topic. Thanks for your patient listening. Thank you.
Thank you, Dr. Ranjan. I think, as I go on saying, definitely a very seldom discussed topic. So it was really eye-opening. For the next session, I'd just like to introduce Dr. Mona Al-Jaferi. Dr. Mona is a neonatologist, senior neonatologist and pediatric consultant at Anrasala Medical Center. She's an assistant professor at Arabian Gulf University in Bahrain and a lactational consultant with IBCLC 2028. She has 15 plus publications in national and international journals. And Dr. Mona is an ex-Salmania Medical Center neonatology consultant and head of the NICU there from May 2010 till November 2016. She was also awarded the Bahraini Women Day Award from the Ministry of Health in 2016 and is an active member in the Breastfeeding from Theory to Practice program since September 2022 that gives training for healthcare providers in the art of breastfeeding. Her topic today would be multidisciplinary teams for post-hospital discharge.
Good morning, everybody. I'm so happy and glad to be around you and to participate in the fourth pediatric symposium. I would like to thank the scientific committee to give me the opportunity to share with you one of my really wish and a dream. Unfortunately, it was not completed before I left, but this is the dream I think most of all neonatologists share with me, to have a multidisciplinary approach post-discharge in ICU. We have it when the baby is inside the ICU. We have the interdisciplinary team because a neonatologist alone will not do anything. He needs to collaborate with all the pediatric subspecialties, with the nurses, with the physiotherapists, speech, dietitians, and the clinical pharmacists. But when baby going home, this is the time where the family will start suffering, and you will see many of moms, they will miss their appointments when they are coming to your clinic as a follow-up, when we have the neonatology follow-up clinic, and you will tell them, why you didn't go to there? Why don't they say, that's mean we have to spend all our days inside the hospital. So that's really, it's a time now to work as a team, and we have the multidisciplinary approach for these babies. Just a few days ago, we celebrate the International Award for Prematurity, and this year, as the theme was access to quality care everywhere. So I think to have a project, a quality improvement project in all big hospitals like the American Mission Hospital and others, to have a project like multidisciplinary approach is one of the quality improvement care project. So because of that, we need these babies, they deserve that. So the objectives of this lecture, we'll talk about the morbidities for prematurity, what are the components when we decide to discharge, what are the multidisciplinary team components and why we need it, and the developmental and the growth follow-up care, psychological follow-up care, and the challenges in the multidisciplinary care. When we see this is the journey of these, the baby will be in the ICU, will have a lot of morbidities where we'll talk about it. Then this is the time when we start the mom to express milk and give the gavage. This is especially if we have a family-centered program, when we involve the mom to be part of our team. Then this is the time when the mom also start to, we don't have the other here. When we have the mom to start to now to be more closer to her baby and practicing kangaroo care, then this is the time when nearby discharge and going here. So let us see what are the morbidities these babies will have when they are in the unit. I will not talk about the acute one, but because I'm talking about the post-discharge, I'm talking about the chronic complications. If we see in respiratory, we'll have chronic lung disease, which it was called in past, bronchopulmonary dysplasia, respiratory infection. They will be still at risk of apnea of prematurity and sudden infant death syndrome. They will have, like, especially within nutrition, they will have feeding difficulties, oral health, and they will have incomplete catch-up growth in short and long term. And we see many of our babies, especially the extremely preemie, they will be failure to thrive, they will be short sometimes, and even we found in some they might have later on as a growth deficiency. They might have cholestasis, and it's more either related to the infection or related to total parenteral nutrition, and also long time of fasting or the complication of necrotizing enterocolitis. They might have anemia, and we have what we call the anemia of prematurity, and they will request transfusion, and they will request also iron and erythropoietin. They are at risk of hypothyroidism. For the eye, they are at risk of the retinopathy for prematurity. They will have squint, they will have myopia and others. These babies, because they suffered a lot inside the ICU, how many painful procedures we are doing for them, how many breaks. If you ask any pediatrician, how many break you break for these babies, it's countless. And we are thinking, oh yeah, because they are preterm, they don't feel it. But it's found that it have a long-term effect. And these babies, that's why you will see them very stressful, distressed, and have a lot of a problem is related to the chronic painful stimuli. Also scar deformities, they will have hernia and bone mineralization, what we call the osteopenia of prematurity, and others. And this is just an example of what are the morbidities these babies they might have. With all these morbidities, do you think there is a need of a team or not? There is a need, yeah, because it's not one problem and it cannot be followed by one person. It's need by many subspecialties. So when we go back, and this is the time when we want these babies is ready to discharge. Is there's any criteria? We have as neonatologists, we have a criteria for discharging these babies. And these criteria is not just the medical, because sometimes we are just focusing on medical issues, but there are other criteria that we have to put it in our mind when we are thinking about discharging these babies. And if we prepare the family from beginning, before going home, things will be ready and involve other teams. So what are the components of the NICU discharge planning? First, this is the most thing we are focusing is the medical stability, medical criteria. We want to make sure that temperature, that the baby have stable temperature when he is outside. We want to make sure that he is gaining steadily, at least 20 to 30 grams per day. Feeding readiness. Feeding is either by direct, either by bottle feed or anyway, even if the gavage or gastrostomy, but he is feeding readiness or breastfeeding. Temperature instability, as we said, respiratory independence. He can breathe by his own, or even if he need nasal cannula or BiPAP, whatever, but he can breathe by his own. The other thing is, which is, I think sometime as physician, at least I'm talking about I'm talking about the experience here in Bahrain, is about the family, how they are prepared. How many times we spend teaching these moms about what to do in case of this baby is becoming apneic. Or we are teaching a family CPR for them, teaching them what are the ABC, stabilization of the airway, about chest compression till the 999 coming. This is very important, and most high-risk patients, before discharging from an ICU, you have to tell the mom the signs when they are, how they are, the ominous sign that you have to take care of it. The other thing, what to act is not a matter just recognition. Also, how to act on it is very important. And also, if we will send them in section, some of babies we discharge, they are in suction machine, they are in oxygen. So we make sure they are familiar with the equipment, they know how to deal with it. And the best is to send somebody to check the things at home. We are doing it if we are sending patient on oxygen or a special suction machine and let them bring all the machine first, make sure, let the medical equipment check all these machines and the maintenance before discharging the baby home. And also teach the mom how to, if it is like he will go on gavage feed, teach her how to insert the tube, rather than if the tube is out, the mom will come running midnight just to somebody to insert for her the tube. So we need to teach all these skills to the moms. Then after that, we have to have a community resources by either community nurse that coming and visiting these babies at home, or the follow-up clinic. And also nowadays is especially after the COVID era, we have the telehealth, and we can use it as by communication between the primary physician and the family. We have the WhatsApp, we have the Zoom, we have many telehealth that can help us to communicate with these patients. So now, after discharge, the patient is now not in the hospital. These babies will need really a support. And this is the time where we are wondering, this is the area we lost many patients, and they might not getting the proper care same when they are in that journey. So what is the multidisciplinary team? If we see the multidisciplinary team as consists of the primary immunologist, the pediatricians, all the subspecialties. We are in need of pediatric pulmonologists. We are in need of gastroenterologists. We are in need of pediatric development care. A lot cardiologists, they will follow with us, especially those who have chronic lung disease. They are prone to have pulmonary hypertension. So we need the pediatric cardiologists. So many pediatricians, they are involved with us in the care of these babies. So when we have when we are thinking about to create multidisciplinary team, these should be involved. And the therapists. When I'm talking about therapists, I'm talking about speech therapist, occupation therapist, physiotherapist, and even the inhalation therapist, who is the one, when if the baby, you are sending him home, he need that inhalation therapist to go and check the equipment. Social worker is very important to be before discharging and even after discharging to follow these patients. I know as physicians, we are busy, but when we have somebody that in communication with the parents, helping them, seeing them what they are in need and giving them the support, it will help. And the others, and I will see what I will talk more about it, others. And in this team, the parents should actively participate. They are not just a one who just taking an order. It's a time now is out that we are using we should not act parents, we should act as partners. So they have to be involved with us. They have to act with us. When I said others, these are others. They are not, they are more important, they are important, same as the other that I'm, the other healthcare providers. We need developmental specialists. We need psychologists, audiologists, ophthalmologists, radiologists, pediatric surgeon. We are all the time. The pediatric surgeon, all the time, they are with us when we are taking care. So if you see, this is a big team. We cannot do it in one set, but at least if we gather, if we arrange the appointments to be in the same time and collaborate, like what I remember, at least what we were able to do, that the neonatologist, the dietitian, the physiotherapist, they are all together in one sitting. We are doing it with the parents. This will help at least at least 3 appointments done in one appointment, and they are hearing. So it will help a lot. So why I'm talking about the multidisciplinary approach? Do you think, is it essential? Are we in need of it or not? I think it is, we are in need of it because we have short-term benefits and we have long-term benefits. It found that it reduced rehospitalization by 25%. So it mean a lot of a lot. And also in long-term benefit, there is reduced neurodevelopmental outcome by 30. And this is why when you are having a multidisciplinary and you are involving the occupation, the speech, the physiotherapist earlier and are with you, you are seeing the patient, you are evaluating, they are putting the program, they are teaching the mom, and they are giving the video to the moms to act at home, to do all these movements. They found we are working about what we call the neuroplasticity, and this will help to improve the development. So it found it improved the outcome by 30%. Also, the parent satisfaction. It found that multidisciplinary approach is improved the parent satisfaction by 40%. So, and this is a huge number. Also focus on family-centered care and integrated community resources. So that's why multidisciplinary team approach is very important. It also leads to adherence. When we have adherence to vaccination according to our Ministry of Health policy. Also, it will help to giving the RSV monoclonal antibody during the RSV infection seasons, like now what we have. This is the season, and we are according to the eligibility criteria. Why I'm saying eligibility criteria? Because it differs from place to place, according to the resources, according to how is the RSV as severity. This is what we are, at least we are following in I was in Salmania Medical Complex at that time. I know it was the criteria of 2010, and then there was an update 2014, but according to when we review our patients, we didn't change. And then there's a lot of critique came to the criteria of 2014. So many of centers, at least in the GCC, they didn't change, like in United Arab Emirates and Saudi, they are still following these criteria because they are adjusting according to the data they have. So this is the criteria we are following for RSV RSV IgG vaccine we are giving. We are giving 5 doses. The season will start usually from September till February. And according to the index case will be the starting. In the past, we were starting in October, but then nowadays we are seeing it's showing earlier. So we are starting earlier. We are starting from September. So with this, then as a part of multidisciplinary care, we need to develop the developmental follow-up care, because early identification of a neurodevelopmental delay, either motor, cognitive, speech, improve the outcome by 50% through intervention program. So that's why we need to have pediatricians who are specialized in developmental care, or from, like in North America, the same neonatologists, they have what we call developmental follow-up program, which is used as third-year subspecialty. So you will see a neonatologist who is subspecialized in developmental, or you will see pediatrician who is subspecialized in development. So at least you should have in your center, if you are taking care of extreme preemie, you should have a developmental clinic. We need to enhance the school readiness. How we enhance that? Because we don't want these babies all the time to be in a special care institutes or special education. I know some they will have, but we need them to be ready to join the ordinary schools. And this is now the trend. That's what we are doing in Bahrain. We want to make these babies be ready to be as a part from any other, like any other children. So how that? It will be by ongoing assessment through specialized follow-up clinic and standardized tests to detect the autism, the ADHD, and learning disability. That's why we have a program for us. We send them by for psychiatric, actually, and it's not, unfortunately, it's not the developmental, but we are seeing it by the psychiatry, child psychiatrists, which will evaluate, and then they will do the psychological test. We do it at 2 years. Then after that, we do it at 3 years, between 3 to 5 years, and before school, going to the elementary school. So when we detect, especially the autism, it can be, as we know, can be detected earlier. Yes, we can detect it between 18 months to 2 years. So, and it found that early intervention will be better outcome. The ADHD, usually it's before the school, because the age, which is really definite diagnosis between 6 to 7 years. So it will be just before the grade 1. Learning disabilities, if they go to the nursery, you can start to detect how is their learning abilities. And we do the proper IQ assessment. They do it at 5 years, and they do it at 7 years here in Bahrain. The other thing is we need the long-term follow-up for growth and the nutrition. Parents we found that when they are coming to us to the clinic, they have very concern related to weight gain for their preterm babies. And we found them, most of them, if we plot all these babies, we'll see them, majority of them, they will be below the curve. So how we can help these babies to do the catch up? But the most important, when you are plotting, especially for the general practitioner and others, do the correct age. Because unfortunate, we are getting referral from local health center that these are babies are not thriving proper. Why? When we just check, we found them, they are doing it, they are bloating according to their chronological age rather than corrected age. But, so please, for all general practitioner, when you plot the growth chart for these babies, do it as corrected age, and it is the corrected age chart needed till up to between 2 years to 2.5 years. Then after that, they should be used the other their chronological age. So, and make sure that they start to be independent, self-feeding when weaning, and shift to in the relationship of control over feeding and intake, and can be anxious time. Why? Because you notice most of moms, and even we are forcing them. We are not letting them come and take, and this will make them more stubborn, and they will not eat. So now it's better give them a chance to eat, and this can be made by have a team. Usually it is from pediatric dietitian, a speech therapist, and there are from nowadays, now what we are seeing, some of the either the speech therapist or the dietitians, they are specialized in this area, and they are giving more hands for more help. So they need to take a full history, observe. They need that session. This session, if they will do it, it need 90 minutes. They will let the baby, they will give the food after the history, and see how is the baby is acting with the while feeding. And then after that, they will do the management plan with the family, with the mother, how to approach this child. And this helps to reduce the anxiety. This is one of my patient. I take her permission. This is 26 week. She was very fussy. She don't want to eat. She is all the time when mom, she is approaching her, she is closing her mouth. She is 1 year and her weight is just 6 kg. Even when I did the corrected age, she is also far away. And then after that, I told her the best, yeah, I sit with her, I send her to the dietitian. Then I told her the best, go to such and such. She will sit with you, she will give you how to help you. And she give her all the detailed plan. And this is the mom, she sent me that video before. See how she is now enjoying taking the food by herself. I know she is messy, but she is enjoying. She is putting all the bites in front of her, and she chooses whatever she wants. But nowadays she is taken by herself. She is enjoying, and by the way, she only wants things which is crunchy and things in pieces. She don't want things which is very like a soup and this she don't like. She wants to feel she is crunching something. But so it is just a matter of one step. It help, it give them, it relieve the anxiety of the parents. So we talk, as also part of it, we talk, then we don't forget about the psychosocial support for families. 50% of parents, they will have what we call the post-trauma stress disorder, and they have especially post-discharge. So it is a huge number. They are very stressful. And we saw many times when we are discharging a mom with the preterm, in the first 1 week, you will receive a call to the NICU almost 3-4 times you are receiving, and she will come either, the first visit is when she come to the clinic is a time of crying, because she is having a lot, she is frustrated. She don't know if she is doing is the right thing or not. She wants somebody to reassure her. And this, I think, is the step. If we apply, and in the past we did it for a short period, and after that in COVID have been canceled. If we put room in these moms with the baby for a few days before discharge, it will make a lot of difference in confidence. But not every time it can be done. So they will have a lot of anxiety, they will have depression, and that when a mom is depressed, when she is stressed, it will affect the outcome of these patients. So we need the peer support group. Usually they are doing it by themselves, the moms actually in ICU when I was there, because in the breastfeeding room, the moms will meet. So what they will do, they will take the phones and they start to make a group and they support each others. So from that idea, what we did with the moms who have now elder preterms, we joined them together. So at least they share with them their experience and how they how it helped them in relieve the anxiety. Mental health counseling is very important. These moms, they need this support. They need the counseling. So we need to be with us as to have the counselor. In Salmania, what we achieve is to have we have psychiatric doctor. She is in Salmania. She's saying, anytime you have a mom, just call us and I will come and I talk to her, and she is very cooperative in that. And as we said, the family-centered care also reduced the parental stress by 40%. So it is very huge number. I saw you the bright side, but there are challenges for any project, bigger project like this have a lot of challenges. One of the challenges is the limited access. Like for us in Bahrain, we don't find that a problem because it is the distance are nearby. But if we apply this in big countries, it will be difficult. Financial constraint. For us, many times we couldn't continue because of no budget. And we will not be able to continue the program. We stopped, and again we continued. A resource of this disparities. The other thing is this joint communication between healthcare providers. If you want to join, and we have many examples to have all them together, like to have the neonatologist, like when we have pediatric orthopedic, the developmental, and the dietitian and the physiotherapist, to have them all in one session is not that much easy. Each one because have its own commitments. So, but what help is now, as we said, technology help us a lot. Telemedicine, community health programs, and integrated health system. If all the things we have nowadays, the e-files, these are, so if I am seeing and are writing the details, my colleague also can see what is the next step that he have to do it together. So there are limitations, but doesn't mean it is impossible, but it's a dream that we need to have it. Like this is a case, if I tell you this is a case, this is 26 week. He was having RDS, he was having BDA, which have been closed by medication. He was having feed intolerance. He was initially he was not gaining weight proper, and he have a chronic lung disease. And this patient had been discharged at age of 4 months, and now he is discharged. So tell me, what are the things you want to do for this patient? Now he will go home, and now the nurse, we have the discharge planner. She give him around 12 appointments that are needed to be done. So what do you think? How we can help him? We help him again by having a multidisciplinary clinic. It's a time to have them all together. Like at least what we are doing, at least when we are not having, we cannot do it in one set, at least have it in one day in the same set. So what we are doing, at least let them visit to the neonatologist, the pulmonologist, the cardiologist, and the dietitian physiotherapist is in the same time, and you are just calling and giving them the history, so they will go and focus. So at least that will help. At least this is the minimum thing that we can do. And with time, it will come, the project will grow up and will reach to a real multidisciplinary clinic. Thank you. So home message is that multidisciplinary care improves survival development and family well-being, focus on evidence-based, family-centered approach, advocate for policies promoting access and continuity care. Thank you.
Thank you, Dr. Mona, for a really enlightening lecture. I'd like to welcome Dr. Ranjan back again for his second lecture called Novel Strategies to Protect the Newborn Brain.
Hello, I'm here once again. You know, India is a cricket-loving country. I first performed the task of the opening batter in cricket. You know, since women have started playing cricket now, we can't call batsman. So we now call batter. So I started the opening batter's role. Now it is number 3 position, which is also very important. So I feel, you know, overwhelmed with the task which they have given me. However, I'll try to do justice. But before that, with the topic of novel neuroprotective strategies to protect the neonatal brain, I want to just tell you the mammothness of India's perinatal statistics. We have an annual birth rate of 27 million. 27 million is the population of the continent of Australia. So imagine every year we add one Australia to India. Can you imagine that? It is what you call as amazing and unbelievable. Then we were talking about health education and things like that. If you take our currency note, like how you have dinar, we have rupees. So imagine a 100 rupee currency note. On that, it is written 100 rupees, 100 rupees, 100 rupees, 100 rupees, 100 rupees in 16 languages, including English. That is the minimum number of languages which is recognized for all national activities. So this is our country. I don't think there's any other country which is as heterogeneous and as diverse as India. When I was in England, when I speak to my colleague who is from India, I speak in English sometimes. So the locals used to ask, hey, Ranjan, you're from the same country, isn't it? Yes. Why are you speaking in English? Because they don't realize that I don't know his mother tongue. Being, you know, the next state. So that is the situation. And sometimes I feel it's a miracle how India is existing as one country. So let's stop there and we will go back to this novel neuroprotective strategies to protect neonatal brain. This is my city. As I said, they say that if you throw a stone randomly, there is 1 in 3 chance that it will fall on somebody who is in information technology or computer science. So that is actually real, not false. So that is what Bangalore is. If you go to London and dial for some information about London Underground, the reply comes from Bangalore. So this is just for your general information, I am saying this. Now, what is neuroprotection? Neuroprotection is defined as the ability to delay or prevent neuronal death and dysfunction, which should translate into delayed disease onset or slow disease progress in humans. So that is what is meant by neuroprotection, and we are supposed to implement neuroprotection strategies so that the brain injury is lessened. It is different in preterms and different in term babies. Babies born before 28 weeks of gestation, 40 to 60% develop moderate to severe neurodevelopmental impairment. Sometimes we say neurodevelopmental rate is very low in our setup. That is because we are not looking for it. And we are not looking for it in a very detailed and systematic manner. So we should have a program, as the previous speaker said, geared towards diagnosing this. It can be cerebral palsy, cognitive impairment, subtle emotional and behavioral problems, and autistic spectrum disorders. That is from very mild to obvious autism. Pathologies like intraventricular hemorrhage, cystic white matter injury, and specific pattern of preterm encephalopathy, dismaturation of neural and glial progenitor cells are the pathologies which lead to this. Our aim is to achieve intact survival when we treat our newborns, may it be preterm, low birth weight, or term babies who have had some perinatal morbidities or perinatal events. I said novel interventions, but when we say novel, like in our life, we can follow modern things in our various aspects of life, but we cannot forget useful older things which you have learned and which are found to be useful even today. So I'm going to also touch upon those topics. Antenatal interventions, the foremost thing is antenatal corticosteroids for all those who are at risk of preterm delivery. Within 7 days, we should give antenatal corticosteroids. I'm not going to go into the details. The dosage, everything is universally well known, and it is a standard of practice. And it doesn't only prevent neurodevelopmental outcome, but has a lot of other benefits too. Epicure study has shown that babies born less than 26 weeks of gestation showed an increased mental development index at 2.5 to 6 years of age when they have received a full course of corticosteroids as prescribed. Not giving antenatal corticosteroids, a mother who is qualified for that can be considered as a criminal injustice in the present day. Now, lower neurodevelopmental impairment at 18 to 22 months of corrected age in preterms born between 23 and 25 weeks of age has been observed after giving antenatal, after mother receiving antenatal corticosteroids. So that is very, very important. That's the first intervention which was there, which is there, and which will continue for days to come. Antenatal magnesium sulfate, yes, in many parts of the world, this has not taken up, but it's an important intervention in the neuroprotection of the newborn brain. Again, I'm not going to go to the details. It seeks to reduce incidence of motor disability, cerebral palsy by 30%. It's very significant. Magnesium sulfate regulates excitatory stimuli, blocking the NMDA receptors. It improves cerebral blood flow. It prevents neuronal injury from pro-inflammatory cytokines, and also may have an anti-apoptic effect. Now, not much monitoring is required, and it is not expensive, and it's feasible and possible to practice it. Only thing is, we should do it very methodically. Numbers needed to treat at 34 weeks is just 56 to prevent one newborn baby's brain. And at less than 30 weeks is 46 to improve one baby's brain. And these are all the indications. Actually, there's no contraindication if you read that. All the babies who are preterm, less than 33 weeks and 6 days of gestation are expected to receive that. The mothers have expected to receive that, not the babies. Babies are still in utero. And it is regardless of all the things like plurality and parity, mode of birth, which is planned or what is going to happen, you know, antenatal magnesium sulfate has to be given. And the dose is there. You can always look it up. And some minimal monitoring like the alertness, the level of consciousness, awareness, and patellar jerk, which will tell you that the mother is neurologically all right, though she is receiving magnesium sulfate. And magnesium sulfate is nothing new. Obstetricians have been using it from a long time for pre-eclampsia and things like that. But here we are using it for neuroprotection of the baby. We come to the same topic, antenatal antibiotics. Meta-analysis revealed significant correlation between chorioamnionitis and infantile CP. And as I mentioned earlier, if there is rupture of membranes, if we give this, it will definitely benefit the baby, even as far as the neurodevelopment is concerned or the protection of the neonatal brain is concerned. Cochrane review, administration of antenatal antibiotics for preterm premature rupture of membranes decreased neonatal infection and decreased abnormal cranial ultrasound prior to discharge from hospital. This, however, this did not make any difference in membranes were intact. The same thing I said in my first talk. So it should be given to all mothers having PPROM expecting imminent delivery at or below 32 weeks and 6 days of gestation. And if it is found out after culture and all, it's not required, fine, you can stop it. Tocolysis, delaying the delivery. To prolong gestation in women with imminent preterm birth, it will also give you an opportunity to complete the antenatal corticosteroid course and giving magnesium sulfate. It was practiced and it is still being practiced. There are a lot of agents which can cause tocolysis. Currently, insufficient evidence to show tocolysis improves neonatal outcome. See, these are some of the studies which come up, and it is up to you to accept it or not. Again, the agents are not expensive and can be practiced. And imagine my country where the load is so much, whether it's good to practice or not good to practice is a debatable point. Progesterone, this has more evidence. Progesterone in estradiol in third trimester seems to protect fetal brain because of their antioxidative and anti-apoptic properties. Maternal progesterone administration has been shown to reduce preterm delivery. That itself is good enough because as the gestation age improves, the brain matures, and it is always good to have a better brain than a good brain. Progesterone suppresses post-ischemic inflammation by reducing the expression of interleukin-1 beta, tumor necrosis factor, and thereby it maintains integrity of blood-brain barrier. Also inhibits post-ischemic apoptosis, induces growth hormone secretion. One of the largest trial, again, optimum of vaginal progesterone to reduce preterm birth in high-risk women found a reduction in neonatal brain injury. However, meta-analysis by Romero et al., I must say this was a small number, revealed no difference in neurodevelopmental outcome. So you will always have studies which support, which says may or may not, and few studies which says no. You are the clinical person, you are the person on the ground, and you have to look at the evidence properly and practice. This is all the things which I have mentioned with asterisks are recent novel interventions. Okay. Docosahexaenic acid, DHA as it is called, long chain polyunsaturated fatty acids, DHA and arachidonic acid are essential for neurogenesis and neurotransmission. Accumulation of DHA in fetal brain happens from the third trimester and it goes on till second year of age. So we'll talk about after birth DHA later. So Dino trial compared infants of mothers on high DHA and standard DHA supplementation until 40 corrected weeks of corrected age gestation. And these infants born after high dose at the age of 18 months showed significant improvement in mental developmental index. However, more benefit was seen in girls. So we can use it. It may have some benefit in boys also, because that is still not very well explained. And in my country, due to various circumstances, prenatal sex determination is banned. In such cases, we can openly or favorably use DHA. Choline is another substance. This is again a very novel method which has been used to improve neonatal brain. Choline plays an important role in neural migration during fetal development, and its deficiency is associated with spina bifida. Animal studies have shown choline supplements during pregnancy increases neuronal size, increases neuronal cell proliferation, reduces hippocampal apoptosis, and improves learning and memory in the offspring. This is choline to mothers, again I'm saying. Wu et al. Conducted prospective cohort studies of 154 mothers, small number, measuring choline levels at 15 and 36 weeks. They were receiving choline supplements and neurodevelopmental assessment done at 18 months. They demonstrated significant positive correlation of increased cognitive scores and maternal plasma-free choline. So this is going to be popular in the future days, I feel. This is one of the new interventions which will come. Not, it's easy to give and it will definitely improve. See, sometimes it's better, we should know what is going to come, because there is a saying in English, the eye sees what the mind knows. So it's always good to have an idea of these things. N-acetylcysteine, the precursor of glutathione, is a free radical scavenger and has anti-apoptic, antioxidant, and anti-inflammatory properties. Newborns who were exposed to chorioamnionitis and antenatal and postnatal N-acetylcysteine were safer, preserved cerebrovascular regulation, blood regulation, and increased anti-inflammatory neuroprotective proteins. That means beneficial to the fetal brain and the continuum of the fetus, which is the newborn. Now, again, come back to our good old practices, which we should not forget. Optimal and management of preterm delivery. Delayed or deferred, whichever word you want to use. Deferred cord clamping reported better neurodevelopmental outcome at the age 7 to 18 months of age, who received placental transfusion because of DCC. Even at 3.5 years follow-up, there was better neurodevelopmental outcome. As I said, every now and then one study comes up. However, a recent meta-analysis concluded there was insufficient evidence about long-term neurodevelopmental outcome in DCC. But please imagine, there are a lot of other benefits. In a country like India and vastly populated countries where anemia in the early infancy and childhood is very rampant, this has found to be useful. Then there are many other important advantages of NCC. Don't look at, DCC. Don't look at the only of the one which I am mentioning. So again, it is a study which has to be done from population to population, taking cognizance of all the other aspects and giving a recommendation. So according to Indian circumstances, as of now, delayed cord clamping is recommended in all babies, preterm and term babies. Cord milking also is another way. So they have been recommended and they have very few contraindications in case baby needs imminent resuscitation and things like that, they may not do it. So we have to take it by environment to environment, country to country. And at the same time, our postnatal intervention should be always geared towards neurodevelopmental outcome and protecting newborn's brain. So all the acute illnesses of prematurity should be promptly treated with the recent recommendations so that baby's brain won't suffer any damage resulting in neurodevelopmental outcome. My previous speaker spoke about nutrition, very, very important. It's very common for us to only look at the ventilator and that, actually present, perceived or expected cardiorespiratory problems and ignore or sometimes forget about the nutrition. It's very, very important for any preterm baby or any sick baby to receive prompt nutrition along with the treatment of the other morbidities. Mother's milk, it's a reward to the baby via the mother given by nature or Almighty, whatever you might call. And we have to promote that. Mother's milk is being neglected, breastfeeding. We should have a separate person for lactation management and making sure mother's milk goes to the baby within the first hour of delivery and as far as possible, exclusive mother's milk for the first 6 months. Family-centered care, as she said, and pain management is very, very important. Again, we may feel these are small aspects, but they have a long-term effect. Kangaroo mother care has become the standard of practice. It has no expense. Even in low and middle income countries, they cannot complain. This is one intervention which has highest benefit, starting from what you call as intelligent quotient, to growth, to development of proper immunity, everything with kangaroo mother care. And we can't say that our environmental temperature is high, so we don't need kangaroo mother care. No, skin to skin contact and skin to skin care is important because the baby coming from a warm environment from in utero to outside, whatever the temperature may be, it is going to lose this thermal loss, which can lead to a lot of problems. So everybody should practice kangaroo mother care wherever and whenever it is feasible. This is another one, caffeine. We are using it for a lot of other things, mainly being apnea of prematurity, but it enhances cerebrocortical activity and decreases hypoxic episodes. So that itself is enough to improve the neurodevelopmental outcome. If you have apneic episodes every now and then, there'll be periods of hypoxic episodes which will definitely affect the brain. Maintains stable vascular hemodynamics, improves gross motor function and cognitive function. So caffeine should be started as early as possible as per the current recommendations. See, these recommendation keeps changing. You might have heard of William Osler. We all learnt about him in general medicine. He's a great physician. Osler's nodes, etc. Now, he once said during a graduation ceremony, my dear students, congratulations, you have become doctors today. But the unfortunate news is half the things which you have read are going to change very soon. And the problem is we don't know which half is going to change. So same way, medicine is a very dynamic subject and things keep changing. And that is why I said we should not feel any day that we know everything or we have learned everything. That is very important in our profession. So caffeine in its proper dosage should be given and the baby should be monitored. Occasionally it develops severe tachycardia and there's some gastrointestinal things when it's given orally. But it's a very important medication as far as I'm concerned and has a lot of multilateral advantages. Indomethacin. See, this is again probably going to be a standard of practice. Prophylactic indomethacin decreases the risk of IVH. However, one of the studies, TIP, did not show clear long-term ND benefits, but work is still going on because indomethacin is available orally and parenterally. And we were using indomethacin for closing the duct some years ago. People like me remember it. And when other things were not available, it was a God-given gift to us. Now, of course, we have several other things. So indomethacin usage has come down and its ill effects has become more glaring. DHA, which I mentioned for the mother, also given postnatally, the babies who received that had a better problem solving, mathematical problems, not other problems. So they had a better intelligent quotient, it is found. But again, Cochrane review 2017 of infants receiving LC-PUFA supplementation did not show significant benefit. I wouldn't put any benefit. So DHA is another one. That is post-natally. This is going to be the key player, erythropoietin. Erythropoietin, an important role in normal male development, even otherwise. Receptor for erythropoietin growth factors are found in astrocytes, microglia, neurons, and endothelial cells of the CNS. Acutely affects by anti-apoptic, anti-excitotoxic, anti-inflammatory, neurotropic, and antioxidant properties, erythropoietin. Long-term effects include angiogenesis, neurogenesis, and oligodendrogenesis. Very important. A Swiss randomized control trial of about 500 babies born before 32 weeks, receiving 3 doses of erythropoietin over the first 42 hours, showed lower white and gray matter injury on MRI at term. This was an important study. But again, this also doesn't have a overall majority. Because again, the Cochrane database in 2015 found erythropoietin decreases adverse neurodevelopmental outcome by 50%, with a number needed to treat only 14, which is very good NNT. However, a trial came, PENET, and it failed to show any effect on death or neurodevelopmental outcome. But people didn't stop at that. A variation of erythropoietin called darbepoetin, they have been testing very rampantly in the recent past in many centers. They are going to work out the doses because as it requires less doses, less number of doses and less overall dose, it makes it cost effective and will become a standard of practice very soon. Remember, erythropoietin. Melatonin has lot of advantage. The recent one, you all know, people take melatonin to battle what sickness or, after the flight, you have this sickness. To counter that, they have been taking melatonin. Melatonin has great, this thing, what is that, effects on the brain and the skin, both. But anyway, melatonin, broad spectrum antioxidant and free radical scavenger. It has low toxicity. See, these are one of the important things, and able to freely cross placenta and blood-brain barrier, has anti-inflammatory properties, reduces preterm birth and inflammation-induced neuronal damage. So if given to the mother, it is supposed to be beneficial. Makes it a promising agent for neuroprotection of the fetus and the newborn. It has been tried both preterm and term, antenatally and postnatally. However, optimum dose is still under research. So a combination of melatonin and erythropoietin or combination of darbepoietin and melatonin probably is going to be in our armamentarium very soon with very good recommendation. As they write, melatonin, anti-inflammatory antioxidant, erythropoietin, long-term brain repair, enhancing neuronal and oligodendral survival. So in a combination, they are found to be working very nicely. Stem cells, mesenchymal stem cells, down-regulate pro-inflammatory cytokines, reduce inflammation and apoptosis. It is very easy. During delivery, you just collect the mesenchymal cells, cord-derived mesenchymal cells, and store it. Whether you want to use it or not, you can make a decision. They have found they suppress the upregulation of cytokines within the CSF and periventricular brain regions. And this has resulted in reduction in cerebral edema. Stem cells also stimulate axonal sprouting, proliferation, and maturation of oligodendrocytes. Across Europe, Australia, Japan, and USA, lot of studies are going on, and we hope that even this will be something which we can practice. The whole idea is to prevent brain damage and injury antenatally happening to the fetus and during the delivery in happening, and after that, if something has happened, to reduce its effect and reduce the progression and result in better neurodental outcome. That is the whole idea. Now, we have spoken about preterm babies. Even term babies also have the problem of events that cause neurodental outcome. Hypoxia, HIE, hypoxic ischemic injury, due to respiratory failure due to establish proper respiration, is still the third largest cause of mortality and morbidity even today in the world, especially LMIC, lower and middle income countries, and also in developed countries because of lot of preterm deliveries and in the periphery. Infants exposed to a perinatal insult typically present with neonatal encephalopathy. Now the terminology has changed from hypoxic ischemic encephalopathy. It has come as neonatal encephalopathy. So the contribution of pure hypoxia and ischemia is debated. Is it only due to that? Over the last decade, the sensitizing effect of inflammation has come into picture. It's not just ischemia, inflammation as such, and a person's ability to combat inflammation on his or her own is being investigated. Neonatal encephalopathy, difficulty with initiating and maintaining respiration, depression of tone and reflexes, subnormal level of consciousness, poor feeding and seizures. These are all, manifestations of neonatal encephalopathy as a complex and multifactorial etiology. And recent focus on understanding endogenous neuroprotection and how to boost it or to supplement its effectors therapeutically once the damage to the brain has occurred, as in neonatal encephalopathy, has taken a great importance in research. Strategies that can augment the body's own endogenous neuroprotection is closely looked at. For over 50 years, it has been noted that babies with birth depression have an endogenous cooling response. So that is which made them think, cooling the body and the head, will it help? And as you know, a lot of research has been done, and therapeutic hypothermia is a standard of care in combating neonatal encephalopathy. There are set guidelines, there's a set window period, and a set information that it will help moderate and severe neonatal encephalopathy, may not improve the milder ones. And at 18 months of age, lot of improvement has been noticed, and some of the studies have said that these improvements persist into childhood. This is something which is happening in lot of units, lot of countries, cooling. And as usual, there will be some studies which will say this is not good for this environment. It is not good for low and middle income countries. That is something which is debatable. Cannabinoids. Cannabinoids are now studied in various pathologies, starting from psychiatric, oncology, and it also has a role to play in neonatal encephalopathy. Endocannabinoids are emerging as a potential neurotherapeutic for neonatal encephalopathy. Endocannabinoids modulate the intensity and extension of neurotoxic processes and the inflammatory response, thereby promoting cell survival. So that means it controls apoptosis. Now you have got cannabinoids which can be synthesized, have shown significant gray and white matter protection. The work is still progressing. I feel this is another substance that will come in favor of treating neonatal encephalopathy. As I said, I am a prompt believer in perinatal medicine. That is the liaison between the obstetricians and pediatricians. You have seen in my 2 talks how many interventions we need the obstetricians to help us to help the neonatal outcome. So I started this journal of perinatology when I came back to India in 1996. This year, it has celebrated its silver jubilee. It's indexed in Excerpt America, Scopus, Copernicus, and in February 2025, it will be indexed in PubMed 2. So if you obstetricians, young pediatricians, young obstetricians, you have any articles, you may send to that. And also, when I returned to India at that age, 1996, I felt the poor nurses were left far behind. They had no platform to write. They had no platform to express their views. So I started this journal called Nursing Digest, which is quarterly. It is into its 15th year now, and it's well received. And I request the nursing fraternity also to discuss, write articles, share your experiences, and get empowered. It is the duty of the healthcare industry, including doctors, to empower nurses because they are the backbone of healthcare in any level of healthcare or in any environment in the world. So these are 2 of my prompt and strong beliefs. So if you feel that I have said something which should not have been said, or if you feel that I have not told something which I had to tell, then you can always email me on this number. Hopefully by 72 hours, I'll reply you all. Thank you.
Thank you, Dr. Ranjan, for that informative lecture again. For our next lecture, I'd like to call Dr. Enthal Al-Jashi to the stage. Dr. Enthal is a consultant pediatrician and genetic and metabolic specialist. here in the American Mission Hospital and part-time in the BDF hospital as well, which is the Bahrain Defense Force Hospital. She has over 30 years of experience in pediatrics and genetic and metabolic diseases, with over 20 plus research publications in local and international journals, and is a speaker in major conferences as well. She'll be talking today on neonatal manifestations of inborn errors of metabolism, a case series. Dr. Amsal.
Yes. Yes, doctor. Yes, doctor.
So just to go forward.
Yes.
Thank you very much, Dr. Sen. Hello, everyone. Good morning. So now I'm sure your brain is full of things. So I will take you from, I think I'm supposed to wake you up. I will take you from the action plan that was talked about to real life, okay? And the real life will be in the area of inborn error of metabolism. So the talk is, since the session is about neonate, so I'll take you through some of the manifestation of the inborn error of metabolism during that part of life. And the presentation will be through a case series that I have passed through. So hopefully you will recognize these manifestations when you face patients. So because of the complexity of the manifestation for inborn error of metabolism and interaction between the inborn error of metabolism as a presentation with the various diseases, it might be but at the bottom of the list as usual for taking action based on that. But sometimes basic investigation could lead you to the way. And from that, you will recognize it from these cases. Why is that? Because the earlier the diagnosis, the better the outcome, as you know. So the number, complexity, and the variable clinical presentation of inborn error of metabolism is always a challenge. Prevention of death and the neurological sequelae in these disorders depend on early diagnosis and the initiation of the treatment. That's why the familiarity of major signs and symptoms of these diseases and the basic lab workup is crucial to be recognized. Those who have attended the previous pediatric symposium, probably they remember this slides. This again will take you to the basic concept of the inborn error of metabolism. You all know these are a genetic defect that will lead to enzyme deficiency. This enzyme deficiency could affect the metabolism of so many substances like protein, fat, carbs, mucolipid, and mucopolysaccharide that could happen inside these organelle intercell, mitochondria, lysosome, peroxisome, cytosol, and even you might hear the diseases, the name of the diseases are related to these organelles. And the genetic background varies from autosomal recessive, which is mostly, autosomal dominant, X-linked, and mitochondrial inheritance. To make it very simple, the classification of inborn error of metabolism, we could classify it into small molecule disorders or large molecule disorders.
Small molecules like amino acid disorders, organic acid disorders, fatty acid disorders, urea cycle. Large molecules, lysosomes, storage disease, which involve the mucolipid and mucopolysaccharide, glycogen storage disease, the respiratory chain complexes in the mitochondria, and the peroxisomal disorders, metabolism. I'm bringing this slide again and again to highlight the importance of the neonatal screening program in all around the world, because simple blood tests could save the life. Now, the process is usually in this machine. Now, you should know that tandem mass spectrometry that is used for diagnosis of either inborn metabolism or neonatal screening will not cover all the areas of inborn or of metabolism. It is basically the diagnosis of small molecule disorders. So large molecules, always you will have a normal tandem mass spectrometry. And probably some of my cases will concentrate on that as well. Now, the age of presentation of these disorders varies from a newborn life, actually from, perinatal, till adulthood. Fabry disease is a very well-known disease of inborn metabolism that manifests in adulthood. And of course, in between this line, we have so many diseases that could present in infancy and childhood. So what are the major manifestations of inborn metabolism in the neonatal period? Babies could present as hydrops fetalis, encephalopathy. We have highlighted a lot about encephalopathy today. It could be cholestatic jaundice, baby present as hypotonia. This, of course, plus or minus the presence of dysmorphic features, laboratory finding like hyperammonemia, metabolic acidosis, and hypoglycemia. So let's start with the first case, which is a case of hydrops. This is a case, male newborn, born at 36-week gestation, birth weight 2.7 kg, and Apgar score 5 and 6 respectively. At the third trimester, scan revealed fetal hydrops. There was ascites, scalp, and nocal edema. Baby born admitted to an ICU for respiratory distress. The family were positive for consanguinity. This is the baby face. You can appreciate. He was hydrops because there was ascites, but you can appreciate the facial features, which we called coarse facial features, the breast nasal bridge, broad nose, long philtrum, abnormal eyebrows, hypertelorism. He was having talibus as well, equinovirus, and abdominal exam showed hepatosplenomegaly. With this finding, any newborn, please, you have to examine also the fundus. And his fundus showed, because as a metabolic, we always look for fundus, especially choroid spots in such condition. And there was no choroid spots detected in this patient. But please, all newborns should be examined. Any complex manifestation, fundus is a part of the assessment. Initial lab, because of their hydrops, there are two types of hydrops. We have immune and non-immune. Based on that, so first we look for evidence of hemolysis, and there was no evidence of hemolysis. So the baby was labeled as non-immune hydrops fetalis. Okay, so what are the causes of non-immune hydrops fetalis? This is based on a study done in 2015. 20%, according to this study, no primary cause is found in babies with hydrops. Another 20%, the contributing factor is cardiovascular disease. Chromosomal disorders, 9%. Inborn error of metabolism, according to the study, contributed to 1.3%. Now, if inborn error of metabolism contribute to 1.3%, so what are the diseases in the inborn of metabolism that lead to hydros fetalis. It is basically the large molecule disorder, which is lysosomal storage disease. And there are different types of lysosomal storage disease that could present with hydrops like MBS, mucopolysaccharide 1, GM1 gangliosidosis, Gaucher disease, Niemann-Pick, sialidosis, galactosialidosis, and others. So for that, as a non-immune, and based on the causes mentioned, chromosomal study was done, which was normal. Always, if we are thinking of a storage disease because baby has hepatosplenomegaly, we always look like for a peripheral blood film. Like fundus, peripheral blood film, again, is a very simple test, but it can lead you really to diagnosis of so many disorders. Reported as that there is this is the lymphocyte, and you can see the vacuoles. So this is a vacuolated lymphocyte. The presence of vacuolated lymphocyte, that means there is really evidence of a storage disease. Tandem mass spectrometry, you would expect it to be normal because we said this will cover only the small molecule disorder. Because of this vacuolated lymphocyte and the thinking that this is a storage disease, then the next step we asked for is urine for a mucopolysaccharide and the oligosaccharide. And the finding showed elevated sialic acid, which confirmed that we are dealing really with lysosomal storage disease. So now we have to go for what is exactly that lysosomal storage disease that could be the reason, because some of the lysosomal storage disease currently, there is an enzyme replacement, and the earlier we start, the better the outcome. That's the aim of early diagnosis and early detection. So, you know, I told you initially that this baby has a Talibus equine virus. Skeletal survey was done, and it showed small limbs and abnormalities, irregularities in the metaphyseal joint as well. Skull ultrasound showed periventricular calcification. Echocardiogram as a storage disease has to be done, and it showed a poor function, only of a 25% ejection fraction with the evidence of cardiomyopathy. So we have a disease that it is really multi-system, from dysmorphic features to abdomen to skeletal to cardiac manifestation to blood film, which has abnormalities. So with this, there was an elevation of urinary sialic acid. So this will lead to most probably the diagnosis of a storage disease called sialidosis. And confirmatory tests for this is either by doing enzyme studies, and far advanced, to be 100% sure, we do the molecular genetic testing, which really confirmed the diagnosis of sialidosis in this family. Unfortunately, no enzyme replacement yet for this disorder, but is there a way now to help this family? Yes. Knowing the genetic background, advise the case discussed with the parent for future pregnancy, especially in the presence of consanguinity, for the possibility for doing pre-implantation genetic testing. So all their pregnancy forward, we have done this, and they had 2 normal newborn after this baby. So prenatal implantation genetic testing now is a way to prevent all these disorders. So what is sialidosis? It's actually, we said lysosomal storage disease. It is 2 types, type 1 and type 2. Type 2 is like the one that presented at the neonatal period. Type 1 is the one which had a cherry spot. And I'll show you a picture of the type 1, which looks like, you know, the mucopolysaccharide. This is the picture which, again, is showing you the coarse facial features. I want you to recognize it because really, I receive in my clinic now at PDF very late patients, age 8, age 9. They were wandering around in the health center for, you know, minor abnormalities or whatever, mental retardation. And no one will mention about these four facial features, which really this is the prime for, the diagnosis of these lysosomal storage disease. I'll move to another representation of as an inborn of metabolism at the neonatal period. Cases with encephalopathy, hyperammonemia. This case is published with my colleague Mona. We worked for this patient at the neonatal unit at Salmania Medical Complex. So this case born at 31 weeks gestation, birth weight is 1.5 kg, Apgar score 9 and 10. There was maternal history of a premature rupture of membrane, mom hypothyroid and thyroxine. Baby admitted to NICO for prematurity and rule out sepsis. Second, started on the bottle feed formula. On second day, baby suddenly became hypoactive with skin mottling, developed apnea, seizure, and jerky movement. Examination of the newborn, he had severe encephalopathy, microneck jare, axial hypotonia with peripheral hypertonia. And again, this baby is a product of consanguineous parents. There was a portion and 3 other normal children. So the basic workup, CBC showed probably evidence of sepsis. The WBC is high or stress, I don't know. Electrolyte, normal. Blood sugar, normal. Evidence for metabolic acidosis or alkalosis was not there. And ammonia is very important to be tested for any encephalopathic baby and lactic acid. And the ammonia showed very, very high. So that means there is a condition with high ammonia. Tandem mass spectrometry will play a very major role in the diagnosis. So what are the metabolic causes of hyperammonemia? Urea cycle defect, organic acid disorder, fatty acid, and pyruvate metabolism. These 3 easily could be diagnosed by tandem mass spectrometry neonatal screening. You can see here the pathway from the up-to-date. How to go when you see a hyperammonemia. So first, you look, is it acidosis or alkalosis or normal, like our patient normal? Then you go the glucose level. Our patient showed normal glucose level. Amino acid from the tandem mass showed for us low citrulline. You can see here in the pathway. Then if you have low citrulline, you should ask for urine uric acid. And then if it is normal, the diagnosis will come as carbamyl phosphate synthetase. So what is carbamyl phosphate synthetase? This is related to the urea cycle defect. So this condition, the hyperammonemia, is basically related to the urea cycle defect because you know urea cycle is important to detox the ammonia to be converted to the urea. And in this metabolism of this pathway, we have 5 major diseases, all of them autosomal recessive, except the OTC, which is ornithine transcarbamylase, which is excellent. So what a treatment option that this patient received? So immediately the formula stopped because it's related to the protein that will lead to more of ammonia. And we did started the detoxification for hyperammonemia through hemodialysis, giving the L-arginine, sodium benzoate, all this to play a role in decreasing the ammonia. And there is this magic drug, which is called Carbaglu. It acts at the first step of the urea cycle defect. And you can see, because this case was published, you can see the effect of Carbaglu. Once it started, immediately ammonia level came down. And luckily, this patient at the age of 4 months, because this is the best option for treatment, patient was sent for liver transplant. Now he is 7 years old and attending school. Third manifestation, hypoglycemia. Very common in the neonatal period when you deal with a newborn, you will find hypoglycemia. For, to define it, to look for a cause, in particular, like endocrine or metabolic, the level should be 2.2 millimole or less than that after 74 hours of life. That is the definition. So the case, again, male patient, product of full term, birth weight 2.8, Apgar score normal, presented at the age of 2 days with history of lethargy, vomiting, reducing feeding, activity, and respiratory distress. Again, consanguineous marriage. And this is the first baby in the family. Examination, he was irritable, hypoactive child. He was hypotonic, heart sounds were normal, and there was no organomegaly. So blood sugar was taken, because of the lethargy and all these things, and the finding, and it showed that very low blood sugar. This have been repeated, and still the blood sugar was low. So that means mainly we are dealing with a condition that is related to hypoglycemia. The ammonia was relatively little bit high, which is fine. And you notice here, usually when you have a hypoglycemia, what should be high to compensate? For the brain, we are talking about any brain. Ketones, yeah? Look at here. The blood sugar is very low, yet there is no ketones. So what are we dealing with? Non-ketotic hypoglycemia. Mainly, where is the problem? Doctora, President, Arab board, huh? The Karim? No? Okay, it will come now, the answer for you. Lactic acid was very high, and CK very, very high. So that means there is a disease that involves muscle and involve the glucose metabolism and no ketone. The diagnosis should be very obvious. How to go with hypoglycemia at that level or below, which is 2.2, as Dr. Salah mentioned. So we label it as either ketotic or non-ketotic. That is to make your life easy. If there is ketone, you will go into these diagnoses: sepsis, gastroenteritis, growth hormone deficiency. From the inborn of metabolism, some of the organic acid, glycogen storage disease, galactosemia, or fructosemia. If it is non-ketotic, you will go again for endocrine. That's why me and Dr. Khadija always we work together when we are in Salmania. We have a protocol for hypoglycemia. You check the insulin, and you look for panhypopituitarism and adrenal insufficiency, and from the inborn of metabolism, fatty acid oxidation defect. So how to approach, again, hypoglycemia. This is again from the up-to-date. So we said ketosis, no ketosis, our patient no ketosis, normal lactate or high lactate, our patient has high lactate. So this confirmed immediately the diagnosis of fatty acid. Since it is a small molecule, tandem mass spectrometry should help you immediately for the diagnosis. And yes, the tandem mass spectrometry result showed a fatty acid oxidation defect, mainly related to the very long chain acids because of the, this carbon 14. That means you are dealing with the very long chain. So that is the newborn. And now this is from last year. They were celebrating in Salmania. I took the picture from government side or the Salmania side at the Instagram, because they were celebrating the rare disease day, and I saw him because I was following him. This is him now. He's in a very good health. He was 9 years last year and attending school. Everything is good with him. And the treatment is very simple, because if this patient was not detected at the neonatal period, he could have died. So just simply high carb formula, MCT, of course, avoid fasting, and carnitine supplementation if carnitine is low. So fatty acid is usually related to the mitochondrial metabolism. I will not take you into this. But how you recognize them clinically? There will be hypoglycemia, because there are various types, enzyme. What are the major manifestations of these fatty acid? Hypoglycemia. Some of them, they have liver dysfunction, cardiomyopathy, skeletal myopathy, like in this patient, very high CK, rhabdomyolysis, like in our patient. So it's basically a disease of muscle, brain, and liver. Last case or last presentation, and not the least, of course, the area of encephalopathy in relation to the inborn of metabolism and the other manifestations, especially the skeletal dysplasia, is huge. And last symposium, I think we presented about the bone disease related to the inborn of metabolism. So prolonged jaundice, because you might face it often, especially at the baby's follow-up at the health center. So could it be related to the inborn of metabolism? Let's see. So this is a 3 weeks female newborn referred from the health center for prolonged jaundice. She was a product of full-term vaginal delivery, non-consanguineous parent, birth weight 3 kg, breastfed, no vomiting or hyperactivity. Then you have to come to stool. Stool, very important, because this would take you to the two paths, obstructive, non-obstructive. Stool is normal, so we are not in the obstructive bath. Examination, ecteric baby, normal muscle tone, liver is 2 centimeters, red reflex is there. Here again will come the eye examination, very important, looking for any accumulation of this sugar in the eye. So red reflex was normal, so galactosemia. And no abnormal smell of urine. As a metabolic, we always ask the nurses, the units, please smell the urine, smell the urine. This is very important. Don't take it lightly. So we have a baby with a prolonged jaundice, failure to thrive, normal stool color, and normal feeding pattern. So how to proceed? The usual things. CBC, it showed low platelet, 90 only. So there is a thrombocytopenia. Electrolyte were normal, blood sugar normal. Look at the LFT. LFT showed mainly direct hyperbilirubinemia, 30% of the total bilirubin, elevation of the gamma GT, and abnormal coagulation as well. So we are dealing with a case with direct hyperbilirubinemia and abnormal coagulation. So what are the metabolic causes? I will not go into all the causes of cholestatic. I'm concentrating in the metabolic causes of cholestatic jaundice in the newborn. Again, either with hepatomegaly or liver failure. Like in our case, is mainly there is liver failure and there is no hepatomegaly. So we are in this category, either galactosemia, hereditary fructosemia, tyrosinemia, type 1, fatty acid oxidation defect, and mitochondrial respiratory chain defect. Tandem mass spectrometry showed elevated tyrosine and methionine. So are we dealing here with tyrosinemia case? Or probably because liver dysfunction could lead also to high tyrosine. So high tyrosine doesn't mean always tyrosinemia. What confirmed the tyrosinemia? You ask for urine, succinyl acetone, and it was positive. So that means we are dealing with tyrosinemia type 1. Tyrosinemia, I would like to tell you, because I had another case referred from KHUH when I was at Salmania, and he was referred mainly to the clinic because of intractable rickets. They were giving vitamin D, no benefit, no change in his rickety changes. So he was referred to actually to our general pediatric, and the general pediatric referred to us. And so rickets could be a manifestation of tyrosinemia, because you know tyrosinemia affects the liver and affects the kidney. So like fatty acids affect certain organs, tyrosinemia affects liver and a kidney. And rickets, intractable rickets, especially not responding to vitamin D, again, you should think of underlying metabolic disease. That's why I'm showing this picture. This is not our patient. This is from the internet. So tyrosinemia type 1, so we said it could be liver, it could be rickety changes, it could be kidney as a renal tubular acidosis. And just to remind you about the metabolism of the tyrosine, that it comes from originally the phenylalanine. Now, I think now for the past 20 years, because this is one of the first drugs introduced for the treatment of inborn of metabolism, which is nitisinone, that block this way, because all the defect in the tyrosinemia is from the last step, which is the accumulation of the fumarate acetoacetic acid that leads even to, if tyrosinemia is treated to carcinoma of the liver. So patient started in nitisinone. This is the nitisinone. And the mother was advised about liver transplant. We use it a lot for, inborn metabolism, and we have a collaboration with the Indian Center. Most of our patients, by the way, they go to India, and we published our paper collaboration with, maybe you'll see it. If you look at my name, you will see. Unfortunately, this mother escaped, and then after, few years, I know that she is following up at the private, one of the private clinic, but she missed the treatment of liver transplant because, with the nitisinone, again, you have to have the diet control, measuring this, measuring that. While liver transplant, if it's successful, alhamdulillah, khalas, successful. So now this is the showing you the effectiveness of liver transplant for such disorders, for this disease. So the key messages from the talk: metabolic diseases are a significant cause of illness in the newborn and should be considered in any newborn if the clinical presentation is out of the proportion to the most common cause. Manifestation mostly, but not exclusively, present after the 24 hours of life, and the presentation variable. Babies with unexplained encephalopathy requires urgent ammonia, glucose, lactic acid, and CK. This is a baseline, should be at all neonatal unit. Tandem mass spectrometry is diagnosis, but this will not cover all the disease as I mentioned. And index of suspicion is crucial to early diagnosis and treatment. And thank you very much.
Thank you, Dr. Mtita. Thank you, all the neonatal topic speakers. We will have a panel discussion. May I invite Dr. Athar, the moderator of the session, to come over to the stage also, please. Global perspectives, local impact. That happened to be the theme of our CME today. And we have indeed done justice. We had two speakers, one speaker talking to high impact topics, Dr. Ranjan, who covered a wide gamut of neonatology problems. We had Dr. Mtita talking about inborn errors of metabolism, its perspective in neonatology. May I invite Dr. Ranjan to come over to the stage? Dr. Mtita is already on stage. Dr. Mona Al-Shafiri.
So I apologize because she had a workshop and she has to run away.
So okay.
Okay.
Dr. Mona, who had the second talk, is not available. We will have Dr. Ranjan covering her topic queries also. Dr. Athar, can you please come over to the stage? I invite Dr. Athar to moderate the sessions. Can you please get started with the discussions? We'll have the audience query first, and we'll coordinate with the audience in India. If they have any queries, we'll have them over the podium. I think we will touch base with the audience in India while Dr. Athar can start the session in the meanwhile.
Thank you, Dr. Vandita, for inviting us to the panel discussion. Thank you, Dr. Ranjan. Thank you, Dr. Iqbal, for your wonderful presentation and up-to-date although our audience may not be fully practicing neonatology, but some questions, because we come across deliveries and some babies might complicate. So these topics are important to cover in our day-to-day pediatric practice as well. Any questions from our audience for Dr. Ranjan?
Yeah. Can anybody coordinate with handing over the mic in the audience? Thank you, Dr. Sinha.
May I suggest that what is the current status as regards, you showed how useful newborn screening can be. What is the latest status in Bahrain to begin universal newborn screening?
Thank you very much for very important questions. Situation in Bahrain. Thank you very much again for your question. We tell you about the good thing. The good thing is that now I can see that most of, not all, private sectors are doing it on a routine basis, using the tandem mastectomy, including the American mission hospital. When it comes to the government sector, unfortunately now, covered diseases are not covered. What's being done only it covers for hypothyroidism and partially for cystic fibrosis as well. But the tandem mastectomy as a related screen is not done. BDF, they are pushing really very hard now, and like all the babies at the neonatal unit, blood will be collected, and I think they are going in the future. That will be done for all the newborn. Now, I would like to mention that people now are moving forward. Those still we are talking about neonatal screening, but now people are talking about genome. Genome as a neonatal screening program for all the genetic diseases. And actually, there's an application came from Dubai, because Dubai started this project since last year. And from this project was a very successful project, and they detected so many, especially those with the neurodevelopmental disorders where there's no cause found. Diseases have been detected. So especially in relation to the autistic features, and I think I found it so useful because especially when it comes to the autism, which is increasing, we are seeing day by day so many cases. Early intervention for this type of children are very important, and the best way to detect if it is related to genetics, which contribute to 20 to 30% of autism, it will be very beneficial.
Thank you, Dr. Imtitan. Would like to hear Dr. Ranjan's opinion about the same problem. What's the status in India regarding newborn screening?
As far as neonatal screening is concerned in India, basing on the context of the population and the two-system healthcare there is government sector and there is private sector. And in private sector, there are small private sector hospitals and corporate hospitals. Now, all the corporate hospitals now have resorted to all babies for PMS and a mastectomy. Government sector, I'm happy to say, all the hospitals are doing thyroid screening very religiously. And many of the hospitals in between, including some of the government sector, are doing what we call as abridged neonatal screening. In the sense, 4 or 5 conditions, which are glucose, galactosemia, adrenal hyperplasia screening, and thyroid, and glucose 6-phosphate dehydrogenase, and one more is 4 or 5 they do, either cystic fibrosis or whatever is relevant in that area. Could be even thalassemia for that matter. So screening is picking up, and I can say that thyroid is 100% throughout the country, abridged in most of the hospitals and corporate hospitals, the platinum mass spectrometry. Genome, at the moment, they are only reading. I know in due course, that will also be thought of. Because whenever a universal screening has to be done, like universal immunization program, the budget has to be there. So we have to look at the budget, and once we start, we have to maintain, not stop it or interrupt it because of various reasons. So this is the situation, and I'm sure very soon, and because when you do investigations more in number, the cost goes down. So that is something which we have realized, and let us see, it should be TMS for the whole population very soon. Thank you.
Thank you. Dr. Hatta, would you have some
Like
questions?
Dr. Paul, you're talking about antenatal antibiotics. A lot of others here, we have like previous screening is very common in this setting compared to India because other pathogens bacteria are dominating. So one of the most important things is maternal fever. That's an indication, intrapartum maternal fever, that forces probably wives to start antibiotic for the mother. So what is that take for you to cover the mother antibiotic if the mother is in intrapartum fever? Because that has a lot of significance for us as well as the brain is also concerned and early onset sepsis is concerned.
Yes, I agree. The moment mother has fever, we are more worried about chorioamnitis. And chorioamnitis, we know, is very commonly associated with preterm onset of labor and birth of a preterm baby. So the obstetrician will have to judge by lab testing and other things whether this could be a real infection. So you should remember a pregnant mother can also catch common viral infection and have just fever. It's a very difficult situation, but the awareness that antenatal antibiotics are dangerous, one should be very careful. And especially there is no use in starting a mother on a broad spectrum antibiotic. You concentrate whether it is due to genitourinary infection or respiratory infection or viral infection. And chorioamnitis also has other features which you can laboratory-wise or clinically diagnose. And depending on these are the 4 things which can cause fever. We'll have to treat that. But only thing is we should be conscious that if we feel that it is not treatable fever, then don't waste time, resources, and inflict the danger of long-term complication on the fetus and the newborn by giving antibiotics.
Thank
Clarified some aspects.
Thank you all for your panel discussion. In the interest of time, and I know we're going over by about half an hour or so. We'll just end the discussion here. Dr. Ranjan, Dr. Imtithal are available throughout the whole of the session today, so you can please catch them in between. I will now stop for a coffee break. The coffee break will be up in the 5th floor, and we'll reconvene back at 11:30, please. All right, so thank you for all the panelists. Thank you very much.
Thank you.
Thank you. And Phoebe lunch se pehle. Thanks. I'm going to give you again. Thanks. Thank you. Thank you.
Have some of the speakers. Thank you very much. No. I hope it was useful. I don't know.
It's being blurred. So my card across.
Hello.
Hello, check.
Hello. Hello. Testing. Hello. Testing.
സ്പീക്കർ ഇത് മൈക്രോഫോൺ മാറ്റി
മൈക്രോഫോൺ മാറണം.
മൈക്രോഫോൺ
ഇല്ലായിരിക്കുമല്ലോ. ഇത് പോരാ. അത് തന്നെ മൈക്രോഫോൺ റെക്ടാങ്കിൾ ലൈറ്റ് ക്യാമറ ഓഡിയോ. ഇതാണ് ഇതിന്റെ
പോഡിയത്തിന്റെ അതാണല്ലേ. അപ്പൊ ഇത് മാറ്റിക്കണം. ഇതിനകത്ത് സ്പീക്കർ
സ്പീക്കർ ഇതുപോലെ നമ്മുടെ HDMI എന്നല്ലേ വന്നെ. അതല്ല
ഇപ്പൊ ഔട്ട് പോകുന്നത് HDMI വഴിയല്ലേ പോണേ.
അതെ.
Hello, check.
ഇത് എടുക്കാം.
Hello, check.
അല്ലേ?
I give the presentation to Joel. It is there.
Joel, okay, let's have a look.
Which one?
Respiratory emergencies.
Yeah, one is respiratory.
Antibiotics, both of them. Save.
Up.
Shift. Take it one by one. Just mute the audience. Mute the audience.
Hello, testing. Hello, testing.
All right, welcome back to the second session. I think everybody is congregating outside there. I can see them all. So they'll all be joining us shortly. I think once I finish my intro, they might be here. Right, so for our next session, I'll call Dr. Basavraj first. Dr. Basavraj is a professor of pediatrics and in charge of the PICU in the Indira Gandhi Institute of Child Health in Bengaluru. He's held multiple national and state level positions with the IAP, and of course, the latest feather being the national president for this year. He's the recipient of the Eminent Doctor Personality Award in 2024 by the National IMA Headquarters, New Delhi, and also the recipient of the Doctor Day Award by IMA Karnataka in 2020, and the recipient of the Fellow of the IAP in 2017. He's the recipient of many honors, including the Dr. Tapan Kumar Ghosh Memorial Oration in 2024. He's had multiple research articles, 37 plus, in national and international journals, including the latest in the BMJ in 2024, which was related to the COVID-19 related disruptions in routine vaccination services in India. He's also on the editorial board for the Journal of Pediatric Infectious Diseases, the Journal of Pediatric Critical Care, Indian Pediatrics, and the Karnataka Pediatric Journal. He's also on the National Advisory Board of the Indian Pediatrics for a number of years. And he has done extensive and multiple community outreach programs nationally. His first topic today would be respiratory emergencies in children. So Dr. Basavraj, if I can invite you to the stage, please. Yeah. Yeah, so just this way. So if you go forward, maybe this one, backwards.
Yeah, fine.
Fine.
Thank you so much, Dr. Sana and Dr. Vanita and all the team members of our IAP Bahrain and AMH especially for organizing this wonderful CM. So what I'll be discussing for the next 25 to 30 minutes is about a common problem. In the first session, we have discussed about neonatal issues. We will be taking you towards a general pediatrics and pediatric respiratory emergency. This is one of the commonest thing across the globe, even in India too. The objective of this presentation will be how do we recognize a respiratory distress in an emergency, and how do we differentiate between the respiratory emergencies, especially distress and failure? There is a thin line of a demarcation. How do we differentiate that? And the difference between the upper airway obstruction and lower airway obstruction, and what is urgency, what is emergency. That's what my presentation will be focusing on to this. When we talk about recognizing a respiratory distress, most important thing is the respiratory rate. This has been globally accepted by the WHO and UNICEF. When we talk about the rate, if the less than 2 months of age, it is 60 and above. Between the 2 months to that of 12 months, this is 50 and above. Between 12 months to that of 5 years, it is 40 and above. As an healthcare professionals, whether you are an intensivist, pediatrician, or you are taking care of a child in an emergency, this is one of the important clinical parameters which helps you to differentiate. Of course, apart from that, what we need to look at it is a retraction. Is it a mild, moderate, and severe retraction? That helps you to differentiate between the severity of the respiratory distress. The another important thing when we are dealing with a child coming to you in an emergency is we need to look at the sound the child is producing. Depending upon that, we can recognize where exactly the pathology in this. Suppose if the child comes with a snuffling sound, that means your pathology and airway obstruction is at the nasopharynx. If the child which is having a snoring, you are most likely it is the pathology in the oropharynx. If the child which is having a stridor, that indicate that this is the child which is having a laryngeal pathology or trachea. If there is an abnormal sound and rattling sound, that indicate this is the commonest thing in an infancy. That indicate that the child is at the carina pathology. And if there is a wheezing, it is a bronchial tree and grunting that indicate that this child is having a parenchymal pathology or a pleural. Just by listening to the sound the child produces in the background of a respiratory complaint, you can be able to recognize where exactly the things. Another important objective of my presentation, I say, how do we differentiate the respiratory distress from the failure? This is very important as a practicing clinician because if the child comes to you with respiratory complaint, just look at the level of consciousness. If the level of consciousness is normal, this child most probably is still in respiratory distress. If there is increased rate with retraction, that indicate that respiratory distress. If there is a level of consciousness is disturbed in terms of if it is an anxious child or a lethargy, altered level of consciousness, that indicate that this is the child which is slipping from respiratory distress into the failure, where as a clinician, you need to have an urgency, where you need to act very quickly. That's why your level of consciousness is very important when you're talking about a child with respiratory complaint. And of course, air entry, you need to look at the air entry. Is it decreased or it is severely decreased? That is also another important thing. What really the COVID-19, which is really changed the whole scenario in the thing is SpO2, whether it is a developed country or a developing country, or is it a clinic, or is it in a small hospital, the SpO2 things which is freely available across, just look at the saturation. If the saturation is anything less than 94%, this is the child which is respiratory distress, which is slipping into the respiratory failure. We need to act very quickly. That is where we change. With this clinical background, let's move on to the few clinical cases, what we all get it in an office practice. This is an 8-week-old male child, came to our emergency department with a noisy breathing for a 1 week duration, an exclusively breastfed baby and gaining the weight normally. That's very, very important. This child is gaining the weight normally. So as far as the diagnosis is concerned, whenever the child which is less than 1 year, which has been developed in an IC breathing at the age of 2 months, within a gaining the weight normally, feeding well. So your diagnosis is certain. It is a case of a laryngomalacia. Well, the laryngomalacia is one of the most common cause of a stridor in infancy. Usually onset is around 2 to 3 months, 6 to 8 weeks of age, and peaks around 6 months, settles down by 1 year. That's the natural course of a disease. But in some cases, this laryngomalacia can be there for a period of 2 years. That's what we need to know, the exception. But apart from laryngomalacia, if the child comes to you with a noisy breathing, what are the other things as a clinician we need to look at it? One is laryngeal wave, laryngeal cyst, laryngeal papilloma, subglottic stenosis, and vascular ring, subglottic hemangioma. These are the other congenital causes we need to think about, because younger age group, we always think about something which is related to the airway. So where the congenital causes is a more likely thing, on vocal cord paralysis in case if there is a change in the voice and all. Most of the time, laryngomalacia things resolves. What it requires is a good counseling and tell about the natural course of a disease and pro-nursing. That's the thing which all requires is. Apart from that, it doesn't require anything. Previously, we used to think about supplement the calcium and all. It has no scientific reason to think all those things. But as a clinician, there are a few exceptions to these things where once in a while you may come across is if the child is having a severe respiratory distress, if the child is having a dyspnea with pulmonary hypertension, obstructive sleep apnea, that is the time where failure to thrive the moment failure to thrive with an icy breathing, think other than laryngomalacia. That's the standard way of thinking. But severe laryngomalacia, once in a while, can present within a failure to thrive. You need to keep it in your mind in that situation where we need to think about a surgical intervention. Otherwise, your thing is just counseling. That's about nice breathing in an 8-week-old child coming to you without failure to thrive, gaining weight. That's how you need think about it. That's one of the common pediatric emergency getting. Let's move on to this other thing. This is a 5-year-old child comes with a cough and rhinorrhea for 2 days and difficulty in the breathing, change in the voice. The moment the change in the voice with noisy breathing, it indicates that there is a larynx is involved, there is a trachea is involved. That's what we need to be. On a clinical examination, this child is having a tachypnea and inspiratory stridor and respiratory distress with retraction. Air entry is bilaterally equal. As far as the diagnosis is concerned, it is certain. Diagnosis is not at all issue. It's a case of acute laryngotracheobronchitis, what we call it as a croup. This is a diagnosis, is no issues. What are the issues as a clinician we are more worried? How do we assess the severity? Just depending upon the severity, we are going to decide whether we are going to treat this child on an OPD basis. Are you going to treat on an emergency basis? Are you going to treat this child in a PICO? That's how you are going to differentiate it. And admission is the thing. And apart from that, management issues we'll discuss. These are the 3 things we. As far as the severity is concerned, Wesley score, this has been well accepted by across the globe, where we need to look at the level of consciousness, whether it is this child is normal, including sleep, or is it depressed. We need to look at that. And the cyanosis is another thing, whether it is cyanosis is there upon hesitation or rest, depending upon that you can score that. Inspiratory stridor, is it there at the rest or on hesitation? Look at the air entry, is it decreased or mild or moderate or severe decrease in the air entry, retraction of the chest. These are the 5 clinical parameters. Quickly assess in your things and decide whether it is the thing. If the score is anything less than 2, what does it do? 2 or less? How does the clinically child will be? Occasional barking cough will be there, hoarseness of voice will be there, no stridor at rest, and retraction may or may not be present. If the score is between the 3 to 5, that indicates that a moderate group where the frequent barking cough will be there, audible stridor you can see at the rest, visible retraction, little distress on hesitation. That's the time where the score is between 3 to 5. It is a moderate group. Severe group is a 1. If the score is between the 6 to 11, how does clinically child look? It is a prominent inspiratory stridor throughout the inspiratory phase, sometimes in the expiratory phase, and the frequent coughing, chest retraction, and the decreased air entry and auscultation, significant distress, and child most of the time it will be agitated. That's where we'll say it is a severe retraction. If the score is more than 12, that indicates that this is a child within a respiratory failure where the most of the time saturation will be less than 94. So next important, once after assessing the severity, it is a mild, moderate, and severe group. The next immediate question is, as a clinician, we need to decide how do we manage this case? What is the thing? When you look at the drugs which can be used in an acute laryngotracheobronchitis, dexamethasone is a well accepted across the internationally. Single dose of dexamethasone, 0.6 milligram per kg, IM, intramuscular, that prevent the most of the child getting admitted if you use it in mild to moderate. I'll discuss about those things. And if the child is not able to, if the parents are not willing to give an injectable, that's the time where you can consider an oral prednisolone, 1 to 2 milligram per kg. You can give it for 2 to 3 days. Inhalation budesonide is one of the well accepted thing, especially is group is concerned. That's the thing. Suppose if the moderate to severe group, that's the time where we'll give an adrenaline nebulization. You can give it normally available adrenaline. You need not to think about racemostic. If you available racemostic, it is fine. Otherwise, normal adrenaline. 0.5 ml per kg, maximum of 5 ml. There are 2 things which is very important when you're talking about an adrenaline nebulization. One is tachycardia and hypertension. Even though theoretically it has been reported, we using it practically, there is no issues which is related to that. And the other common mistake, what we do it as a practicing pediatrician is, if the child is agitated, we'll try to give a sedation. Sedation is a contraindicated because basically here the child is irritable because of hypoxia. You need to address the hypoxia. Once if you address that, that's good enough. That is why no need for a sedation. To summarize, the group management is concerned, if it is a mild group, that is score of the Wesley scoring system, it is 2 or less. What we need to give it is, in this child, you given a good nebulization within a Budicard, and you can give a single dose of methadone. So when you talk about single dose of methadone or dexamethasone in a mild group, there is a lot of debate on that, whether to give an injectable dexamethasone in a mild group. Answer is, looking at the risk and benefit. So Indian Academy of Pediatrics recommends you can go with a single dose of a dexamethasone. That's what we have debated. Finally, we accepted. Let's give in a single dose of a dexamethasone, even in a case of a mild group, where the benefit still outweighs the risk. So that's one of the important things. The second important thing is, in case of a moderate group, what it requires is a humidified oxygen and requires a steroid. And the most of the time we need to maintain a good hydration status. These are the children where the electrolyte imbalance and dehydration is the thing. Keep the good hydration. That's more important in the case of a moderate respiratory distress. And if the child improves it, you can wait for after giving an adrenaline nebulization, a rebound effect can be there, because adrenaline nebulization effect will be last for only for 4 to 6 hours. You need to observe the child in an emergency for 4 to 6 hours before sending them to the home, because sometimes rebound effect can be there. That is what we need to see. If the child is making an improvement after 4 to 6 hours in emergency department, you can send them to the home, depending upon. If it is not making an improvement, where you need to admit into the intensive care unit, where you need to admit the child. And one of the important thing is, these are the childs which will develop in severe group, where the hypoxia, you give a good amount of oxygen, IV fluid, and adrenaline nebulization and steroid, and be prepared with a tracheostomy. So why this is very rarely it requires a tracheostomy if you follow the protocol properly. So very rarely it requires, but you should be, because airway is likely to compromise. If if the patient is hypoxic and if the child is not making an improvement, that's the time where your difficult intubation, you can anticipate it. If you fail in intubation, where you need to go for a tracheostomy, that is it. There is no role for antibiotic, because most of the time your group is caused by either a viral infection. Generally, it does not require any antibiotics. That is the other thing. What Dr. Ranjanji was talking about, rational use of an antibiotic and rise of a non-communicable diseases in the morning. So we need to restrict and emergence of a drug resistance into that. So to summarize, the look for the causes of respiratory emergencies in upper airway, it could be croup is one of the things we have discussed. Bacterial tracheitis is not a common thing. Once in a while, you can get in a case of bacterial tracheitis if the child is toxic, with a stridor, with a change in the voice. So that's the time where you think about bacterial tracheitis as the thing. The commonest cause for bacterial tracheitis is a streptococcal infection or staphylococcal infection. This is the time where you require an antibiotic. Otherwise, in a group, doesn't require an antibiotic. Retropharyngeal peritonsillar abscess, especially if there is abnormal neck movement with a throat examination, that's the time where you can pick it. Anaphylaxis itself can present like in respiratory emergencies in terms of an airway obstruction and wheezing, especially following a vaccination and following an insect bite, following an allergy, where you need to be well equipped to address the anaphylaxis with an injectable adrenaline IM. It is not subcutaneous, it is an IM. 0.01 ml per kg, maximum of 0.5 ml. You can give it if the weight of the baby is less than 10 kg, you can give it 0.3 ml. If the weight is more than 10 kg, you can give a 0.5 ml. Anaphylaxis, injectable, adrenaline intramuscularly is the drug of choice. And of course, infectious mononucleosis in school-going children, we need to be foreign body. I discussed it in respiratory papillomatosis and epiglottitis. following an introduction of a vaccination of an H influenza coverage. This H influenza is not a common thing. Epiglottitis, we rarely see epiglottitis. So what are the clinical marker when the child comes to you in the emergency department or in your OPD? If the child is having any choking, gagging, difficulty in the swallowing, think about foreign body is the cause for the respiratory distress. If the patient is having any facial swelling, skin and mucus involvement, with the involvement of a cardiac or a GIT or respiratory, wheeze and all, think about anaphylaxis in the things. If the child is having irritability, neck stiffness, poor feeding, think about retropharyngeal abscess, muffled voice, trismus, and palatal cellulitis, bulging mass on the examination of the pharynx. Think about peritonsillar abscess. And if there is a bleeding and bruising, subcutaneous emphysema, think about the trauma. If the child is having an high-grade fever, toxic appearance, respiratory distress, change in the voice, think about bacterial. These are some of the clinical clues where quickly in an emergency department or in an OPD where you can, these are the pointer towards that. After discussing about the upper airway respiratory emergencies, let's move on to the lower airway. So this is a 1.5-year-old girl presented with a fever for 3 days, cough for 3 days, and child is having a respiratory distress and clinical examination, tachycardia, tachypnea with heart rate of 128, respiratory rate of 68, and chest retraction. Look at the saturation, it is 90%, less than 94%. So hyperresonant lung field. This is one of the common thing what we all come across. That as far as the diagnosis is concerned, absolutely there is no thing. It is in a case of a bronchiolitis. So whenever you talk about a bronchiolitis, of course, now with the invention of our monoclonal antibodies, using a monoclonal antibodies to the, especially preterm, congenital heart diseases and immunosuppression, where the presently what we are using a monoclonal antibody for RSV, it has prevented the number of cases of RSV. But in India, we still see a lot of cases of bronchiolitis because we do not use a monoclonal antibodies what it has been used in developed countries. So in that case, if you come across with an RSV, how do we address this bronchiolitis? So oxygen is then one of the most important thing, humidified high flow nasal cannula. This is also following a COVID-19. Across the globe, one of the good thing, if you look at the positive outlook of a COVID-19 is a use of humidified high flow nasal cannula, even in a smallest setting where the humidified high flow nasal cannula can be used even in wards, emergency, not necessarily it is an intensive care unit. This is one of the common thing we can use it. That prevents the need for an invasive ventilation. Almost we have done a study in our institute where the need for mechanical ventilation has gone down dramatically, more than 40 to 50% of the percent. And what is other important thing is once you start an humidified high flow nasal cannula, you need to monitor this child. Continuous monitoring and reassessment is the need of the hour. And trial and error method. Adrenaline nebulization, it is not well accepted like in a crow book, where it is an accepted thing. Here, you can try adrenaline nebulization. If the child makes an improvement, continue. If the child doesn't make an improvement, just take it out. Bronchodilator, it is a double-edged sword. The moment you use a bronchodilator nebulization, what really it happens is already bronchomalacia is already existing, not like in hyperreactive airway disease where the bronchospasm, here the bronchomalacia, further worsening can take place. But still sometimes we give a trial. If some patient makes an improvement, we'll continue the bronchodilator. Otherwise, we need to take it out. The message is bronchodilator is a double-edged sword. You need to be very, very careful if you are using in a bronchiolitis. And of course, 3% sodium chloride is a thing where nebulization can be done. If the child makes an improvement, you can continue. I told you it is a trial and error method, whether the adrenaline nebulization, whether it is a bronchodilator, whether it is a 3% sodium chloride or 20% mannitol nebulization. All these things are the trial and error, where the few papers are there on this, where you can try those things. And role for antibiotic. When you talk about anything, bronchiolitis is RSV is the main thing, where you can try the ribavirin, but not in a routine thing. but otherwise role for antibiotics is concerned doesn't exist. Ribavirin is the one thing where you can try if you are comfortable and that. That's about the bronchiolitis is one of the common lower respiratory tract emergencies we come. Let's move to the second thing. This is a 6-year-old boy presented with the OPD with an high-grade fever and cough for 2 days, right-sided chest pain and difficulty in the breathing. And the 6 years respiratory rate is 42. There is a tachypnea with retraction. Saturation is 92%. Crepitations on the right side of the lung. When you look at the diagnosis in this child, as far as the diagnosis is concerned, respiratory symptoms with tachypnea, you doesn't require any chest X-ray, you doesn't require any auscultatory finding, respiratory complaints with tachypnea, unless otherwise post WHO and UNICEF, even in a developed or developing countries, it is a pneumonia is the thing, community acquired pneumonia. So does it require any investigation? Answer is to diagnose a community acquired pneumonia, it doesn't require any investigation. But if you have an counts like a CBC, if the counts is anything more than 15,000 with the polymorphs of more than 10,000, if the peripheral smear is showing a toxic granule, band param, shift to the left, what does it indicate? Most likely pathology is in a bacterial where I can think about an antibiotics and all. And ultrasound is one of the most important thing nowadays. It is ultrasound is like a stethoscope in the emergency department and the OPD and the ward, where you can use a USG chest to look into the diagnosis of a pneumonia. Chest X-ray, if you're anticipating complications like either it could be a pleural effusion, it could be a consolidation or a pneumothorax. That's the time where you can. But what is more important is your respiratory panel. Look for what the etiological agent in this child. Your respiratory panel is one of the important thing, especially to look for the blood culture. Only 5 to 10% of the cases of a pneumonia, you will get a blood culture thing. And treatment wise is concerned, it is the O2 inhalation because this child is having a saturation of 92% with the distress, requires an oxygen. Of course, you need to maintain IV fluid. As far as the antibiotic is concerned, it all depends upon the age of the child. If the age of the child is less than 2 to 3 months, you think about covering a gram-negative along with the gram-positive, where we go with an amoxicillin along with an aminoglycoside. If the age of the child is more than 3 months, amoxicillin is good enough. If amoxicillin is not available, you can give amoxicillin with the clavulanic acid. Still, when you think about the bacteria, it is a streptococcal pneumonia. Even though universal immunization is covered, still the streptococcal pneumonia is a common thing. You think about amoxicillin. What about macrolides? Macrolides generally we don't use in a routine clinical practice. Whenever you have any extrapulmonary manifestations, like if you have a skin manifestation, if you have a joint involvement, if you have a child with the symptoms are more and not toxic, the school going children, that's the time where we think about macrolide routinely. We don't use a macrolide as a routine things in the community acquired pneumonia. That's about the community acquired pneumonia is the other respiratory emergency we come up. Let's look at the other respiratory emergencies. We get it in a clinical practice. This is a 13-year-old girl presented with a severe cough, difficulty in the breathing, a known case of an asthma with a family history of an atopy. So on clinical examination, tachycardia, tachypnea with a retraction. And when you look into the clinical examination, apart from that, there is an extensive bilateral wheeze and saturation is 88%. And the diagnosis is concerned since there is a family history, there is a wheezing and a known case of an asthma, it is an acute exacerbation of an asthma. Once we talk about acute exacerbation of asthma, what are the management issues we cover? Any patient with respiratory distress, with hypoxia, first and foremost thing is go to delivery. That's the very, very important. Oxygen is the first drug which needs to be given. So in this patient, this child is a bilateral wheeze. Bronchodilator is another thing, which is when you talk about the bronchodilator, what is the bronchodilator? We can use it. Salbutamol and ipratropium bromide. These are the two things which is available. So what we use generally is if it is a mild exacerbation, you can go with a salbutamol that is 150 microgram per kg, maximum of 2.5 milligram. Only thing either you can give it with a continuous nebulization or you can give it with 20 minutes interval, you can give it. So you can go. Or basically when you are talking about an bronchodilator delivery, you prefer to go with an MDI, meter dose inhaler, in a case of a mild to moderate. Better to avoid a nebulizer per se. It is associated with cross infection and all. You can give a 4 to 8 puffs once in 20 interval of 20 minutes, 3 times you can give it. That's good enough. If it is a moderate to severe exacerbation, that is the time where you can think about going within both salbutamol and ipratropium bromide upfront. Latest GINA guidelines of 2024, which clearly mentions that you need not to wait. Previously, we used to say, give in a salbutamol, then add an ipratropium bromide, but no need to wait for that. If it is a moderate to severe exacerbation, go upfront with the salbutamol and ipratropium together per a child. And the next important thing after addressing the bronchodilator is then steroid. Steroid, if the baby is able to take orally, so you can give an oral steroid, that is an prednisolone, 1 to 2 milligram per kg for 3 to 5 days. If the child is not able to take orally, the options will be either you can give an hydrocortisone, you can start with the 5 milligram, followed by 2.5 milligram per kg 6th hourly for 3 to 5 days. Methylprednisolone is another drug which can be used 1 to 3 milligram per kg. Advantages with the methylprednisolone is it is in a less mineralocorticoid activity. So you can use a mineralocorticoid 1 to 3 milligram, maximum of a 60 milligram of the things you can use it. So ipratropium bromide, I have already discussed. I will not go with. Suppose if the patient doesn't respond within a bronchodilator of salbutamol, ipratropium bromide, along with the steroids, what are the other options we have it in our things? Magnesium sulfate. Magnesium sulfate is a drug which can be used after if the patient doesn't make an improvement with a salbutamol, ipratropium bromide, with a steroid for 1 hour you can wait. If it is not, that's the time you can use a magnesium sulfate in the dose of 25 to 50 milligram per kg. You can give it. But remember one thing, if you are using a magnesium sulfate, 2 things you need to be very careful. One, which can cause an tachyarrhythmias. Second thing, it can cause an hypotension. So how do we address the hypotension is given a small aliquot of a fluid of 5 to 10 ml per kg of a normal saline or a ringer lactate, just replenish the thing and intensive monitoring, that itself is sufficient. You can give a maximum of 2 to 3 doses of magnesium sulfate. Other way to mitigate this risk is you can give it as an infusion, magnesium sulfate. That's another way where you can give it. So these are some of the practical issues when you're delivering a magnesium sulfate to the things. As a clinician, what are the things we should do? What are the things we should not do? In a case of an acute exacerbation of asthma, rescue steroid, you go upfront with the things, inhalation beta 2 agonist, you can give it 6 to 8 puffs of an by meter dose inhaler. If you are using a nebulizer, remember one thing, it is likely to cause a ventilatory perfusion mismatch. If you are not using with an oxygen, it has to be oxygen driven if you are using a nebulizer in a moderate to severe exacerbation. And so if it is a moderate to severe, better you hospitalize, give it the oxygen-driven nebulization. Routinely, what we do, unnecessary exposure to the radiation hazard. Doing an X-ray is unwarranted in a case of an asthma, unless if you're thinking about some pneumonia, some complication, that's the time you can do an X-ray, otherwise no. Inhalation steroid, even though GINA guidelines of 2023 and 2024, it mentions about the inhalation steroid along with the parenteral steroid in a case of a moderate to severe exacerbation of asthma can be a useful entity, but still we don't use it in a practical thing because we go upfront with a parenteral steroid as the drug. Inhalation steroid is the thing previously used to say no need to use it. Nowadays we say you can consider, but it is not then still it is not in the literature, is not very much in that. Oral beta 2 agonist is another thing, oral salbutamol and all, not really required. Nebulization without oxygen, antibiotic not required, mucolytic and cough suppressant not really required in the case of an acute exacerbation of asthma. So if you have any facilities in your things, yes, you can initiate admit into the pediatric intensive care unit because further treatment, what it requires is an ketamine infusion sometimes where you need to go with that, where it requires an high end of a level 3 critical care unit. I'm not going in detail to that. So if you have, if the child is deteriorating and all, then you can use it and you refer it to the level 3 wherever it is available. That's about an acute exacerbation of asthma. Let's look at another case. This is a 2.5-year-old boy presented to our emergency department with a sudden onset of a cough with a respiratory distress. Heart rate is 118, tachycardia, tachypnea for this age, and air entry is decreased on one side, that is on the left side. Sudden onset, 2.5-year-old child coming to with a severe respiratory distress. Diagnosis is almost certain. It is you need to suspect a foreign body as the thing. When we did an X-ray, look at that, is hyperinflated left hemithorax with the mediastinal shift. You can see it. Mediastinal shift is there. Yeah, mediastinal shift. So it is obstructive emphysema. So as far as this is concerned, foreign body is the one of the thing. What we need to be careful in a case of a foreign body, see it can cause a respiratory distress. If you don't act quickly, it can go into the respiratory failure, cardiac arrest can take place. That is why we need to act. Suppose sometimes if you miss further, what will happen? Sometimes missed foreign body, that can cause a recurrent pneumonia, it can cause a lung abscess, chronic lung disorder. We need to be careful on those things. That is why it is an emergency. We need to act. Just if you are suspecting a foreign body, especially in case of an sudden onset without a prodrome of a respiratory complaint, we need to think about the things where we need to do a rigid bronchoscopy under general anesthesia. We need to involve the surgeons into the management of these cases. So to summarize, what really we have discussed is a specific management. If there is an upper airway obstruction with the stridor, adrenaline nebulization, single dose of dexamethasone is the key. Lower airway obstruction, adrenaline nebulization, subcutaneous adrenaline or a nebulization with oxygen, we can give it salbutamol or ipratropium bromide. In case of a foreign body, rigid bronchoscopy, don't blindly sweep the thing. If the seizures with respiratory failure, think about giving it midazolam also. With bag and mask ventilation, anaphylaxis, it is always a intramuscular adrenaline is the thing. And respiratory emergencies is the most common medical emergencies in the children. Good clinical history, physical examination alone is sufficient. It doesn't require many investigation, pinpoint where exactly the pathology, and appropriate decision on that can save the critically ill child. With this, once again, I thank you. Thank you all.
Thank you, Dr. Basavraj, for that very enlightening lecture, actually. I think it revised a lot of things that we had and definitely new things as well. I'd like now to introduce Dr. Khadija. Dr. Khadija Ali is a consultant pediatric endocrinologist and diabetologist at the King Hamad American Mission Hospital and a part-time consultant at the King Hamad University Hospital as well. She's been a speaker in multiple national and international conferences and symposium with more than 18 research works and publications in national and international journals. She was also awarded the Prince Salman bin Hamad Medal for Medical Merit in December 2021 as one of the COVID-19 frontline professionals. She's also a member of multiple societies in Bahrain, including the Bahrain Medical Society and the Bahrain Diabetic Association, and involved, especially in the hospital and outside, in multiple community outreach activities related to pediatric endocrinology. Dr. Khadija will be talking regarding type 2 diabetes mellitus in children. Welcome you, Dr. Khadija.
Thank you, Dr. Sana, for your kind introduction. I have nothing to disclose, and this is my outline for the presentation. During my presentation, I took my information from two updated studies, it's a Search and Today. Maybe you will see in the slides that I mentioned Search. So Search for Diabetes study was launched in the US in 2000. It's a prospective nationwide multi-center study aimed at understanding the epidemiology of both type 1 and type 2 diabetes in children. And the other one, Today, which stands for Treatment Options for Type 2 Diabetes in Adolescents and Youth. Well, until 20 years ago, type 2 diabetes accounted for less than 3% only of all cases of new onset diabetes in adolescents. At present, it reached up to 45%. I can see this from my own practice when I start to see kids with diabetes 10 years back. I see type 2 diabetes like once every few months. Now I see 2 to 3 cases every month. The prevalence is significantly increased, which is affected by obesity worldwide. And according to Search study data published in 2023, for example, in the US, incidence doubled in children and adolescents from 9 to 17.9 cases per 100,000 persons per year, from 2002, 2003 to 2017 and 18. Same thing in Europe, in most of the country, specifically here in Germany, a threefold increase was reported from 10 to 19 years old between 2002 and 2020. The incidence raised from 3.4 to 10.8 per 100,000, and same thing in Asia as well. What are the risk factors that make type 2 diabetes increases? Race, ethnicity, obesity, nutrition, sedentary time, age, sex, puberty, family history, genetics, maternal diabetes, and maternal obesity. In a recent meta-analysis comprising data from 30 studies involving 4,688 children and adolescents, the prevalence of obesity at the time of diagnosis reached up to 77%. Both the prevalence and incidence rates are higher in girls than in boys. There is a sex difference that is not seen in later onset type 2 diabetes. The prevalence ratio of girls to boys reported as much as 6:1 for First Nation youth in Canada. However, this difference doesn't found in China, but most of the country there is a difference. Maybe the difference is due to differential sex hormone effect or undiagnosed polycystic ovary syndrome or divergent post-pubertal weight gain. Prevalence increases with age, tripling from age 10 to 14 years to 15 to 18 years. It occurs more often during the second decade of life, coinciding with pubertal insulin resistance. Most children who develop type 2 have a first or second degree relative affected by this condition. Does early life affect? Of course. Intrauterine exposure to maternal diabetes and maternal obesity, fetal overnutrition are associated with development of type 2 in offspring. Mid-pregnancy maternal BMI and glycemia are associated with direct adiposity measure in 10 to 14 years old children. Weight gain during the first 4 months of life is associated with an increased risk of overweight at the age of 7 years. It might be to mitochondrial damage, endoplasmic reticulum stress, and epigenetic modifications may underlie this observation, but many mechanisms are not known. Role for breastfeeding, yes, it can be protective against prediabetes and metabolic syndrome in offspring exposed to gestational diabetes in utero compared to others who were not breastfed. The pathophysiology is multiple genetic, environmental, and metabolic causes that may differ among individuals and populations. It includes hepatic, peripheral, and adipose tissue insulin resistance, together with relative insulin deficiency due to impaired pancreatic beta cell function. and hypergluconemia due to alpha cell dysfunction, as well as impaired incretin effect. Obesity is the most important cause in the development of insulin resistance, and the critical determinant of insulin sensitivity is not the degree of obesity itself, not the weight itself, rather the distribution of fat partitioning. The phenotype characterized by increased intramyocellular lipid content and visceral and decreased subcutaneous fat. We can see here is the subcutaneous fat, but the visceral fat, the one in the viscera, this is the one that is associated directly with insulin resistance, the visceral fat. Indeed, visceral lipid were positively related to the 2-hour plasma glucose and inversely related to the glucose disposal and non-oxidative glucose metabolism. Obese adolescents and children with type 2 have a marked reduction in both first and second phase insulin secretion. I will show you in the next slide about the phases of insulin secretion. Thus, at diagnosis, just as in adult, 80% of their beta cell function is reduced or lost. While youth onset or children onset share these phenotypical features with adult, there are some unique characteristics for youth and children. The progression in obese children from insulin resistance to type 2 has been shown to be faster than in adults. The transition from pre-diabetes to type 2 diabetes in adults is usually gradual. It takes 5 to 10 years. But in youth, it's found to be 2.5 years. It's very short compared to adults. Early presentation of type 2 in youth raises the possibility of an accelerated process in pediatric age compared with adults, that's shortening the transition time between impaired glucose tolerance and type 2 diabetes. The deterioration of beta cell function in youth is more accelerated, is around 20 to 35% per year, but in adult is around 7 to 11 years. Early onset seem to be associated with increased risk of morbidity and mortality during the most productive years of life. So this observation in these children and young adults or young youth is a more severe and rapidly progressive condition than the adults. It's very important to screen for type 2 diabetes and pre-diabetes earlier. So early detection, as I said, and intervention even before pre-diabetes condition are established should be implemented to prevent further decline in beta cell function and delay the complication and have better outcome. How to screen for type 2 diabetes? We use fasting plasma glucose, 2-hour plasma glucose after 75 gram, oral glucose tolerance test or GTT, or by HbA1c. If these tests are normal, we should repeat after every 3 years. However, we can do it in annual basis if there are risk factor or something happened that sudden increase in the weight, or there is a family history or any other risk factors. We do it in annual basis. Risk-based screening of type 2 in children and adolescents. Screening in youth should be considered after the onset of puberty or at age of 10 years, whichever is earlier. In youth with BMI more than 85th percentile, which is mean overweight, for age and sex with one or more of the following, which is the risk factor: family history, race, signs of insulin resistance like acanthosis nigricans, hypertension, dyslipidemia, polycystic ovary, maternal history of type 2 or gestational diabetes, and also for those who are using weight-promoting atypical antipsychotic agents. We have to know pre-diabetes. It's very important. Pre-diabetes, the progression from normal glucose tolerance to type 2 involve intermediate stage of impaired fasting glucose, impaired glucose tolerance. We call it pre-diabetes. The transition state of impaired glucose tolerance in adults is associated with high incidence of vascular complication, around 10%. Importantly, if lifestyle modification, or we use pharma, pharma medications can reverse it. This is very important. We can reverse pre-diabetes stage. And we prevent further development of the complications. Diagnosis of pre-diabetes, if the impaired fasting glucose from 5.6 to 6.9 millimole per liter is a pre-diabetes. 7 considered diabetes. Impaired glucose tolerance after 2 plasma OGTT from 7.8 to 11 millimole, we consider the pre-diabetes. Or if the HbA1c 5.7 to 6.4%, this is a pre-diabetes range. It's very important to detect pre-diabetes because most of the studies showed there is a highly reversible stage. We can go to the normal readings of diabetes. Here is a study done between 2010 and 2016. They studied 526 adolescents. 162 had impaired glucose tolerance. In follow-up after 2 years, 65% reverted to normal glucose tolerance. 27 persisted as impaired, and 8% progressed to type 2 diabetes. What they did for them, they just give them a nutritional advices, even no exercise. The lifestyle modification was a nutritional advices, and they follow up them after 2 years. Here is the 2 phases of insulin secretion when taking high sugary food. The first phase lasted for 10 minutes, and the second phase from 10 minutes to 120 minutes. There is pointer, I don't know. I will use the arrow. This is the normal first phase insulin secretion and second phase, the complete line. This line is the pre-diabetes. There is a reduction in the first phase, it's impaired, but the second phase is normal. And the last one is type 2 diabetes, where the 2 phases are impaired, the first phase and second phase. And here are the stages, the stage of impaired fasting glucose when hepatic insulin resistance, impaired glucose sensitivity, first phase insulin secretion, as we saw. Impaired glucose tolerance, whole body insulin resistance, not the hepatic only. There is delayed or blunted insulin response, insufficient to compensate for the reduced insulin action. Then we have a phase of both whole body insulin resistance, defect in first and second insulin response. And later on, the beta cell destruction. There will be reduced beta cell function in youth or children around 20 to 35 per year, in adult 7 to 10% per year. So it's faster in children. Type 2 diabetes, and after the pre-diabetes, we go to type 2 diabetes can vary in presentation. They can be asymptomatic. Last week, I diagnosed a child. He came for something else, and we found him to have 7.1 his HbA1c without any symptoms. Or they can present as DKA or hyperosmolar hyperglycemic state, a small percentage. But during the COVID time, many children with type 2 diabetes presented with diabetic ketoacidosis. To diagnose, we need to confirm is it diabetes or not, and is it really type 1 or type 2 or monogenic type? Because nowadays, many children are obese, and they might come with type 1 diabetes, but because of obesity, we can diagnose them as type 2 diabetes. The criteria for type 2, we have symptoms of hyperglycemia, or not necessarily there is a symptoms, with the level of the level are same as the adult for children, pre-diabetes and diabetes. If fasting blood glucose 7 or more, if post OGTT plasma glucose 11.1 and more, if HbA1c more or equal to 6.5%. These levels are a diabetes level for type 1 or type 2. Now we'll go to the management. Treatment involved managing insulin resistance, beta cell failure, and the comorbidities. We need the target of the sugar to be for fasting from 4 to 6 millimole per liter, for postprandial from 4 to 8 millimole per liter if we can, And for HbA1c, less than 7%. And in most cases, it can be less than 6.5% if there is no hypoglycemia. We always start with lifestyle modification. In all stages, they have to go through exercise and dietary modification. In type 2, we don't wait. We have to start medication immediately. Depends on HbA1c. If HbA1c 8.5 or less, we start with metformin. It's the treatment of choice together with healthy life changes, as mentioned. If there is ketosis at the presentation, ketonuria, ketoacidosis, or if the HbA1c higher than 8.5, insulin is required initially with long-acting or intermediate-acting once per day basal insulin. Usually we start with 0.25 to 0.5 unit per kg. Metformin should be started at the same time and the dose titrated unless acidosis is present. If there is acidosis, we don't prefer to start metformin. Transition to metformin only, if we start with both metformin and insulin, usually be achieved over 2 to 6 weeks by decreasing the insulin dose by 30 to 50% each time the dose of metformin is increased, with a goal of eliminating insulin therapy if this can be achieved with optimal glycemic management. Data from today's study indicate that around 90% of youth with type 2 diabetes can be successfully weaned off insulin and treated with metformin alone with attainment of glycemic target. What is the subsequent therapy? The initial therapy, glucophage or metformin plus minus insulin. The goal of initial treatment should be attained an HbA1c less than 7%, and in some situations less than 6.5 if there is no hypoglycemia. If we didn't reach our aim, a medication should be added. So what are the things approved? FDA approved medication for treating type 2 in children, less than those for adult. Metformin, top of the list. We have GLP-1 receptor agonist, Victoza. We are using it, well, in the doses 0.6, 1.2, 1.8. If we use a higher dose, we call it 3 milligrams Saxenda. We use it for obesity. And there is SGLT2 inhibitor can be also added and used. We'll keep add medication till we have our target of HbA1c around 7%. If HbA1c more than 10, we have to initiate again or reinitiate of basal insulin. The starting dose of basal insulin same 0.25 to 0.5 units per kg, and the dose is titrated based on the blood sugar readings. If the glycemic target is not attained on a combination of insulin and metformin, and we increase the dose of insulin up to 1.5 units per kg per day, we have to initiate a prandial insulin, short-acting insulin, till we reach our aim or target of HbA1c. This is just a summary of what I said about how to start if HbA1c is than 8.5 or more than 8.5. And if we have DKA, we have to give them with the DKA protocol, IV insulin. If medical doesn't help, we go for bariatric surgery. We should be considered in youth or with obesity-related comorbidities, post-pubertal youth with type 2 and BMI more than or equal to 35 kilogram per meter square, particularly when, as I said, medical therapy has been failed. A large US pediatric bariatric surgery centers compare their result to matched individuals treated with medical therapy in today's study and showed greater and more sustained lowering of HbA1c with surgery and improvement or normalization of other comorbidities like dyslipidemia, hypertension, kidney disease in nearly all the youth in this study. There is still lack of long-term post-bariatric surgery data for more than 10 or 15 years in relation to they need reoperations or not, complication, bone health, and nutritional deficiencies. طبعاً bariatric surgery should be undertaken in center of excellence with established and experienced surgical, nutritional, behavioral, and medical support. Additionally, the adolescent himself must be able to sign a consent before the surgery and explain to him the benefits and the risks. It's not only the type 2 diabetes, we should screen for comorbidities associated with type 2 diabetes, when we should screen actually at the time of diagnosis and after that. For hypertension, we screen at the time of diagnosis and then in every visit. For dyslipidemia, at the time of diagnosis and every year by doing the fasting lipids. Okay. For nephropathy, yearly starting at diabetes onset also, we measure the albumin to creatinine ratio, non-alcoholic fatty liver disease by measuring the liver enzymes and other. Comorbidities is very important. In many cases, you can find at the diagnosis, they have comorbidities as well. In conclusion, the growing number of obese children and adolescents affected by type 2 diabetes and the rapid development of glucose homeostasis dysregulation in this age group explain why type 2 is becoming one of the most important public health problems. Therefore, identifying obese youth at risk for type 2 is of primary importance in order to interrupt its progression and the diabetes-related cardiovascular complication in this age group. Princess, and thank you so much.
Thank you, Dr. Khadija. I think this is Dr. Khadija's area of speciality, something we always keep sending to her most of the time. All right. For our final lecture for this second session, I'd like to call Dr. Yogesh Parekh for here. He is a former professor and head of Department of Pediatrics, PDU, Government Medical College and KT Children's Hospital in Rajkot, Gujarat. He's now working in the Government Medical College in Surat, Gujarat. He has held multiple national and state level positions in the IAP, and he's currently the Honorary Secretary General of the IAP. He has more than 30 scientific publications and presentations in both national and international journals and conferences, and has been awarded the prestigious Travel Award for Outstanding Abstract for the research paper at the International Conference in the First Congress of the Asian Society for Pediatric Research, which was held in Tokyo, Japan. He has been a faculty at various national and international conferences, and he's also a master trainer for many programs in India, along with being an MCI and NMC assessor and inspector, and conducting exam as an examiner for various universities. So Dr. Yogesh, we welcome you. And Dr. Yogesh will be presenting on growth monitoring, why, how, and when. Here, this one to go forward, this one to go back. In case we need.
Hello. Yeah, thank you, Dr. Sana. And thank you, the King Ahmed American Mission Hospital, for inviting us. Thank you, Dr. Vanitha, Dr. Deepak, Dr. Sana, Dr. Madhuri, and all. So this is the first time we are visiting Bahrain, this our IAP branch. So we congratulate Bahrain branch for arranging this wonderful CME with the great audience. And I am seeing all the participants are seated with the since morning without any break. So thank you very much. Now it's very common topic. After Dr. Basaraj and Dr. Khadija talk and the all learned faculties, I am standing before you the lunch break. So I will finish quickly. So let us start the videos. Yeah, pre-lecture. Yeah. So, and this is a very common topic for the all the growth monitoring, how to use the growth charts and what is it's important with the early, this specific is with the early childhood developments. So we know every young child deserves to thrive. A child's brain develop fastest within the first 2-3 years. And for this nurturing care, we have 5 important foundation pillars like good health. Second is the adequate nutrition. Third is responsive care. Fourth is safety and security. And fifth is very early responsive learning. So these are the 5 pillars of the foundation for the children's development. What is the definition of the physical growth? We all know physical growth refers to the increase in the body mass. It may be the size of the cell or the size. So it may be length or height and the weight, as well as the size of the organs. Children grow rapidly from birth to about 2 years. After this first spurt of the infancy and the early childhood, the toddlerhood, growth slow down. And the second spurts come during the adolescent period, during the puberty. So growth is one of the measure of the well-being of the children. So we are seeing this, the graph, it's showing the first spurts and the second spurts. Why the growth monitoring is very important? Because it is the barometer of the well-being of any child. And it is a very important pillar of the preventive care. It helps reassure the normals of the life, and it helps identify the growth disorder, nutritional disorder, or systemic disease, whatever the non-communicable disease. Magnitude of the problem in India. In India, we have a system to survey the NFS 4 and 5, the National Health Family Survey conducted during the 2019-2021 in comparison to conducted for 2015 to 16. So both the data we have here for the important children under 5 years who are stunted. Stunted means the height for age less than -2 SD. 30.5 to 5 that this is 38.8. So it is the stunting is decreased. Children under 5 who are wasted means weight for height less than -2 SD. Here also the significant change 19.3% to the 20.21% in comparison to NFS 4. Children under 5 who are severely wasted means weight for height less than -3 SD, the 7.7% in comparison to NFS 4 data 7.5. This is the core. This is the cause of the concern for this India, because the severely fasting under 5 is an increase. Children under 5 who are underweight, weight for age 32.1% in comparison to NFHS 4 is 30.5%. So this is also some improvement is there. So what is the situation in the Bahrain? Growth problems in the Bahrain, 3 major issues: obesity, underweight, and the growth retardation. So prevalence of the obesity in the children and adolescents in Bahrain increased from the 11.6% to the 17.2% between 2002 to 2016. So what are the factors affected? It may be this risk of the obesity includes the higher maternal education and the more time spent watching TV or the playing computer with the screen time. Mostly due to the screen time, overeating will be there. In the underweight, one of the studies showing that 36.8% of the children were underweight. Children who were underweight also had a significant delay in the motor, cognitive, and the global development comparison to the normal physical growth having a children. Third is the growth retardation. One of the studies showing the 9.8% of the children had growth retardation. It is also the significant delay in the all development outcome compared to the children with the normal physical growth. So what the line showing the child's growth? See, first chart showing the good growth. All the weight and height is growing well. Second, having some danger signs, some not growing well, some danger signs, and find out something the next children is there, or the solid introduced, or breastfeeding is stopped, some this or any chronic diarrhea or illness is there. if any hospital admission required. So this is the something is that this is a static line. The third one is a very dangerous. So the whole chart is going down. So what are the importance of growth in the developments? Evidence suggests that the prenatal period and the first 24 months after the birth are the most sensitive times. After 24 months, the association of cognition with the stunting is not as strong, but some catch-up is possible in height for age after 24 months, but the cognitive gains are uncertain. In conditions like hypothyroidism, growth hormone deficiency, parental neglect, or affect both the domains, and most of them are preventable. So here we can have an importance of the growth in the development. Studies showing that journal published in the original article published in the Journal of Global Health Science, multiple anthropometric failures and the early childhood development in 34 lower and middle income countries, showing that a potentially additive relationship between the multiple anthropometric failures and the early childhood development. Second study published in the BMC Pediatrics, findings suggestive of the importance of the integrated intervention that support mild to severe malnutrition as a key component of the nurturing care. It approaches to the improvement in the ECD in the lower middle income countries. So how do we measure the growth? Very simple tools are there. We have to measure the growth. Child's growth is assessed by the measuring his or her weight, length for the up to the age of the 2 years, and height for more than 2 years. To know if your child is growing well, we have to check the child's weight, length or height, and we have to compare with the expected for the age and the gender of the same age. Measurement of the height by up to 2 years, we have to measure by the infantometer. Above 2 years, we have to measure by the stadiometer. See here, this main thing is the photograph showing the how to take measurement of the height. We have to stand this child, all the back is supported, head, shoulder, buttocks, and the ankle. And we have to see the perpendicular line with the eye line. What is we are putting the objects to the stadiometer. Mostly we are making some mistakes here only. So how to monitor the growth? Growth monitoring helps us to assess how the child is growing. Identify growth faltering and the pattern of the growth failure. It identifies the nutritional deficit, if any. It provides timely intervention. It can help in the parental understanding. So up to the age of the 3 years, the measurement of the head circumference is also very important, especially in the children with the microcephaly neurodevelopment disorders. And how to measure the growth in the children? See, this is the growth 1 year, 2 year, 3 year, and 4 years. The trajectory is showing. Growth monitoring. The single measurement indicates the child's size at that particular point of the time. See here the graph is there, 12 months of age, and the weight is 10.5 kg. So when the monitoring is a continuous longitudinal process in which growth assessment is done at the fixed intervals and the growth trajectory is followed. So this is the we have plotted the 12 months of the weight and the weight 10.5 kg. They plot the 75th of the percentile. Growth monitoring. We have to select this is simple plotting methods. Very simple, less time consuming. It is very less expensive and the most diagnostic tool. What are the growth charts? The different countries have a different growth charts. Most of the country following the WHO growth charts. India following the WHO and the IAP growth charts. Here the Bahrain, mostly the CDC growth charts are following. So these are the different growth charts. Growth chart is a simple graph in which the child's body parameters are plotted at the age at which the measurement is done. Growth chart is utilized to maintain the longitudinal record of the child's growth parameters. It has to track the growth of the children birth through the adolescence to the adulthood. On the growth chart, curves of the normal growth have been drawn based on the measurement of the thousands of the normal children. So particular children, we have to compare with what are the thousands of the children in the country. So these are three childs. Child 1 is showing the normal growth at visibly. Child 2 is showing malnourishment little bit, and the third child is having a severe malnutrition. Using the growth charts, the correct WHO, CDC or country-specific growth chart should be selected according to the age and the gender. On the first visit, we have to enter the child's name, date of the birth, and the other details of the chart. Explain the purpose of the chart and the process to the parents. Measure the parents' height and not on the chart for the future reference. Because we have to take the mother and father both height for the calculate the mean parental height. All values should be marked as a dots, not as a circle around the dot. In the India, we have a previously Indian 2015, before the 2015, we are using the WHO and the IAP specific chart. But after the Indian Pediatrics, this journal publication committee, IAP growth chart committee, recommend the revised growth charts for the height, weight, and the body mass index. So we are now introduce the BMI also in the our IAP growth charts. So up to 5 years, we are using the WHO growth charts. 5 to 18 years, IAP 2015 growth charts. You may use the CDC or country specific growth charts. This is WHO 0 to 5 years chart for the boys. We have length for height, head circumference, and the weight. And this is the pink chart for the girls. This is for the Saudi children and adolescent. But Bahrain is not using the only the CDC and the WHO charts. So this is the CDC growth charts for the boys. This is for the girls. And this is the IAP growth chart where the BMI is introduced along with the height and the weight. This is for the girls. So how to plot? This is we are showing put a small dot and plot the MPH at the age of 18 is subject, and we have to interpret height age and the weight age. So this is the growth chart for the one of the girl child. Calculating height and age and the weight age. See, here we are putting this age. So chronological age is 10 years, height age 8.10 years, and weight age is 12.8 years. 3 simple steps to understand the growth charts. One is the selection of the charts. Second is the plotting, how to plot it and how to interpret. This is the third thing. Let us have a case A and case B. Case A is a 10.6 years old girl came with the not gaining weight and height. With the history of abdominal pain, diarrhea on and off, no history of polyuria, polydipsia or the weight loss or visual complaints, and had normal birth weight. Height is 126 centimeter, weight is 19 kg. Father weight height is 167 centimeter, mother height is 156 centimeter. In case of B, same 10.6-year-old girl came with the not gaining weight since 1 to 2 years. Either chronic illness is there. History of the lethargy, constipation since 3 to 4 months. No systemic complaints, cold intolerance, and the normal birth history. Height is 121 centimeter, weight is 29 kg. Father's height 117 centimeter, mother's height 157 centimeter. So in comparison to case A and case B, see, we are plotting this on the pink chart. The chronological age is more than height age, it is more than weight age. So this is some celiac disease, nutritional cause is there. In case B, the chronological age is more than weight age, more than height age. This is the endocrine disease, so hypothyroidism is there. So importance of the height and age and the weight age. So in the case A, this is weight is more affected. In the case B, the height is more affected. So this is the systemic nutritional cause. This is the endocrine cause. So when do we monitor the growth? Up to 2 years, we have to monitor the length, weight, and the head circumference at the 0, 6, 10, and 14 weeks. Then 6, 9, 15, and 18 months. In our NCECD program, we have a total 11 child visits, and 2 to 5 years, height, weight, and the head circumference every 6 months. Then more than 5 years, we have to monitor the height, weight, and the BMI, and along with the SMR also, tenor stage. Every 6 months, and the tenor staging every yearly. So when do you monitor? First, less than 7 days, then the 6 weeks, 10 weeks, 14 weeks, then the 5th visit at the 6 months, 6th visit at the 9 months, then the 12 months, 18 months, 24 months, and the 30 months and the 36 months. So total 11 well child visits up to the age of 3 years. And in India, we are using the MCP card, Maternal and Child Protection Card. So in the each visit, we have to ask, assess, and the counsel the parents. So parental counsel is more important. Growth monitoring and its active measurement and plotting of the weight and the height or length provides a unique opportunity to trigger the interest of the parents and makes it easier to educate and counsel them about their child's growth. If we are plotting and explaining to the parents, then they will ask the question, what is happening to my child? So if the normal growth is there, we have to praise the parents and we have to schedule the next visit. We have to demonstrate their parents which part of the growth is indicating the normal. So they can understand, and if any deviation from the normal growth, they can come to us. Then we have to use the color coded charts are easy to explain. Show the parents on the chart how to determine that their child's growth parameters are within the normal limits. And we have to praise them for the providing suitable and nourishment after checking the diet and the schedule the next visit. If the suppose child has some growth faltering, then we have to educate and counsel parents, analyze the dietary gap, and then we have to schedule the next visit. So we have to explain where the deviation started from the earlier trend and starts to fall below the expected range. It indicates the growth faltering. It indicates the child is not growing adequately, possibly due to the inadequate diet or due to the any illness. So we have to do a dietary gap analysis and educate the parent on how to improve the child's nutritional status according to the IAP-AMH recommendation. If the diet is fine, illness need to be actively looked for, and we have to treat the actively for the illness. Third is the abnormal growth. We have to educate and counsel parents about the malnourishment, analyze for the cause. If nutritional, then we have to admit the NRC. NRC is our Nutritional Rehabilitation Center, is as per the WHO recommendation. A child's growth parameters well below the normal range, less than -2 or even -3 Z score, it indicates malnutrition. It could be the underweight, wasting, stunting, or the severe acute malnutrition. This also needs to be shown to the parents. We have to explain the features and the consequences of the malnutrition. The child's need to be evaluated in the depth for the cause. If it is purely nutritional, then we have to refer to the Nutritional Rehabilitation Center. So what are the indications to refer to the NRC for the growth monitoring? Weight loss or the lack of the weight gain on 2 consecutive monthly visits. If any inadequate catch-up growth in the preterm babies, with the good care and the feeding very low birth weight, infants mostly achieve the weight catch-up during the 2nd year and the height catch-up by the 3 to 4 years. Though some children continue to show the catch-up growth later. Then the third is poor catch-up growth is in the children with the nutritional deprivation and or medical any complication. The fourth is weight, length or height for or head circumference below the 3rd centile or the above 97th percentile or the growth charts. And the fifth is crossing of the 2 major centiles upward or the downward of the growth charts. So take home message is be motivated to perform growth monitoring for every child. Being a pediatrician, we should monitor each and every child and we have to plot on the growth charts. Plot growth parameters at each well child visit on the WHO growth chart or the IAP growth charts or the country specific charts. Interpret the trajectory of the growth from the growth curves. Counsel the parents on the identified growth pattern and refer children with the growth faltering and we have at the appropriate time and treat the children if any medical condition is there. So thank you very much. This Gabriela Mastral said many things can wait. Children can't wait. Today their bones are being formed. Their blood is being made. Their senses are being developed. To them, we cannot say tomorrow. Their name is today. So please, the do the growth monitoring and plot the growth charts every day. Thank you and thank you very much.
We'll have a quick panel discussion. We're running short of time. We'll, yes, before. Can Dr. Basiraj come over to the stage, please? Dr. Brahmara Madhuri is our service line head in pediatrics. She will be the one moderating this session. The audience can have some questions. We can have somebody navigating amongst the audience for the questions. Any questions? Yeah, time for 2 questions. Dr. Khadija will be here. She is busy with patients. She'll be here anytime now. In the meanwhile, you can ask some questions and Dr. Pramara will be moderating. Dr. Pramara, you can initiate the session by asking any questions, right?
Thank you very much for holding on. I know all of us must be hungry. Thank you very much, Dr. Basiraj, for that very, very comprehensive coverage of respiratory emergencies. Just one topic that I would like to bring forth is the dosage of the dexamethasone, the current update, and I would like to know your experience about usage of the high dose dexa versus low dose dexamethasone, especially group, before anybody else.
This is a very, very important thing. When you are looking at an treating a cold with a high dose dexamethasone, it is a single dose. We need to use it 10.6 milligram per kg. And the versus the small dose, low dose in the 5.5 milligram per kg. It is always preferred to go with a higher dose since we are using a single dose. Absolutely, there is no issues with that. As far as adrenal suppression is concerned, we can use a maximum of 8 milligram total. It should not cause any problem.
Much. And any questions from the audience?
Yeah. Yes. Thanks for very, very enlightening lectures. My question, how common is the rebound phenomena after the administration in your practice of the pediatric cancer?
That's a very, very important. During my presentation, I commented on reboundness of an adrenaline. Adrenaline usually the effect starts within 15 to 20 minutes. That's the thing. The once that effect starts, it will last for a peak of up to 2 hours. Then it starts coming down over a period of 4 hours. Sometimes the things is rebound effect can be. As far as the residual adrenaline is concerned, we don't use a residual adrenaline in our practice. We use a routine adrenaline. With that, generally there is not much of a problem and there is no rebound phenomena. Second thing, even I mentioned it regarding tachycardia and hypertension. Even though theoretically it has been mentioned in the literature, but in practice we don't come across. So these are the things, but as far as the residual, I do not have experience in this.
Any other questions from the audience?
Yeah, this is a very important question. Is there any role of the parental leader to agree in the case of an accident? A decade back, if you ask me this question in 2009, we used to use an IAP-AMH is the drug we used to use it. But in the last 1 decade, we do not use an IAP-AMH. Reason being, the problem with IAP-AMH, it requires an intense monitoring. Tachyarrhythmia is the major issue. That was the reason why we don't use an IAP-AMH in India. That's the next question comes.
can we have it use an IV salvage? Absolutely answer to that question. We do not have any experience using an IV salbutamol in Indian setting. We don't use. What we do is, if the patient doesn't respond within a bronchodilator, we with an interpreter, with an inhalation like salbutamol, intravenously, we go with magnesium sulfate with intense monitoring. The problem associated with magnesium is one is hypotension, another is tachyarrhythmia. But these are the things can be addressed with a small adequate of the fluid of 5 to 10 ml of crystalline normal saline. Because like that, if the patient doesn't respond to the magnesium sulfate, we escalate the therapy with a low dose of ketamine, 0.5 to 0.7 milligram per kg per hour. Where the problem with the ketamine is it can have the bronchoria and hypersecretion. That's the major issue. If you're using the low dose of ketamine, 0.5 to 0.7 milligram per kg per hour, this effect will be mitigated. It will not be any major issue. We can.
How about IV-aminophenol? How about IV-aminophenol?
See, aminophylline, Dr. Vanitha may be very fond about those days. We used to use an aminophylline as one of the common drug in that. See, the problem with an aminophylline is it has got three advantages. One, it's a good bronchodilator. Two, some anti-inflammatory effect. Three, which is having a steroid sparing effect. These are the things which has been associated with the good thing with aminophylline. But the thing with aminophylline is a narrow therapeutic index, GI disturbances, hypotension, arrhythmias, very low threshold for the toxicity is correct. But I purposefully did not mention in this forum. When aminophylline is concerned, I do use it, aminophylline in our ICU, our resource limited in the public sector unit, with a dose of 2.5 milligram or to 5 milligram per kg as a loading dose, followed by 1 to 1.5 milligram as a thing. We do use it with an intensive monitoring. It is a wonderful drug, except with a narrow therapeutic index is concerned. It's a wonderful drug. You can use it. I use it. But I did not mention this forum because this has got a very narrow therapeutic area. Regarding IV salbutamol, so
his question was IV salbutamol.
Yeah, in UK they are using. So here we are not using this. To be honestly speaking, I don't have an experience. Definitely, I had an experience, but now in the last 1 decade, I have not used it. Yeah, even I have used salbutamol. I'm sorry, but I use only UK.
Parenteral medications, I think we are limited to only Maxelf and aminophylline with a pinch of salt. I guess that's where we stand. Maybe we go to ketamine as Dr. was suggesting. I think we also do not have IV salbutamol availability in. He represents the ICU of Bahrain and it's not available over there. So that's where we stand.
Type 2 diabetes mellitus in children. So what is the impact of COVID-19 pandemic on diabetes, like type 2 diabetes?
Yeah. The cases increased worldwide during the pandemic from time to because of sedentary life, they sit down because of the movement. And the other thing, there is non-immune invasion of the virus in the pancreas directly. It's affected the intestinal destruction, plus the stress kept there also increase their weight and all. For these three factors start to during COVID increases. In many cases, they can present even with DKA more. It's mentioned in the literature. Actually, type 2 increase all that. It's not immune, but all autoimmune diseases increases during COVID. Type 1 diabetes, we have so many cases. Hyperthyroidism, I used to see one case per year like this. During COVID, many cases coming every month, hyperthyroidism treatment. So, yeah, it's different than type, but type 2 increases.
So by having both confidence data, especially when you are talking heights and hypervalues and to expect that like mid-75. So nowadays we are not using that normal calculating mid-75. We are just directly using the flow charts to the charts so that you can just see what is mid-parental height and check what is heights and then. So depending on that, you interpret the charts. Yeah. So mostly in India, the endocrinologists are using the MPH, the minimum height. But in the normal setup, we are using the WHO and the IAP growth chart, specifically BMI. This is the take home for the IAP setup in the Indian setup.
Currently also the use of Z scores more than just percentile charts. I think percentile charts along with the Z scores will be a good combination to use. I think for paucity of time, we will have to cut short any more questions. But the whole wrap up of the first two sessions links very well to prevention. We as pediatricians are into prevention of diseases. So when you link up prevention of type 2 obesity, the NCDs associated with antibiotic use, it boils down to us championing prevention as in good nutrition, good growth monitoring, so that they stay within the growth parameters. They avoid obesity, they avoid malnutrition and undernutrition, and therefore keep up their immunity and therefore decreased use of antibiotics. So all this actually quite links up to the whole thing. So we look forward to the post-lunch session. Is there any other comment from the speakers before we close?
So as you mentioned, the prevention is better than the cure. And I thanks and congratulate the scientific committee. They prepared in such a way the prevention part. What a AMR or the PIC setup or the growth monitoring, it's better to have achieved all this one setup.
Very right. In fact, this week we are celebrating the AMR week, so that falls in perspective.
That's why we have the program with the UNICEF there, AMR, on this National New World Week celebration.
Thank you all. It was an interesting discussion. Can you all please remain on the stage? We are having a photo session before we go for the lunch break. We invite all present in the audience to come over to the podium. We will organize based on our height, who would be on the stage and who would be, we would want to cover the whole group in a, some can stand on the top.
A very big group.
I think we can all be done. Yeah. So basically, self-direct ourselves too. Yeah.
Some of us are on top, some of us are.
Can you all please come over before we go for a lunch break? Yeah, doctor, if, yeah, maybe the guest speakers can be on the top. And I invite everyone to come over for the group photo.
The speakers can stand in the center or on the top. Dr. Kailan? Stand beside you. Is this okay? Just wait, please. There are a few cameras for him. Yeah. Do you want to give it to them for opening the screen? Okay. One more. Please have the lunch and please, there's enough lunch for everyone, please. Don't forget to go to the fifth floor, have your lunch and come down. Enough.
Arrange access.
The number that is there.
Presentations are there, you can keep it and. Doctor photo. Section finish, you can share it back
Yeah,
in,
I'm
right?
just trying to figure out we have all of them or not. And do I have those? Yeah, okay. So, do I need to go back on again? Stop sharing?
And share it.
Okay.
That you can stop and share.
Yeah. That one's mine or yours? I think that one's mine. Doesn't matter, both of them are ours. I'll start then, yeah? No, apologies, so that we can see. All right, I think we'll get the final session started. Welcome back from the post-lunch break. I hope no sleepy faces here. We still have an interesting session to go. Right, I would like to invite back Dr. Basavraj, please, to kickstart this session and his second lecture of the series. He will be presenting on the rational use of antibiotics in the PICU.
So Vanita will be very happy. Yes. So this is an institute where I am working. It is 1,000 bedded, presently 500, and 500 is yet to be operational. 1,000 bedded children's hospital. So where I'm heading in a 50 bedded pediatric intensive care unit. So what I'll be discussing in the next 20 to 30 minutes is about a rational use of antibiotic, focusing on emergency and pediatric intensive care unit. I'll not go in detail into the OPD things. So what's the learning objective of this presentation? Understanding what is the empirical antibiotic therapy, how we choose an empirical antibiotic therapy, and specific antibacterial, understanding when not to start the antibiotic even in the critically ill children, understanding the antibiotic stewardship. When we talk about this, there is a high risk which has been associated with an untreated infection in a critically ill children. That's why antibiotic plays an important role. In the morning, Dr. Ranjan has brought out a lot of issues which is related to the antibiotics is one of the things for a rise of a non-communicable disease. Whole globe is now talking about NCD. So we need to critically relook at it, when to use, when not to use. What is the rationale behind that? That's an important thing. Inappropriate use of antibiotic therapy, which can promote the emergence of a drug resistance. We know that in 1940s, we discovered the penicillin. Following that, lot of good things has been happened. Now, if you don't use the antibiotic rationally, and we are going to enter once again a pre-antibiotic era where no antibiotic is left. All the antibiotics will develop in a drug resistance. That's why it is in a need of the hour. And nosocomial infection poses different challenges to the clinical practice, whether you are an intensivist, whether you are a practicing pediatrician or practicing healthcare provider. Antibiotic stewardship really helps in controlling the nosocomial infection. So general approach is we need to know when to use an empirical and definitive therapy. And we need to know that escalation and de-escalation of antibiotic strategy almost in every day. We need to relook at that. Should I de-escalate it? Because problem is once you start an antibiotic, you will never relook at it. That's where it is. And when to start an antibiotic therapy, that's another thing. We need to understand the pharmacokinetics and pharmacodynamic. Basically, we need to look at the bacteriostatic, bactericidal, and combination therapy when it is useful. What is the host factor? Is it an immunocompetent host or immunocompromised host? How I need to change the antibiotic therapy? And the factors we need to consider when you are choosing an antibiotic, when your choice of antibiotic, it should be a most effective antibiotic. We should select it, and it should be less toxic. That's then a more important thing because these are some of the things which is very important. And the cost really in a low mid in LMIC, where the cost really plays an important role, where we need to consider the cost factor, it should be less expensive and precise duration of a time. If the antibiotic is required for 5 days, use it for only 5 days. Don't use it for 3 days. Don't use it for 7 days. You cut it at 5 days. Precise duration of time is important. And of course, it should be able to cure and prevent the infection we need to be. What are the questions we need to answer yourself? You need to answer yourself before choosing an antibiotic. The first and foremost, we say in a famous word, before inking, think before you ink. Before you writing any antibiotic, we need to think why I'm using an antibiotic, what the clinical diagnosis is. Second thing, we need to look at what the bug which has been caused this clinical condition so that you can prescribe a right antibiotic. And your thinking process should be what is the antimicrobial activity of this antibiotics? What is the likelihood of a drug resistance? When you talk about the drug resistance, what is the global drug resistance scenario? What is your national drug scenario? And what is that AMH, RNA, wherever you are working? What is the antibiotic spectrum pattern? What is the drug resistance pattern we need to look at? Because unless you know the local things, just looking at the literature alone is not sufficient. And is there any factor that affects the choice of a drug? The moment we say the factors, it could be in a renal failure or it could be in a liver failure, because your pharmacokinetics and pharmacodynamics is likely to be affected. We need to look at it so that you need to adjust the dose of the drug and the dose and duration of the treatment for the clinical condition. That's plays a very important. Next thing is, once after choosing an antibiotic, next thing is this antibiotic is working to this child? Is it a clinical symptoms is coming down? It could be in a clinical parameter. It could be a lab parameter. It could be a microbiological thing. You need to look at it in a comprehensive way on day-to-day rounds. Then only the choosing of your antibiotic really is going to play an important role. And the presumptive therapy, when you are if you want to start in a presumptive therapy, make sure that your antibiotic should be started only after sending the appropriate blood culture and any relevant culture which is required. You send the make it a habit to send the culture before starting an antibiotic. Any change in the antibiotic, you must think about microbiologically. What is the culture sensitivity pattern? Look into those things. Then only you can consider that. And another important thing of late, what we are looking at an MIC level, minimum inhibitory concentration of a drug is very important when you are choosing these antibiotics. Review the antibiotic therapy should be done daily, and therapy should be escalated or de-escalated depending upon the culture. And empirical therapy, if you are choosing it, you need to justify especially in a life-threatening condition of infection which has been ICU setting where you're waiting for the result. That time you need to justify, put a justification notes in day-to-day route so that you will not misuse the antibiotic. So what are the common clinical conditions where antibiotic is required upfront, where you cannot wait? Meningitis, the patient coming with an acute febrile encephalopathy or meningoencephalitis, this is the time you can't wait for the report to come. You take the cultures and start the antibiotic upfront, because meningitis, if you delay even in a minute, you are going to have a more morbidity and mortality. We need to be bacterial pneumonia. You cannot wait for the bacterial pneumonia to wait for the culture or X-ray to be there. You need to start upfront. If it is an acute abdomen or surgical problem, which is because of an infection, that's the time where you cannot. If it is if you're suspecting about an appendicitis, if you're suspecting about another abdominal sepsis, where you cannot wait, you need to go upfront. Pyelonephritis, urinary tract infection, which is a complicated, where you cannot wait for an antibiotic, septicemia, enteric fever, nosocomial infection. These are the clinical conditions you cannot wait. Where you can wait, where the misuse of antibiotic really take place in the clinical practice. You know, this is a case of a bronchiolitis. Morning we discussed when you are discussing about the respiratory emergencies. The age of the child is between the 2 months to 2 years. There is an hyporesonant lung phase, and just it is in a case of a bronchiolitis. You have diagnosed it is a bronchiolitis. It is not a bronchopneumonia. Where you are starting an antibiotic, really not going to work. If at all, if you start an it is an antiviral. Ribavirin is the drug where you can start that. So these are the way you need to be more cautious. You need to be in even though I am working in a public sector hospital in India, where we don't start an antibiotic to the bronchiolitis. Initially when my postgraduates used to say, sir, you're not stuck. See, this is a viral infection. You are very certain that your diagnosis is a bronchiolitis. Why do you want to start the antibiotic? That's what we need to be. Asthma, case of an asthma, we discussed in the morning. So you know it is a known case of an acute exacerbation of asthma. the role for antibiotic is really not required. So there is no point in starting an antibiotic. You need to be certain that yes, it is a case of an acute exacerbation. I don't want to start an antibiotic. You need to learn that it will come over a period of a time. Dengue fever. Dengue is in so much now it is becoming an endemic. Previously used to talk about pandemic, then epidemic. Now it has become an endemic, almost 365 days in a year across the globe where the dengue cases has been reporting. If you certain that it is a case of any dengue, there is no need to start an antibiotic in that. Acute febrile illness, which is less than 7 days duration, there is absolutely no need unless there is some serious pointer which is pointing towards yes, it is a thing which requires an antibiotic. Viral exanthema. Most of the time, exanthematous fever, it is unless if it is a meningococcemia and something like that, then only you can think about antibiotic. Other rickettsial infection, meningococcemia. These are the very few conditions with viral exanthematous fever requires an antibiotic. Febrile is the majority of the time it is caused by viral infection and which is triggering the thing. No require trauma, which is a clean and it is no open wound and all. You don't require antibiotics. So you need to be very clearer, even though you are working in an emergency department or a pediatric intensive care unit, you should be bold enough to say there is no need for an antibiotic in certain conditions. With this general background, let's come to the few specific clinical conditions where how do we choose the antibiotic rationally in a pediatric intensive care. Community acquired pneumonia is a very commonest thing which we all come across, whether it is in LMIC or in a developed and everywhere. If the age of the child is less than 2 months, you need to cover both gram positive and gram negative. Most of the time it requires an IV antibiotic. There is no role for an oral antibiotic in less than 2 to 3 months, where you can go with either amoxicillin clavulanic acid, or you can go with a cefotaxime or ceftriaxone with amikacin. You can give a 7 to 10 days. If it is more than 2 months, that's the time where you are expecting a streptococcal pneumonia or an H influenza or Moraxella catarrhalis. These are the 3 common bugs which is in that time where you can use an if it is a sick child, you need to cover with an amoxicillin or ampicillin, or depending upon your clinical spectrum, you can 3rd generation cephalosporin. You can consider adding an anti-staphylococcal coverage if you're thinking about anything which is related to the staphylococcal infection. Otherwise, role for cloxacillin does not rise in a routine. If you're suspecting MRSA, when do you suspect MRSA? Suppose if you have a trauma followed by the child is developing a pneumonia, where MRSA is a more likely possibility. If the patient which has been received in a penicillin group of an antibiotic in a last 90 days, that's the time where you can think about it. If you're getting a lot of cases of a MRSA from your community to your ICU, that's the time you can think about an MRSA where you can consider a vancomycin. So, or if your ICU is getting a lot of cases of MRSA, then you can think about an vancomycin. Otherwise, role for vancomycin is very, very limited. If you are using a vancomycin for MSSA drug, it is in a less sensitive. So as compared to that of a cloxacillin or amoxicillin clavulanic acid. And of course, we need to think about severe sepsis where you necrotizing pneumonia and all, where if it is hospital acquired, consider piperacillin tazobactam. Otherwise, routinely not really required in that. And macrolides already in the morning I mentioned, not really required in the routine practice. Coming to the empyema, it is one of the complications of a community acquired pneumonia. Even if you give a loads of antibiotic, it is not going to work out. What really it is going to work out? It is the draining of the pus is a very important. Upfront using of a video assisted thrombus VADs, RNA, you can use an urokinase or streptokinase. If there is a multiple loculation, break that. Draining the pus is the key. And the first line therapy in a case of a staph suspected, you can go with the clox and ceftriaxone. If it is a seriously with the disseminated, if you're not sure about is it a MSSA or MRSA, that's the time where staphylococcal coverage with vancomycin is recommended. Linezolid, it is an antitubercular activity and it can be used in nephro where the renal compromise is there. That's the time where you can use it. Reserve the drug. That is why I'm not mentioning about the linezolid. This is the drug needs to be reserved in a special condition. So coming to the VAP is another thing in intensive care unit. Usually the first line drug, what we use it in our ICU, we go with the piperacillin tazobactam along with an aminoglycosides acid. So only in a case of a suspected MRSA, we give a vancomycin. Otherwise, it is the second line is a meropenem. with vancomycin. Third line, we'll go with the colistin based. So judicious use of an antibiotic is the need of the hour in a critical care unit. Serious upper respiratory tract infection, which are the things which can come, especially following a COVID-19, lot of immunization gap which has been there. So we don't know at which point of time we are going to get in a Corynebacterium diphtheria. We need to be aware the drug of choice in Corynebacterium diphtheria is a crystalline penicillin. The present WHO guidelines also mentions about azithromycin instead of crystalline penicillin. You can go with azithromycin. That's also equally good. But what we prefer in our ICUs, we use it a crystalline penicillin. Mastitis and other ear infection, where amoxicillin with clavulanic acid or third generation cephalosporin is good enough. Ludwig's angina, which is where the Peptostreptococcus is one of the things, clindamycin or amoxiclav, you can use it, and piperacillin tazobactam can be considered as a second drug. Coming to the pyogenic meningitis, in less than 2 months, the drug which is in a newborn period, previously used to use in a third generation cephalosporin and all. Nowadays, the lot of drug resistance to that. Upfront, you can go with the meropenem with amikacin, meropenem for the 21 days, amikacin for the 2 weeks. That's good enough for anything. If the 2 months and above, you go with the ceftriaxone and vancomycin. This is a globally well accepted, but one of the punchline here, what you need to remember is, so in our ICU, we don't get much of in pneumococcal resistance to ceftriaxone. Still, we use a ceftriaxone as a drug. We need to, that's why I said you need to analyze your local data before choosing an antibiotic. But globally accepted is vancomycin and ceftriaxone is the first line for any neuroinfection. And brain abscess, go upfront with an ceftriaxone with vancomycin, or a ticoplanin with metronidazole, because anaerobic coverage is required. Wherever there is a pus, whether it is in the lungs, whether it is in the brain, whether it is in a soft tissue or joint, unless you drain that pus, but just loads of antibiotic, it's not really where you need to drain the pus and rationalize the antibiotic according to the sensitivity pattern. You can give it for 3 to 4 weeks of an antibiotic in abscess cases. Coming to the encephalitis, when you're talking about meningoencephalitis, herpes simplex and encephalitis is a thing where you can use an antiviral drug, acyclovir for 2 to 3 weeks. So other than herpes simplex encephalitis, so acyclovir may not be really that useful. So unless you rule it out, you can give an acyclovir as a drug in that scenario. Gastrointestinal dysentery, so which is requiring an hospitalization, especially Shigella dysentery, and ceftriaxone is the third generation, cephalosporin is the drug, we can use it. Otherwise, if it is a patient is on OPD basis, I am not talking about the OPD drugs, it is a cefixime is the thing. Cholera, you can use an azithromycin or a doxycycline. Given less than 8 years, still you can use, because if you are using it for a short period of time, you are not going to use it for a long period of time, because we had a lot of experience with rickettsia. Treating with the doxycycline does not cause any adverse effect. You can use it. Enteric fever, upfront, now no more quinolone group of drugs. It is the ceftriaxone is the drug, even though in 2018, lot of drug resistance which has been reported from Pakistan. Subsequently, it has been lot of cases which has been noticed in US and other parts. Now, in the last 4 to 5 years, we don't see much drug resistant to the ceftriaxone is concerned. So we can go still ceftriaxone is the drug. If at all, if you're considering a second line of drug, it is an azithromycin or meropenem is the drug, where in a sick children you can use it. Only thing, if you are using azithromycin IV, you need to be cardiac monitoring, intense cardiac monitoring is the key, because long QT interval syndrome, and these are the patients, sudden cardiac arrest which has been noted with IV azithromycin. That's why we need to be cautious if you're using an IV azithromycin. Otherwise, meropenem is a good enough. Of course, peritonitis, you need to cover a good coverage for the streptococcal pneumonia, ceftriaxone or amoxicillin amoxicillin is good enough in that third generation. Complicated UTI, you go with the third generation cephalosporin with an IV antibiotic. If it is an immunocompromised host, that's the time where you can consider piperacillin tazobactam in a complicated UTI. That means I am talking about pyelonephritis. In that scenario, with immunocompromised, so upfront you can go with the piperacillin tazobactam. Otherwise, third generation cephalosporin is good enough. Soft tissue infection is concerned, if your cellulitis, abscess, you need to cover the staphylococcal coverage. basically you need to cover with a cloxacillin or amoxicillin or cefazolin is a first generation cephalosporin. It is equally good, especially with MSSA methicillin sensitive. But remember one thing, if you are thinking about any toxin, abscess or cellulitis, toxin production is the thing where we need to think about the drug which acts on mRNA. Drugs which acts on mRNA is your clindamycin or a linezolide. These are the two drugs which acts on an mRNA. Your whole purpose is to bring down the toxin production. So that is why we need to add a clindamycin or a linezolide. I prefer to use with a clindamycin because linezolide we need to reserve for an anti-tubercular other thing. Osteoarthritis, this is the where staphylococcal and H influenza coverage is required. You go with amoxicillin with the gentamicin. Septic arthritis, once again, with amoxicillin with the gentamicin is good enough. So, and in case of a tetanus, we do get a cases of tetanus in our ICU. So either crystalline penicillin or metronidazole is the drug we can use it because most of the time they do well with these things. Coming to the febrile neutropenia, the drug which needs to be covered is in a gram negative. That is basically it is a pseudomonas and a Klebsiella. These are the organisms where you expect in that ceftazidime with amikacin is thing. If you're thinking about any staphylococcal infection, if there is any clue to suggest towards the TAP, that's the time where you can cover up with a vancomycin, that is piperacillin tazobactam plus vancomycin or meropenem. And febrile neutropenia, which is also in a predisposed for a fungal infection, we need to keep it in mind, amphotericin. If you are using an amphotericin, liposomal amphotericin is the thing, and good hydration is the key. It is likely to cause a renal dysfunction. And if you're using it a renal dysfunction, we need to make sure that your dose is adjusted and good hydration is maintained. You are calculating depending upon the creatinine clearance. So trauma. So some of the guidelines which is related to trauma is concerned. If it is an open, clean wound, amoxicillin and or ceftriaxone is good. Metronidazole can be added only if the patient which is an unclean, severe blunt injury abdomen. Sometimes we don't know intestine these things. That time we need to cover apart from the cephalosporin. We need to cover it the metronidazole. If there is a head injury with CSF rhinorrhea, please cover it in the initially with the ceftriaxone. And post-operative surgical thing, that's the time where we need to cover with an apart from third generation cephalosporin, we need to cover with the metronidazole in that. Surgical things we have discussed about these things. If it is a clean wound, the cephalosporin is good enough. Clean, contaminated, you add a metronidazole. Contaminated wound, cefazolin that is covering a staphylococcal plus metronidazole covering anaerobic organism. Dirty wound, apart from cefazolin, metronidazole, we need to think about a clindamycin also because where it is more likely to have an anaerobic organism also. Toxic shock syndrome. Toxic shock syndrome, if the organism is unknown, you're suspecting a toxic shock syndrome. That's the time where you can go with a cefotaxime plus clots along with clindamycin. Clindamycin is the thing which is required. If the patient which has been already received an antibiotic in last 90 days, which is covering the penicillin group of a drug, in that scenario, you don't wait for a second drug to be started. Go upfront with vancomycin along with the clindamycin. If the known group A streptococcal infection, your simple drugs like a penicillin or ampicillin is good enough, even in a toxic shock syndrome, unless you know the bug, what the bug is. So you cannot choose your antibiotic things. Severe sepsis and septic shock, I'm sure Dr. Vanita is going to cover this one. Just I have to touch upon the antibiotic part is concerned. So third generation cephalosporin along with aminoglycoside, this is the first line drug in a case of a severe sepsis where you don't know the bug, you are waiting for the culture report. And if you are having a trauma, then you are suspecting MRSA as a thing, then you can add in a vancomycin or a ticoplanin. Otherwise, generally vanco or tico is not really required. And to cover the anaerobic things, metronidazole or clinda in a case of a gastrointestinal source of infection. If it is an immunosuppressed, you cannot use in a single drug. You need to go with a combination of a drug where you can go with apart from the third generation cephalosporin and MRSA coverage, you need to add an aminoglycoside or a carbapenem depending upon your culture sensitivity pattern. Children who are at the increased risk for fungal infection in a severe sepsis, there you can consider your amphotericin as a drug for an antifungal coverage. Hospital-acquired infection, this is another thing where we lot of things as intensivist we face it. If it is a central line associated infection, that's the time where we need to cover gram-positive cocci, especially MRSA coverage. And also you need to cover an Acinetobacter, Klebsiella, Pseudomonas. These are the common bugs in a pediatric intensive care unit where you need to cover with a piperacillin tazobactam with that. So vancomycin and antifungal can be used depending upon the what really you are suspecting you can. And other important thing when you are talking about the antibiotic is when do we stop antibiotic? When do you de-escalate it? This is the most important thing. Before antibiotic is started, you have already taken a culture. So you need to relook at the culture after 48 to 72 hours. You look at the culture. If the culture is negative, child is stable, you're not suspecting any infection, you can stop the antibiotic. No need to wait. Suppose there are a situation where you are not sure about that, and where antibiotic which is likely to be infection which is likely to be there, your cultures are negative, then you can scale down further. So you need not to go with an higher antibiotic. That's how you can either you can stop or you can de-escalate your antibiotic depending upon the clinical condition. Indication in general in a vancomycin, when all we use in vancomycin, if there is a signs of serious sepsis along with suspecting a methicillin resistant Staphylococcus aureus colonization, high risk for an MRSA, especially if it is a VP shunt or a central line catheter. In that situation, you need to go upfront with an vancomycin. Central line alone is not a serious indication for that. We need to look at it and other things which is existing in that. Injection for meropenem, it is a signs of serious sepsis, which is a known colonization with either Klebsiella, Enterobacter species, or an Acinetobacter. That's the time where you can, if the patient is already received the third generation cephalosporin, so quinolones or piperacillin tazobactam, that's the time where you can consider the meropenem as a drug where you can use those things. When not to use an antibiotic. This is a very important thing. Most of the things in bronchiolitis I have already discussed in the beginning itself. So if it is a progressing, if the X-ray is worsening, you are expecting any hospital-acquired infection, that is the time you can start. Otherwise, generally, you avoid antibiotic in bronchiolitis. In case of a severe asthma, unless you have an infiltrate, pneumonia, consolidation, no need to start an antibiotic. Only in that situation, you can start an antibiotic in anything. Dengue shock syndrome, even if the child which is having an ARDS-like picture, if the patient is there, no need to start because it's basically ARDS-like picture. It is mainly because of a fluid overload, fluid spillover, where if you have taken an X-ray in a lying down position, that behaves like a thing. Just if you restrict your fluid, that's good enough, no need. Unless you have an inflammatory marker, procalcitonin or a blood culture which is positive, that's the time you can start an antibiotic in dengue. Otherwise, we don't start an antibiotic in that. So if there is a clinical worsening, procalcitonin is rising, culture counts is rising, CRP is rising, that is the time if you are not confident about the things, then you can start. Otherwise, in generally, no need for antibiotic. Exanthem fever, most of the time it is viral, no need. Febrile season, generally it doesn't require the antibiotic, just it requires a paracetamol and clobazam, that too a controversial thing. And antibiotic is concerned, no controversy. Coming to the acute febrile illness, basically we need to look at it, the duration of the illness. Is it a less than 1 week? Is it a more than 1 week? If it is a less than 1 week, without any serious marker, just do the basic investigation. If the basic investigation suggestive of a bacterial infections, like a counts is more than 15,000, polymorphs is more than 10,000, if there is a toxic granule, band params, shipped to the lab, Dole bodies, if you find something which is pointing towards a bacterial infection, that's the time you can start an antibiotic in acute febrile illness of less than 7 days. Otherwise, it is not required. If it is a more than 1 week, second investigations, if you look for a blood culture and a simple antibiotic like amoxicillin or amoxicillin clavulanic acid is good enough. Unless if it is a nosocomial and immunocompromised, then you need to cover a gram-negative coverage. Yeah, I'll be completing. So this is my last line. So antimicrobial stewardship is concerned. I'll not go in detail about these things. What ultimately at the end of the day, when you're deciding about the antimicrobial leadership, whoever the person who has been in charge of either in the ward, OPD or intensive care or emergency, leadership which really plays an important role. Accountability and patient quality should be focused. That's more important. Drug expertise involved in a clinical pharmacist in day-to-day decision making, especially second line drug. And action, which is a pre-authorization. If you are escalating the antibiotic, hospital should have a policy unless you have an authorization from the unit chief or a medical superintendent or a director. You're not going to give the drugs, especially meropenem, vancomycin. These things has to be there. Tracking and monitoring on the progress is a very, very important thing. Reporting and reporting about information regularly to the involvement of a team. Teamwork is a very important. You need to have a doctor, nurses, as well as a relevant clinical pharmacist is a very important thing. Educate the clinician about the disease, state management, and involve a microbiologist into the decision-making process. That really going to play. These are some of the core elements of antimicrobial stewardship. With this, I thank you. Thank you very much.
Thank you, Dr. Basavaraj, for that wonderful lecture there. I'd like now to call Dr. Deepak, who is our Chief Medical Superintendent and the CMS, to present the trophy and mementos for our sessions so far. We can, Dr. Deepak. So we'll continue with Dr. Benita's presentation after we finish this one. Okay, so if I can call Dr. Ranjan up first, please. Dr. Ranjan. Dr. Basavaraj, can I have you up?
Yogesh.
Dr. Yogesh. Oh, sure. Last but not least, Dr. Benita. Yeah. Don't worry, our other local speakers will be getting their awards. I think all of them are busy in clinics at the moment. Yeah, but Dr. Ranjan would also like to have a word.
As the chairperson of the IAP International Liaison Committee, it is my pleasure to acknowledge, appreciate, and thank the people from the American Mission Hospital, starting with the Chief Medical Superintendent, Dr. Deepak, and Dr. Vanita, who was the main person who was liaisoning with IAP, Dr. Muhammad Salman, who has been very active in this endeavor, and of course, the CEO Dr. George Cherian. He's out in the USA. He expressed he was feeling very bad that he wasn't here. I said, Dr. Deepak is there, Dr. Vanika is there, and we all have the well-wishers here. This is an endeavor from the last 2-3 years. We have been doing this, expanding IAP beyond the borders of India. We have had MOU with Bangladesh, Nepal, and we are active with we have started now with the Bahrain. Oman is also very actively involved with IAP, and we tend to do this thing more often and with more countries. So it's a principle of giving and taking. That is how we feel that we should progress. And as a token of our appreciation, we would like to honor Dr. Deepak. Dr. Vanita was the mitochondria of the whole project today, and we sorely miss the presence of Dr. Cherian, and we transfer the mementos to him. But Dr. Muhammad Salman, you have seen, he was one of the most active person in the whole program. So I hope this cooperation and commitment will grow to newer heights in the days to come. Thank you.
May I request the people here on stage to remain on stage? And may I also ask Dr. Brahmara to please come up onto the stage? Just thought of informing, and as most of you know, you would have seen there the two logos on the top, the Indian Academy of Pediatrics and also the American Mission Hospital. A memorandum of understanding has been signed by these two organizations to better the clinical education here in Bahrain and to encourage the pediatricians to be able to improve themselves and continuously educate themselves on the field of it. So in this connection, the memorandum of understanding is here. So we will just have a quick photo shoot with the president of the IAP, Mr. Baswaraj, and Dr. Deepak Abraham.
The black side on this side. Black face.
No, it's okay.
Thank you. Thank you, everyone. I think, yeah.
One speaker.
Yep, we have our last but not least speaker, shall I say, the most anticipated double session. We have Dr. Vanita coming for our final session now. She's a consultant pediatrician here in American Mission Hospital in Bahrain, with over 25 years of experience in both pediatrics and neonatology. She also is the author of over 20 systemic Cochrane Review publications and the editor of Focus Atlas Junior. She'll be presenting two topics back to back, so I will not introduce her again. But she'll be presenting approach to pediatric sepsis and septic shock, followed by focus as a multimodal tool in septic shock. So Dr. Vinitha, the stage is yours.
Thank you, Dr. Sana, for the introduction. I should thank the audience. This is the concluding session, and the audience is still lingering in the auditorium. A big thanks, because I recognize that. I think should be okay. Okay. I hope to do justice for the fact that you all stayed back to the last session. My topic is approach to sepsis and septic shock. The objectives, before starting, I should declare I have no conflict of interest. I'm part of IAP, I'm part of AMH. I'm an avid Focusian. I could be biased towards focus and use of in wherever I would talk about, but nevertheless, no conflict of interest with the topics that I would be talking. I would be quoting the relevant evidence wherever I'm talking. So objectives, defining sepsis and septic shock, critically appraise the evidence and the literature regarding various aspects of shock as in surviving sepsis campaign 2024, fluid therapy, vasectomy therapy, hemodynamic monitoring, antibiotic treatment, and a little bit about life after sepsis. At the outset, I'll open the thought. There's no polling, but I would ask you to, amongst all the interventions listed, which do you think has the highest impact on sepsis management? Fluid therapy, vasectomy management, antibiotic therapy, hemodynamic monitoring. I'll leave you for your thinking on this. I will proceed. Sepsis, I'm sure everyone, whoever we are in the ER, the nurses, the pediatricians in the ICU, I'm sure everybody has encountered it and everybody has been challenged regarding this particular complex phenomenon. What's the need to define sepsis? We all are aware of it, and we all are aware this is one phenomenon which has posed a challenge in every critical diagnosis. It masquerades as just about everything in a critical encounter. So that brings us to compiling all the challenges from different parts of the world, of different settings like LMICs, well-developed ICUs, ERs. Everybody should be able to see a common forum as to what sepsis is. And this is the reason sepsis happen to go through many phases of defining and redefining. Let us see how that happened to evolve until 2024, where it has landed to Phoenix Sepsis Score, which has happened to define by far the best way of defining sepsis because it assesses some bedside assessment to define sepsis. So the key points of this Phoenix Sepsis Score, which is the latest sepsis definition, how should suspected infection children who are critical be identified as sepsis? This is based on millions of sepsis encounter data, and it is data driven. That's the beauty of this particular definition. So to trace the definition through the stages of different years, beginning from time immemorial, Hippocrates happened to think something rotten It's not too wrong. And until of late, it was something caused by infection and the complexities that the body encounters with infection. Can you see the bottom one? I know it when I see it. That's one of the definitions. Still, some people would be falling back on. So it's a leading cause of death among children. Around 2005, something akin to pediatrics happened to be part of Surviving Sepsis campaign. And 2016, which has shaped up the sepsis definition as in the present format, wherein we talk about it being a life-threatening condition and its dysregulated immunity, not just the infection. That's the primary source of concern. And in 2024, that's the current definition we are going to elaborate on, stands here. This is called Phoenix Sepsis Scar, basically because it was defined in the Phoenix Convention. It took data, as I said, millions of sepsis encountered. It's undisputable because of the amount of data which backs up this definition. It is from all the sources. You can see the 4 low resource sites, Bangladesh, China, Colombia, and Kenya, apart from US, which populated this data. And this database, not just simple, complex mathematical evaluations of this objective data, happen to be the source for populating this definition. So what it basically did was to recognize the importance of which organ dysfunction to contribute to mortality suspicion from any sepsis, so-called sepsis encounter. So mind you, it's become objective. You can see how it is utilizable at the bedside, saying that it is a life-threatening complication of infection which is dysregulated immunity. How can we apply at the bedside to define? It's probably not so easy to conjecture defining it on the bedside. To give it a practical notion is how Phoenix proposed this, and this is the current sepsis defining platform. So it has recognized the importance of 4 organ systems: respiratory, cardiovascular, coagulation, neurological, and has objectivized the severity of individual organ function in points. And it is given the able points to each severity, and cumulative scoring is how you would define. Septic shock, in the same way, would be, in addition, the involvement of the hemodynamics, that is the cardiovascular system, wherein only 2 factors, the vasoactive medication inclusion and lactate scoring. So we can see with simple biochemical measures and some clinical evaluation, you have how you can define, and this is really practically applicable. So what is Phoenix sepsis criteria? Sepsis is defined as more than 2 points. You can see, you can note, actually it utilized 8 organ dysfunctions, but the other 4 were taken away. You can note that the liver, the kidney, and all are taken away from the scoring, because using these scores, you can capture the diagnosis of sepsis as good as including them. So what sepsis? Sepsis is any more than 2 points in this group, and septic shock is inclusion of 1 additional point in the cardiovascular group. This is how septic shock is defined. This is the current Phoenix sepsis score. You can note it used to be a continuum. We used to begin with SIRS, which is no longer included. And there used to be convention to bifurcate sepsis as sepsis and severe sepsis. Everything is removed and it's simplified to just 2 categories, sepsis and septic shock. It's not necessary to call sepsis as severe sepsis or sepsis, for the reason sepsis itself is life-threatening. So as things stand now, sepsis is any of the organ dysfunction from the listed organ dysfunction, scoring more than 2, and septic shock including the hemodynamic instability. So how would you use this as an algorithm? So to algorithmize any unwell child, you screen for sepsis. Mind you, for early diagnosis, this is not a definition which is going to be useful. This is to delineate sepsis as a defined entity. So for early diagnosis, whatever tools we are still using remains standard. We would be using sepsis definition as a new Phoenix sepsis score only. So you screen for sepsis, parallelly do antimicrobial treatment and organ support as needed. And as you suspected sepsis, you assess for organ dysfunction as listed. And if a score is about 2, you are meeting the criteria of sepsis, you parallelly administer all the other interventions like antimicrobials, organ system, organ support and transfer to ICU as needed. And if you have additional cardiovascular support needing, it would be configured as septic shock. Okay, that brings me to the actual focus of what we are doing. Actually, the topic was designed to be an intensivist to present approach to sepsis, but I took over. So I am basically covering critical appraisal because we know we have broken down the steps and we know the 6 steps, and there is a lot of criticism and appreciation for individual steps. And as I opened the talk, which intervention amongst these all, we wouldn't really know which one is doing the most optimum result impact. So we know obtain IV access, collect blood culture, start empiric broad spectrum antibiotics, which was very broadly covered by Dr. Basavaraj. You measure lactate, administer boluses. This is where a lot of changes have happened. This is some sticky point we will discuss further in the discussion. And start vasoactive agents. Most of them are indisputable. Empiric antibiotic happens to be globally one of the interventions which has transformed the landscape of sepsis. But there are all the other, we call them bundles, all the other interventions concurrently you initiate them to have an impact. There is the time frame proposed by the Surviving Sepsis Campaign. If it is septic shock, within 1 hour, initiation of all the concurrent steps. And if it is suspected sepsis, you still have time to manipulate all the interventions in a 3-hour bundle. Having said this, we will explore each part of this in the subsequent critical appraisal. So the sequence was until of late ventilation, infusion, and pumping, which has been reframed to be infusion, ventilation, and pumping. Infusion happens to take over. Ventilation can still be managed with non-invasive measures. Ventilating a partially perfused or partially infused child is a disaster. Any intensivist can hold the evidence for this. So fluid and vasoactive inotrope management, again, presence of intensive care in your setting or absence of intensive care in your setting makes you to decide which arm you would go about. The basic difference is because there are lots of de-resuscitation means that one has to do if you salvage a sepsis. And this cannot be done very well when you do not have resources like ICU. And for that reason, ICU presence or absence has a different way of approaching, basically in the fluid management. So I'll touch upon it in the subsequent discussions. I do not want to duplicate it. One point to note, the WHO definition of hypotension has different convention. Please note this, and this is because permissive hypotension is the thing that promoted in interventions. So hypotension is 50, 60, and 70 systolic blood pressure. It is different from PALS for the age groups less than 12 months, 1 to 5 years, and more than 5 years, or all the 3 perfusions. So hemodynamic instability is both the blood pressure and the perfusion. And in the perfusion, if you have all the 3 parameters without the adherence of the blood pressure convention, we can still call it a shock. So this needs to be kept in mind, and this has transformed the landscape of how we manage a little more conservatively as regards fluid management. So this is the thing about resource limited setting, and this is the thing we are expected to adhere to. So I will list up the therapeutic endpoints whenever we are addressing sepsis and septic shock particularly, so that we debate about these points as we go about the evidence that's about these matters. So the safety of less than 2 seconds or equal, normal pulses, good quality. And without this, we are asked not to rely on the non-invasive blood pressure, good warm extremities, urine output more than 1 ml per kg per hour, normal mental status. This is a very useful objective marker. Normal blood pressure, as I said, only reliable with vital pulses, normal glucose and ionized calcium, not to forget these biochemical parameters. That brings me to various surviving sepsis campaign factors amongst the listed interventions. And I have listed the evidence level, and I'll discuss the further points. So in healthcare systems with available intensive care, administered up to 40 to 60 in boluses of 10 to 20 over the first hour. You titrated over the clinical markers of cardiac output, discontinue when fluid overload develops. This is not so easy to assess and intervene. We will look into various measures like point of care ultrasound, which assists us to be in tandem with these instructions. And we'll see the nuances of this instruction and where the quality lies as we proceed. In healthcare systems with no availability of intensive care, absence of hypotension, we recommend against bolus fluid administration. This is a point we should note. And in healthcare systems with no availability of intensive care, if hypotension is present, we suggest administering again in the similar fashion and discontinue when fluid overdevelop. Note that we stop it at 40 ml per kg in the 1 hour. So all are weak recommendation except the one which dissuades us from giving bolus when there is no hypotension. It is a strong recommendation of surviving sepsis campaign regarding fluid therapy. So what is it with fluid therapy? Rapid fluid administration, this is an adult recommendation of 30 ml per kg of ideal body weight. This has to be initiated within first hour. Mind you, this is an adult recommendation which is derived from pediatric recommendation. It has been downgraded from strong to weak for the reason that they recognize the boluses are doing more harm than good. And it's not very simply put, it has the nuances. It's a Jekyll and Hyde. What is beneficial has the other face, and we will see what's the other face. So what's the evidence of fluid in fluid therapy? It's a rationale, it's an assumption that septic shock is a situation of hypovolemia, and fluid therapy will augment the cardiac. This is the whole reason why the fluid boluses are given based on Frank's Starling curve. And we assume lactic acidosis means it's hypoperfusion. Whereas there is one study which dispelled this myth. This one study changed the whole rationale behind fluid therapy. This is a randomized controlled trial based in Africa. It's a multi-center controlled trial. Mortality after fluid bolus. This was studied. And this study is called FEAST trial. Everybody in the intensive care podium would be aware of this study. You can see the graph, the albumin bolus, saline bolus, no bolus. You can see hands down, the no bolus one had, there's a wide gap of bolus and no bolus, and the crystalloid and albumin debate can come to it later. The fact that no bolus had more survival, had a survival benefit, transformed the thought of using boluses in septic shock. So the other studies of effect of early resuscitation protocol in hospital mortality, again, exemplifies the same factor. And after resuscitation, later administration in hospital, in ICU, also does not show any survival benefit by using IV fluids. So there was a comparison of conservative versus liberal approach. What we mean is giving multiple boluses in once upon a time until last decade, giving lots of fluids was the background of managing septic shock. And over a period of time, this has evolved to be what needs to be done on the grounds of sepsis or septic shock. You need to know not all septic shock patients are fluid responsive. This is the assumption with which we began. If we give fluids, it will respond with increase in cardiac output. And that's the reason we will start with giving fluids. But half the children who we treat with fluids do not respond. These are called as fluid unresponsive. So there's no point in giving fluids. But what's happening, the flip side of the fluid accumulation syndromes are also evolving. So fluid challenges are ending up with so many unwanted side effects which are clubbed together as fluid accumulation syndromes. And that is the defining point of trying to be conservative on fluid challenges. So how could fluids be harmful? Why are we debating this point? In general, we should know sepsis is not a hypovolemic state. The main pathology here is vasoplegia, and there is microvascular dysfunction. The glycoprotein, we all are aware of it. And what happens to all the fluids we are giving? They're getting third space. And what happens to third spacing? It causes tissue congestion, which again contradicts whatever we wanted to do. It is not letting the perfusion to be on the positive direction. So another phenomenon, fluid boluses cause vasodilatation, which is again self-defeating. Some patients develop cardiomyopathy as a response, which is non-ischemic response to the fluid boluses, which is sepsis-induced cardiomyopathy as well. So this is one of the studies from Dr. Sachitra Ranjit. This is exemplifying all the plus and minus of what happens when we give fluids. All the green ones are it improves the perfusion as imagined. But what's the flip side? Any organ, wherever it's congesting, it is causing the damage. So when we decide to give fluids, what are the fluids to give? Crystalloids or colloids? The debate is tilted towards crystalloids. It is said that both have the same benefits. So the cost of albumin would be the deciding factor. So crystalloids is a choice. Amongst the crystalloids, normal saline or buffered solutions, it is done in repeated studies. Any one of it is okay as the Surviving Sepsis Campaign suggestion, although repeated studies have tilted the favor towards buffered solutions. So isotonic saline is the most commonly used crystalloid, although the recent studies confer some benefit towards the balanced fluids. So these are the various studies towards which fluids. One is still ongoing, and they have anyway decided it has to be a crystalloid, and there have been harms with some of the colloids. Albumin is still one of the choices, good benefit with certain situations. Of course, our Indian scenarios, some situations like dengue and shock, which is masquerading both like sepsis and septic shock with similar pathogenesis like third spacing, it would still be a useful option. So effect of IV fluid with balanced solution on mortality, both are going hand in hand. So the choices decided by Surviving Sepsis guidelines to be any one of the two. Amongst the hemodynamic monitoring, the SSC says we are unable to issue a recommendation as to what should be the target. There have been adult studies to target a lower map of 50th centile or map of 5th centile. So the debate has, with some weak recommendation, it is tilted towards between 5 to 50th. Whereas in the adult, it is stationed to 65. They've studied a 80 map to 65 map, and they've seen as good response. So the suggestion is to go for a lower map. And bedside clinical signs cannot be utilized in monitoring once the child is determined to be septic shock and the interventions are already planned. You will have to have proper monitoring. Amongst the non-invasive one would be a focus managing of hemodynamic monitoring, which I'll talk in the next one. The trends of lactate, a single measure cannot inform you much. Lactate trend, lactate clearance is what is used as hemodynamic monitoring. But lactate is not just because of perfusion. This caveat needs to be realized. So I showed the WHO convention for defining hypotension, and on the top is the WHO suggestion of the MAP target for different age groups. It's 55 plus age into 1.5, and you get an equivalent number. It is above 5th centile, below 50th centile, roughly to titrate. So what's a MAP target again? So we said low target is good enough. So what do the studies say? They studied both the low target and the high target interventions, and the survival benefit tracking along the same line. So what does it mean? We don't have to make extra interventions to reach the higher target. A lower target gives you equal benefit. Apart from that, the side effects of higher target interventions can all be minimized, including some arrhythmias and atrial congestion. So higher MAP did not improve the survival rate. AFibs were more common and RRTs were more required when you're using interventions to reach the higher target, although this is an adult study. So caveats to follow lactate levels, lactate clearance more than 20% would be the suggested norm to say that it is working. You should know this is not the only perfusion which is informing you the lactate levels. That is one of the caveats. There are studies like Andromeda, which is equating bedside evaluation of just CFT, which can be more frequently assessed. This would be 4 hourly or so, the convention. So that can be done 2 hourly and would give you equally reliable information. Amongst the vasoactive medicine, what's the debate? Dopamine is out of the complete utilization. Even the low middle income countries are no longer using dopamine. The choice is epinephrine as regards pediatrics, but either epinephrine or non-epinephrine is the choice. Vasoplasia is increasingly being recognized as the basic pathology in septic shock, and that makes the first choice. So after administering, how would you manage the observation? Again, bedside evaluation would not be sufficient is what the recommendation is. So a word about sepsis in the heart. It is not just the vasoplasia. There is an effect on the heart. There is something called a Starkle-Stilbo, which happens because of severe vasoconstriction. So vasoconstriction of myocardial circulation can lead to something like this, and global ventricular dysfunction as well as ventricular dilatation and diastolic dysfunction. These are all the evolution of changes in the heart, and that is also something we need to keep in mind. Using vasoconstrictors can be contradictory to the effects that's expected of a heart in the whole big picture. So early use of norepinephrine, we all know the algorithm. We start with fluids and we expect a response, we hope for the response, and we can repeat the boluses until the response. Depending on your situation, ICU, no ICU. And when you reach 60 ml per kg and you still don't have a response, we label it fluid refractory. And that's when you go for vasoactive medication. But is there the studies have studied, you start with fluid, you perfuse the system, but there is something called as venoplegia also that's affecting the whole pathogenesis. If we nudge this system into action, we probably can salvage the whole scenario much better. So with this perspective, a lot of studies were made to use early norepinephrine before labeling it fluid refractory. We start with fluids. We know the harms of fluids by now. So we start parallelly. By the time we administer one bolus, get started with norepinephrine. Would that make a difference? It did. So the recommendations in adults have already changed to start with fluids and get started early with the vasoactive medication has a lot of survival benefit and confer de-resuscitation help for the ICU transfer also, because you would not have done too many IV boluses. Can it be given in the peripheral circulation? This is to be the reason why you wouldn't do an early vasoactive medication. You would have to set up a central line before getting started. But studies have been done, local tissue injury and the harms of peripheral vasoactive medication are minimal and can be a choice if you can start vasoactive medications in the local, in the peripheral circulation. The caveat here is cannot be continued beyond 24 hours. That is what is the norm. So you can use in a big enough vein, something proximal to cubital fossa, and can be administered in the peripheral circulation with a bit of dilution as the norms suggest. Antibiotics. This, if I talk anything about this, it would be a reputation of more judiciously covered by Dr. Basaraj. In any case, I will list up the mention of antibiotic therapy in SSC. In children with septic shock, indisputably, starting antibiotic therapy as soon as possible. The timeline has been defined within 1 hour for septic shock and within 3 hours for sepsis. In children with multi-organ dysfunction, 3 hours has been stipulated to be the timeline. And empiric broad spectrum, this was the rationale behind this was already covered by Dr. Basaraj. And once the pathogen is determined, de-escalate, narrow down the spectrum and get to the right antibiotic. If no pathogen is identified, we recommend narrowing based on other markers and the comorbidity factors. So timely administration of APRO. What was the rationale behind 1 hour, 3 hour? Are there studies to support it? There have been retrospective data evaluation as well as assessing early and very early administration in sepsis as well as septic shock. And you can see for every hour delay, this was talked about in Dr. Basaraj's discussion. For every hour delay, you can see the survival curve shifting, skewing up beyond the survival determined by proper timely administration. So aggressive versus conservative. So what this means is giving very early, again, quasi-experimental studies were done. The objective data as to improvement in outcome between the two groups was minimal. What this means is giving very early is not conferring any benefit, not just with mortality, with other factors as well. So it gives you room to, in fact, it is better to analyze every information before deciding on the antibiotic, and that scenario is more profitable as regards decision in antibiotic again. So not just the timing, administering antimicrobials is indisputably one intervention which has transformed sepsis. It's not just the timing. So more important questions are the appropriateness, which was discussed in the previous discussion, and other comorbidities based on suspected site, invasive devices, local prevalence, etc. The decision that is choosing the appropriate antibiotic, which is more important. Final wrap-up, sepsis, early detection and institutional antibiotic is important. Although new recent definition, Phoenix sepsis score, does not touch upon early definition, it streamlines bedside evaluation of deciding sepsis and septic shock. Only about 50% of patients in the septic shock are fluid responsive. Be mindful of this. The management as regards fluid has dramatically changed over a period of time. The harms of fluid have been increasingly recognized. Fluid de-resuscitation is the thing intensivists talk about. Restrictive fluid strategy with early use of vasopressors. This is a strategy which is pitched to be the most important change in the recent surviving sepsis guidelines. And balanced solution, normal saline, either of it could be okay. Targeting a map between 5 to 50th centile is the suggestion based on various studies that have been recently done. A word about life after sepsis. We all know the Surviving Sepsis campaign has made a dramatic change on the survival. But what happens to the survivors? Sepsis survivors have a huge readmission rates. They have a cognitive decline post-sepsis. Readmission rates are ridden with greater mortality as well. Amongst the readmission, the problems encountered are recurrence of infections, longer duration of antibiotic therapy, repeated exposures, and we all know what are the flip sides of re-exposures, and lower hemoglobin with recurrent admissions. And what are the cognitive decline and neurological complications? ICU-acquired paralysis, cognitive impairment, functional disabilities, poor quality of life, we can imagine that. Outcome of sepsis and septic shock, mortality is definitely declining over time, but shock and multi-organ dysfunctions are also increasing in its incidence. Survivors of sepsis have increased mortality within the 1 year of discharge and at least 8 years, and decreased cognitive abilities and health-related quality of life. So that brings me to the end of the topic, and I have to sustain by going to the next topic. I will not take a break. I'll proceed to the next topic, which is in the same vein. It is POCUS as a multimodal tool in sepsis and septic shock. Basically, I touched upon the definition of the sepsis and septic shock as things stand now, and various interventions in sepsis, although I didn't go to the nuances of the interventions, I touched upon the pros and cons and what's the evidence behind it. Now, I will talk about using POCUS as a multimodal tool in sepsis and septic shock. POCUS is point of care ultrasound, and how that helps. We have lots of POCUSians in the auditoriums. It's the new thing that has evolved over the last few months. So this will be more increasingly recognized as a topic. So let me go to the topic. I'll have to end this show. Sorry for taking that break. Let me put it on the slideshow. Okay, so POCUS is point of care ultrasound, how we can utilize it as a tool in sepsis and septic shock. The objectives of this talk is introducing POCUS and whole body ultrasound, how it can help in sepsis and septic shock. Parallel this with certain elements of surviving sepsis campaign that we talked about just now. What are the basics? The lung ultrasound, the IVC, the cardia, and velocity time integral, which should be necessary to track the sepsis and septic shock. What's volume responsiveness? What are the dynamic indices of monitoring the sepsis and septic shock? A word about VEXAS, which is a new thing that is part of evaluation of sepsis. A sneak peek into beyond the basics. This would be construed as basics and POCUS, and a little bit beyond the basics if I still think that would be necessary. Okay, point of care ultrasound, a multimodal tool. This is one of the references. How it can be used as a tool. It can touch upon diagnosis, treatment and monitoring, and therapeutic management. We can see sepsis can have various manifestations. Source identification is one of the most important thing that is necessary in management of sepsis, because whilst we are managing sepsis along the lines, 6 lines, one of the expected thing out of us is to identify the source. And how that can be helped by point of care ultrasound is you can do lung ultrasound to determine pneumonia. You can check on effusion. You can do abdomen and pelvis ultrasound to look at free fluid and any accumulation which will configure the source identification. Cellulitis, abscess, necrotizing fasciitis have definite applications to determine in POCUS. In musculoskeletal, any septic arthritis, the effusion can be determined. Then thrombophlebotitis and peritonsillar abscesses are all sources that can be identified. So in the diagnosis arena, POCUS is a very important tool. In the differential diagnosis of shock, we all know 4 types of shock. By far, this seems to be the best tool to distinguish these 4 types of shocks. And in sepsis, if there are complications, we could be encountering very many sources of shock, and distinguishing that would be one of the assistance POCUS can make for you. And when you do decide it is sepsis and you start managing, when you're managing, this is the most useful thing, fluid treatment and monitoring. So hemodynamic assessment as regards fluid responsiveness, we saw half of the fluid administered babies do not respond. They do not, so the fluids that are given are just going into the third space and they are going to cause harm. So having any intervention which can predict this would be of utility, and you can imagine the great amount of help this particular tool can have on the interventions. If you can foresee fluid responsiveness without giving fluids, you're not doing any harm. You already know this situation cannot be salvaged by giving fluids, and you will move to the next interventions. And that's one of the very useful utility of POCUS, fluid responsiveness, and we will discuss that in a little more detail. So in therapeutic management, if you've identified sources like effusions, pleural effusion, pericardial effusion, you have ultrasound guided ways to drain these sources. So source identification, hemodynamic monitoring, fluid treatment and monitoring, therapeutic management. You can see the whole body ultrasound has a intricate intertwining with management in ICU. So this seems like a good roadmap. You can have a clinical suspicion of sepsis. You can have identification of the differentiation of the shock as we talked about. You initiate empiric treatment. You can have POCUS guidance for hemodynamic assessment. You can have POCUS guided sepsis source identification, POCUS guided interventions like draining, as I said. You can make further decision making. Abnormal, this is one of the surviving sepsis guidelines. Let me take you back to the SSC guideline. If there is abnormal perfusion with or without hypotension, we have an ICU. What's the intervention? You give boluses. If signs of fluid overload is absent, you give fluid boluses. Repeated assessments have to be done, and once shock resolves, you stop. You consider assessing cardiac function, and you consider vasoactive medication once the fluid overload situation is encountered. Can you see very many situations here which cannot be just clinically determined, but yet we are asked to make these initial decision making based on the clinical evaluation. If we have means of assisting this clinical evaluation, which is more objective and which gives you more confidence to intervene in the direction suggested, it would be something of the expected interventions without causing complications. So how do we do that? So this is one of the papers again quoting Dr. Suchitra Ranjit, Best Fit T3, a tired monitoring approach to persistent septic shock. Here, this is a pilot study using advanced ultrasound and non-invasive cardiac output monitoring. Initial fluids and vasoactive agents are titrated with some basic echocardiography, which any pediatric graduate can train themselves in a short period and utilize it on bedside. So how it is proposed to do, if you're having a situation where you're trying to salvage with boluses, if it is unresolved, this is where you introduce this particular intervention, the components of which I will show in the subsequent slides. Lung ultrasound, IVC, heart function. So in the lung ultrasound, you're seeing A lines. A briefing about this would be necessary for the uninitiated audience, but I would summarize, having A lines would mean it's a dry lung. Having a collapsing and pulsatile IVC would mean the fluid responsiveness is there. Having a good cardiac function is giving you confidence that there is a heart which can take more fluids. So you have a scenario where you assess all these three components, you know you can give fluid bolus. And you have a scenario where those A lines are no longer there, but you are seeing B lines, you're seeing a fuller IVC, but a poor contractile heart. So this is a scenario which is prompting you to start inotropes. A scenario where lung A lines, IVC again, pulsatile and heart function good. You can see this permutation and combination is much similar to what we saw before, where lung A lines, IVC pulsatile and heart function good. Exactly similar situation, but with the clinical parameters of the BP and the low diastole, you already know this is vasoplegia and you are going for presses, and once the situation warrants, the inodilators. So basically with these three parameters, as I said, are not very difficult for anybody to train themselves, and checking on lung A lines, B lines, checking on the contour of IVC and its respirophasic nature, and checking on the cardiac contractility, putting it all together, you can decide on whether fluids or inotropes or presses, which are the three primary interventions, and timely decisions on these three aspects can be made at the crucial time. So what are the PUCAS applications in sepsis? Assessing the cardiac output, as I showed you. A gross eyeballing of the cardiac function is sufficient to make the decision. Apart from that, certain nuances which I'll discuss would be an additional factor to help your decision making. So volume status, volume responsiveness, this is a very important thing. Otherwise, other cardiac function assessments would also assist in your decision making. The IVC on the left, you can see this is an inferior vena cava draining into the right atrium. It is pulsatile and it's narrow. Whereas the same IVC, you can see here, this is called a plethoric IVC and it's no longer pulsatile. So looking at these two, you can say this one can take fluids. This one, you would stop short of giving more boluses. This is the situation where you have reached the fluid overload that the surviving sepsis guideline is asking you to caution about. So the next application is the echo. This is called as the parasternal long axis view. What you will see is the cardiac activity based on the the vigor with which the heart is functioning. Just the eyeballing, you can see this is a good enough heart. And this is a apical 4-chamber view where you can see paradoxical movement of the interventricular septum already. So this is a heart which is not as good by visual estimation. This is a lung. You can see these horizontal lines are called A lines. This means the lung is dry and well aerated. Whereas here you can see a lot of vertical lines, and these are supposed to be suggestive of presence of fluids, and these are called B lines. So basically, it's titrating based on these three applications. One suggestion was to use only the IVC. In intubated patients, it's different in an intubated and a non-intubated. You will be seeing distensibility and collapsibility, and the norms are different. I wouldn't go into the details. Basically, based on the IVC, the A lines, B lines is how you decide whether you can go ahead, green for crystalloids, whether you'll be cautious, and whether you will stop giving boluses anymore. So to algorithmize, if you see a IVC collapse, more than 50% respirophasic, I will come to the passive leg raising a little while later, and lung ultrasound, no B lines. So you can go ahead and give fluids, and this is said to be fluid responsive. We will talk about responsiveness a little while later. IVC normal, full with minimal respirophasic and presence of B lines, it's a caution. You discontinue fluids and consider vasoactive agents. So this, to summarize, crystalloid would be necessary in an IVC finding where it is respirophasic. When IVC is full and a good LV, it's the norepinephrine. IVC is full, bad LV, it is inodilators. It's not as simple as that, but it is to algorithmize paralleling POCUS use in your interventions. The intensivists in the podium would know the complexities of using this, but I'm just touching base with how it can be utilized. So the concept of fluid responsive versus fluid tolerant. We have to give fluid when we know the volume is contracted. There is a need for expanding the volume. But if the volume is leaked all over, we know intolerance has already begun. Classic scenario, dengue. There would be shock, but the child would be edematous. Child will be having a big labor. Child will be, this is the classic challenge an intensivist has back home. So here, you need to give fluids because there is shock, but there is fluid all over. It's a scenario of fluid intolerance. So you can see scenario A, this is what we believe. We give fluids, we'll reach the intolerant state in a while later, and we keep giving fluids. But actuality, our hope is this, both responsiveness and the tolerance is on the same point, but most scenarios in critical care, we've already crossed the intolerance and we would still need the fluid. So these scenarios are titrated based on these applications I said. So fluid responsiveness and fluid tolerance are two pendulums keep shifting to either side, and we will have to navigate this narrow zone whilst we are administering fluid because we already recognize the harms of fluid. So there is another component called as VTI. I will just show you how that is also a simple means by how it can be measured. And we can titrate, this is configuring which type of shock. We are focusing on addressing our septic shock. So cardiac output is the area, VTI, I will show you what it is. It's cardiac output, heart rate measured into the velocity of the flow in the aorta, where everything is a constant. Only VTI is a variable. So you can use VTI as a surrogate for cardiac output. So what exactly is VTI? We use some we do apical 5-chamber, we use pulse wave Doppler, we make repeated measurements, and we get a figure called as VDI. We manipulate the pulse wave Doppler gate in the left ventricular outflow tract. And when we measure, what we get is the velocity time integral. We track the graph, it's the distance of this graph, which is somewhere about 16 centimeters. So we use this measure. This will give a surrogate as to cardiac output. So how we utilize it? If we give fluids, what we intend increase in cardiac output. Do we have a ways of predicting this? We give fluids. Without giving fluids, can we get a hang on increase in the VTI or increase in any of the markers to predict so that we can give fluids and avoid fluids in situations where it's not responsive? So this is what it is. Fluid responsiveness is increase in stroke volume, at least 20% with a standardized bolus. This is in an adult 500 ml fluid bolus or a passive leg rise. A passive leg rise is, I will show you what it is. It simulates a scenario where you don't give fluids, but it will mobilize the fluids in the lower part of the body. When you do these maneuvers, they shifted into the system, will serve as giving a 500 ml bolus. So there will be increase in the stroke volume. That will give you an idea as to how your fluid bolus can be of use. If there is no change, that already cautions you that the fluids are not gonna do any improvement in the scenario. So this is the passive leg raise. This is the one which has been configured for utility in these scenarios to assess the fluid responsiveness. So semi-recumbent, you make him recumbent and then go for 45-degree passive leg raise, all without disturbing the rest of the scenario. And you measure the same VTI or surrogates like carotid output also can be, carotid index is something which can be also measured. There is a difference of 12% increase, would tell you you can do this. The advantage is in spontaneous breathing, you can utilize this. Most of the other measures of fluid responsiveness require a strict control conditions, but here this can be used for spontaneously breathing children. With that, we can cluster into, basically, we are utilizing the same information. Can we give fluids? Can we give vasoactive medications? Can we give vasoconstrictors? This would be the decision you will be making. Recognizing the fact that sepsis shock is different phenotypes, and putting 2-3 parameters together, you can recognize which phenotype the particular category belongs and plan your intervention. This is basically leading to the intervention based on the clustering. And in summary, would be like when you encounter a low blood pressure scenario, if there is obvious fluid loss, of course, you will not use the fluid responsiveness test. You know there is a need for fluid. You pump in as much fluids as you would have decided the losses. And then if it's not the similar scenario, there is no fluid loss and it's a septic shock you're contemplating, this is when you use the fluid passive leg raise test. And if you see the responsiveness, you can go ahead with fluid management. So this is one of the study. It's a meta-analysis of various ultrasound-guided fluid resuscitation. It, of course, concludes ultrasound-guided fluid resuscitation in patients with septic shock is ultra beneficial, especially when using IVC and PLR, passive leg raising, combined with echocardiography. So that brings me to the tier 3 that the Dr. Suchitra Ranjit's publication was talking about. You recognize the importance of other things like diastolic dysfunction, like tissue congestion, venous congestion, to be contributing towards the septic shock. So what about tissue congestion? We can imagine venous congestion, that is because of capillary leak or venoplegia. Any venous congestion can contribute again in the same direction as not allowing any positive perfusion effects and diffusion is compromised. So the major organ systems which can get compromised, of course, the heart and the brain, but the assessment available, the windows available are the easiest window is the portal vein. If you see a congested, a plethoric IVC, you can use this application. If you notice the particular suggestion set in the VIXs, it can guide you as to de-resuscitation. De-resuscitation is a very important concurrent steps that an intensivist takes after salvaging the resuscitation, and VIXs contributes much towards its help. So evaluation, including lung ultrasound and VIXs, finally streamlines this in a better way. So this summarizes various ultrasound applications in different situations, particularly noting the perfusion and such, and how it can utilize, it can inform us in tandem our intervention means in an intensive care. So I thought of touching upon beyond the basics, which I don't think would be a platform for. I will talk about the salvage situation, a septic shock which is rectified, then it was resuscitated, then we saw a scenario like this. We are seeing a cardiac function like this. I wouldn't know if anybody wants to interact here and say what's going on in the heart. This is after giving a bolus, a 2D echo was done. Anybody can comment on what's happening in the heart? About the eyeballing of the function. The cardiac activity is good. Yeah, but there is RV dilatation. Can that be recognized? Yeah, and there is paradoxical movement of the interventricular septum. This is a situation where there is severe hypoxia causing pulmonary vasoconstriction. Severe pulmonary vasoconstriction can challenge the heart like this, causing acute right ventricular strain. But in the background, you can see a good contracting heart. We saw the IVC, which is pulsatile and normal, which is suggesting it has room for fluids. And we saw the lung, it is good air lines. So it prompted us to proceed with the intervention of IV fluids. What happened next? No, let's hold because of the RV strain. What happened next over here? As we proceeded, there you can see severe left ventricular dysfunction. There is apical ballooning. This is something that happens when there is hypoperfusion of the heart. This can be secondary to the massive hypoperfusion. The heart hypoperfusion in itself is leading to, we already saw a very good heart. We had a very good contractility, but what we saw after initiating some measures was a hypocontractile ballooning of the apex. And the IVC is telling the same story. It is still fluid responsiveness and it is still dry. What this means is, despite the cardiac function, the situation requires IV fluids. This is what is a complicated scenario which can be assessed only with advanced hemodynamics. So what happened next? We continued with the fluids and we saw a scenario where the B line started evolving. Yes. Whereas but the cardiac ballooning is seemingly getting rectified. Although IVC dilated, B lines are coming up, the cardiac function is kind of falling in place. What was myocardial ischemia, which caused the apical ballooning, salvaging it with a little bit of fluids made the situation go better. We can titrate the fluids henceforth. What I'm trying to make a point is we have demonized fluids. Fluids can be very harmful. But in situations where we can assess, we have tools to assess when the fluids can be given and needs to be given, can alter the situation, and it is not a one-off thing. You will have to keep hemodynamically monitoring to titrate the interventions. That brings me to the take home. Incorporating focus is of paramount importance and it will cover unmet needs regarding the management of sepsis. Initial intervention management of septic shock is aligned with surviving sepsis guidelines, catering to the nuances. You can save, hold it when there is fluid accumulation or overload signs, which can't be imagined very easily by clinical signs. And these, if you want to go on tandem with these instructions, you would need some assistance, and that's where bedside ultrasound can help. Advanced focus monitoring, of course, can help with more nuances. That is not the topic of today's discussion. That brings me to the end, although there are only 4 or 5 faces lingering here. Thank you for all those who stayed back. Yeah, that's our moderator. Yeah, we have an interesting question. Yeah.
Yeah. So for the assessment of the fluid status, we use dynamic
Fluid responsiveness. Correct.
Yeah. Yeah, and also other than that, we use pulse pressure variability and systolic blood pressure.
Yeah, if you have invasive arterial
Yes,
monitoring.
yeah.
So I was trying to touch the discussion in the non-invasive forum,
Yes.
which is as good as the invasive arterial monitoring is the point I was trying to make. Yeah.
The dynamic
Indices, the PLR and fluid responsiveness, I was trying to parallel it with the PPV you're talking about. Yes.
the dynamic measures for the fluid assessment, like passenger gradient, this is very important now.
Especially in spontaneous breathing. Yeah.
And the other one, the others are like checking the IVC collapsibility, spontaneous elimination.
Correct.
IVC distinctively less.
In the mechanically ventilated. Yeah.
So other than that, we go for the pulse pressure variability and systolic blood pressure.
Arterial waveform.
We and definitely check for the cardiac, like check for the cardiac function, relation pattern. We calculate the cardiac output based on the median. And we also do the lung ultrasound. We use it as the diagnostic as well as therapeutic. And we use focus for the lines of it.
Yeah, that's where it all began. Yeah.
Without the other one, we're not supposed to put lines.
Exactly.
Yeah.
That's the medical legal standpoint now. Yes. Thank you for reiterating these points. I would like to hear from Dr. Basuraj about his comments on utilization of focus.
Basically very important, especially it is very going to be very useful in the use of limited settings also.
Exactly. Thank you, Doctor.
These things which really going to be very useful. What we use in our ICU is basically we look at an IVC, collapsibility and this one. And apart from that, we look at the NM, lungs, A-line, B-line. These are very simple things.
Exactly.
And the third thing, we look at the cardiac contractility and all. And we link it vasoactive scores, whatever it is there in our this one. Those things will take into the consideration. Our inotropes and all is based on these things. And as Rohini said, these are some of the things we really use. And it's a very useful tool in the clinical practice.
It has become second nature in
It's
ICU.
almost like
Yeah.
an ultrasound.
Exactly.
Ultrasound. We need not to look at it in a cardiologist or we need not to look at it in a sonologist. We have to use it. That's where.
That's where it belongs, the focus, right? Thank you, doctor. Any other? Confirm the presence of intubation? Yes. Yeah.
Yeah.
Yeah. ONSD, yeah.
Actually, we can use focus for any branch of medicine, etc.
It's in psychiatry, maybe. Yeah. Okay.
Thank you.
Thank you all.
Thank you.
Out of, she's passing the mic. Okay, I think we already concluded the session before the conclusion. And as a passing out of thanks, Dr. Mohammed Salman, would you like to have a word on the stage? Yeah, thank you all. It was.
It's actually thanking each other.
Thank you.
Yeah.
Yeah, this is just collaboration. It's not a job of any one single person. It's always a collaboration with all of us. I know you are traveling from India to different countries, and thanks to come to Bahrain and sharing your knowledge with us. It's just starting for a long-term collaboration, I'm sure. And I hope see you again in Bahrain.
Thank you. Thank you. We also learned, I'm a mortal neonatologist. I learned a lot from extensive talk. Extensive talk.
I can see between the lines what you